I can't help myself. Good morning. Welcome to day 2 of the second meeting of the International Alliance on Brain Health. I'm Steve Lewis. I'm the president of the World Federation of Neurology, and it is my absolute honor and privilege to be here today to welcome you to a very exciting day 2 and lots of important things to talk about. We begin with session 1 of day 2, entitled One Brain, One Health, Integration of Neurological and Psychiatric Approaches in Global and Regional Plans. This panel will explore the convergence between neurology and psychiatry within the framework of global health policies. To open the discussion, we welcome Professor Claudio Bassetti, representative of the Lancet Commission on Brain Health and the Swiss Brain Health Foundation. He will present the latest developments regarding the Swiss Brain Health Foundation. This is a very important example of the integration of neurology and psychiatry in mental health. Please welcome Claudio Bassetti, who will present to us today. Thank you, Claudio.
So good morning. I'm thrilled to experience with you the second day of the second international meeting on brain health. I'm sorry to disappoint you. I was planning to present an update on the Lancet Commission. Unfortunately, the preparation are not yet finalized, so I'm not allowed to discuss and present the update, but I can assure you that in May, June, this will be ready. I mean, we have a formal step to go through with the Lancet Commission, and we anticipate to be ready to start officially in June, at the latest in July. So, and we will have the kickoff in Geneva, and Ingrid Beek and the local organizers will help us to organize this event, and we plan to have the kickoff in January and February. So we'll make sure that you will be invited and you will be informed. And this is all I can say today, but I'm ready during the coffee break to maybe say a little bit more about the Lancet Commission. So I actually switched to something that I've been devoting a lot of my energy in the last few years, the Swiss Brain Health Plan, which is one way to implement brain health plans at local level. We discussed yesterday the importance understanding the local frame and the local needs when you talk about implementing brain health. And I will show you what we do in Switzerland. It is obvious that implementing a brain health plan in Switzerland is different than if you do it in India, in Ghana, or in New Zealand. So now our way has been to develop a frame which we call the plan, and now we are in the implementation phase, and this is why we are planning, and I will show at the end of my presentation the plans for the creation of a Swiss Center of Competence for Brain Health. Now, I like to stress our slogan because, as it was said by Professor Steve Lewis, from the beginning, and this is going to be also the case for the Lancet Commission, our mission is really to create bridges between the different disciplines. And this is why we have this slogan, brain health and mental well-being, our common human capital. So we want to work on these different fields together and join forces. Now I'm happy to say that I'm not doing this by myself. This would be an impossible task. And this is the board of the Swiss Brain Health Plan and of the implementation of the Swiss Brain Health Plan. And I'm really proud and happy that Christina Adorian, Ingrid Beek, and Alexander Data are here in Buenos Aires with me. It's just proving the fact that we are committed to the Swiss Brain Health Plan and to all that is linked to this. I would like to mention that we are very happy to have Professor Thomas Zeltner and others with us. Thomas Zeltner used to be the president of the public health organization in Switzerland, and he's the president of the Red Cross. So he's a very influential person, and he's the person also who founded the WHO Foundation. So he is really our, I would say, mentor in this endeavor. Now, the Swiss Brain Health Plan was not created because there was a political mandate, but it was created as a bottom-up initiative. I came actually with the experience of the European Academy of Neurology. I was, at the beginning of this decade, the president, and I was asked to actually create, or I decided to create a European Brain Health Plan. And when I stepped down from the presidency of the European Academy, I actually thought, well, it would be nice to do something in Switzerland. And to launch this, it was important to create a momentum, and this led to this incredible publication with over 50 authors. So you can imagine how complex this may be, and we have neurologists, we have psychiatrists, we have neuroscientists, we have general practitioners, we have psychologists, we have public health specialists, we have a couple Nobel awardees, etc. So this was really an incredible momentum, and actually the publication is available and actually set the frame for the next 50 years. Now, the challenge is really how you move from such a plan to concrete implementations, and I will show you what we are doing. Now, we have published subsequent papers, and I like to show these very nice figures of the more recent paper on one brain, one mind, one health, one planet, and I'm happy to say that Indrid was chairing this initiative, and please read this for details. So what are the strategic priorities that we identified for the Swiss Brain Health Plan? They are not very original. If you look at around the world about brain plans, they are similarly done, so it's not really the strategic priorities that define the plan, it's really their implementation, but still, these are our 5 strategic priorities. One is the awareness, to talk about the burden of brain disorders, but also the positive message, we have something we have to protect and foster brain health. Then we have a problem of workforce, even in Switzerland, not only in the world, not only in Africa. So we need to think about educating and forming new workforces that will work on prevention, promoting health. So we have created some initiatives around interprofessional training. I will say something more about this. It is obvious that we need more research. I mean, we need to have a mechanistic approach to brain disorders, and we have to implement what we know, but we need to know more about the mechanism of brain disorders. I mean, we have the examples of stroke, we have the examples of depression, we have the example of dementia, but there are many, many other brain disorders where we do not have any clue about the true targets that we should actually use to be effective in treating and preventing these disorders. So this is a cartoon that we have developed over the years, and we show the complexity of the topic of brain health. So it is obvious that this is something that is quite challenging. Then we have to talk about prevention, and in Switzerland, only 2% of the entire budget goes for prevention, so we have a problem in doing prevention and promoting prevention. We are lucky because the health minister of Switzerland has identified prevention as one of her targets, but she has to battle in a difficult field of interest. And finally, last but not least, empowering patients and caregivers. So these are the strategic pillars. So very often I'm asked, but what is really different? What is special about the Swiss plan? And I would say what is particularly challenging, and this is the fact that from the beginning, we wanted to foster the cross-disciplinary approach. It's easy to say, it's difficult to be realized. How do you work together with neurologists, psychiatrists, pediatricians, psychologists, GPs? So this has been probably the most difficult part of doing this and starting this. Second, how you foster interprofessionality. You cannot talk about brain health and promoting brain health without involving those that are in the field and working with patients and with families and with and those that are still healthy but may be at risk. And finally, how you engage patient families and organization. So we actually had 2 major, I think, decisions that we took from the beginning. One is to work with this SFCNS. This is a federation of neurosocieties that I created 15 years ago with a few friends. And this federation actually put together 14 national societies, neurology, neurosurgery, psychiatry, etc., to have a single voice when we speak with the political stakeholders in Switzerland. So this was actually a very important step, and finally the brain health is linked to the support of the SFCNS. But it's not only about neuroscience, so this is why we have more than 14 societies now joining the brain health mission. The second one is that we need some funding, because all these societies are good, but they don't have any funding. So we had to create our own foundation to support what we do. And this is the Swiss Brain Health Foundation, which was created just a few months ago. Now, this is a list of the stakeholders that are now supporting and engaged in the Swiss Brain Health Plan, and I'm happy to say that we have professional societies, we have the Federal Office of Public Health, we have universities, we have patients' organizations, and I'm proud to say that we have linked, and we have links with international initiatives, the European Sleep Foundation, the World Psychiatric Association, the European Academy, etc., etc. You know, to have all these contacts, you have to talk with people, you have to meet them, so it's a huge work, actually, so to put together all these contacts. Now, one thing that is fundamental in our approach is that we don't want to have a center that does everything, because it's impossible in Switzerland. I mean, we are a very democratic country, and everybody thinks they are the best. So we need to actually maximize the local initiatives, the local expertise. So our approach is really to create a network of regional hubs. So we have Geneva, we have Lausanne, we have the University Center, Basel, Zurich, and Lugano, and we have even local, smaller initiatives. Now, I will not go into the details, but each of these centers have been developing some initiatives around the major strategic pillars: awareness, education, research, prevention, and empowering patients. Some of them are more keen to work on the topic of aging or dementia, other on the topic of sleep, other are more involved in pediatric and, and early life development across the brain health. Geneva has a strong interest in stimulation technology, etc., etc. So we have right now over 20 professional societies, 20 organizations, including the Sleep Society, which it's very close to my heart, 6 universities, 2 University of Applied Sciences. And I like to mention my own reality, and Christina and I are coordinating this work. In Bern, we have the Bern. So that's a local initiative, which is the Brain Engagement and Research Network for promoting brain health. So I think we will be successful as much as we can empower the local and the energy that comes from all these excellent centers. And in Bern, we have 12 groups that are now working on brain health, and we have the support of our university. So let me give you some example of what we do concretely. So what we do for awareness, to the strategic pillar number 1, we have been organizing local but also national events, and I will not go through them, but Diego and Alexander know that we have a focus also on sleep. We had the Brain Health and Sleep Initiative, a worldwide, that gave rise then to an interesting initiative. And we have been very active internationally, and Paul and I have been a couple times at the European Parliament. That's a quite amazing experience to dealing with these different interests and politicians, but I think it was successful, Paul, and we'll continue with this international activities, and I'm always proud and happy to present our Swiss experience. Second is interprofessional training. I'm very proud to say that University of Bern, through an international faculty, has launched this, I believe, quite unique initiative of this International Certificate of Advanced Studies in Brain Health. We have the second cycle, so we have trained already over 70 students internationally. It's a virtual course, is in English, and it's actually accessible for everybody, and as you see, we have plenty of countries. So I'd love to think that after this meeting, maybe we will have also some candidates from South America. Please contact us. We do have, for less advantaged countries, also the possibility to support the attendance of this course, which give a university certificate. And the topics that we cover are brain health and determinants, interventions, disorders, and action plans. And what I like to stress is that it is open not only for MDs, but also for psychologists, sport specialists, nurses, physical, occupational, and speech therapists, healthcare, and and other people. So it's really a cross-disciplinary university course which is open to everybody, and this is about education. Now, the third pillar is research, and we have done two major efforts. The first one was together with the European Academy of Neurology, and this was this work that has been just published, received an incredible attention about the epidemiology and economic burden of sleep disorders. Now, I will not go into the details, please read the paper. The final conclusion was that the frequency of chronic, not acute insomnia, which is 100%, as you all know, or shift-related sleep problems. We all experience this when we travel. But chronic sleep disorders affect 30%, and I should say circadian, Diego. So sleep and circadian disorders affect 30% of the population. And if you look at the projected cost, this is a complicated algorithm. These are not effective, but it's projected cost according to prevalence and the usual approaches that the IHME uses to calculate the cost. 3% of the GDPs can be attributed to sleep and circadian disorders. An incredible burden, and I'm very sad because the IHME has actually abandoned sleep disorders from their approach, and we are working to try to reintroduce sleep disorders and the metrics to measure disability in their approaches. The second work will be presented later by Ingrid. This is a very important piece of work because, you know, politicians believe or are interested in figures or votes, and typically both. So we need to actually show the burden of brain disorders and the weight of the brain disorders. And the brain disorders are the #1 cause of costs in Switzerland. So this is not only European, it's not only American data, this is Swiss data. And we actually have shown, and Ingrid will show, there is a disbalance between the burden and the budget spending, and we need to solve this. And we have some ideas of how to do this. So please stay alert to the presentation of Ingrid. This is a work that we have done with the IHME and with the Swiss Brain Health Foundation. Now, we are happy because we have been asked in the last month to provide recommendation from the two institutions in Switzerland that are involved with prevention. One is the Federal Office of Public Health, and actually the recommendation are to the foundation that supports the work of the Federal Office, which is called Promotion Santé Suisse. And what they asked us to do, and this was particularly tedious as work, is to map what is already existing. So the Federal Office of Public Health does not want to have a brain plan that comes into the space and, and wants to attract all the resources and push out what is already been done. So this has been a tremendous work. And eventually, here is the conclusion. So if you talk about brain health, you have to realize that you have to have different targets that you may want to address, physiological needs, protective factors, new factors such as commercial determinants, climate changes, new technologies, and then the original risk factors. So when mapping what is already ongoing in Switzerland, we came up with these 5 recommendations, and we are now in actually detailing what we should do. One is promotion of restorative sleep. This is an obvious blind spot, I would say, in Switzerland and probably international. The second one is stimulating cognitive emotional functions and promoting mental resilience. So it's not about prevention, it's actually promoting brain health per se, which is a value in itself. Balanced use of digital technology, and then preventing traumatic brain injury, which is actually neglected in Switzerland. We have a neurosurgeon who is the president of CSF-CNS, who has a special interest in this field. I cannot go into the activities around the involvement of patient and relatives. We have testimonials, we have videos. We are creating Federation of Patient Organization in Switzerland devoted to brain disorders. You know, the patient organizations are not better than professional organizations. They're better with each other. So we try to bring them to speak with one voice when talking with the stakeholders. We have famous people, such as this world champion of skiing, who actually suffered a tremendous brain injury. We have the video, I will not show it. And he actually was rehabilitated and is one of our best testimonial. We have an unknown patient with depression who is very illustrative and very convincing. And then we have this wife of the Chancellor of the University of Bern who actually developed dementia. And she actually took care of his husband, and she herself then finished in the hospital and so on. So although she's a very brilliant person and is a very intelligent person, but she could not help herself, so she actually wants now to teach and discuss with others, you know, about her experience. So we are now in the process of creating, according to the what I've said before, the Center of Competence for Brain Health. We will have 4 main topics. I will not go into details, and the idea is really shown here. So we want to have a hub, and we will have a cockpit somewhere in Switzerland, and we want to promote a holistic approach, a public-private approach, and a non-profit approach. Now, the Swiss Brain Health Foundation allows us now to have this operational team that is working, and we are developing now along these 4 main pillars, and according to the strategic pillars, different activities. We are creating an AI-assisted brain health check platform. We have a working group that is looking at brain capital data sets. We want to validate an approach and not just speak about slogans. So we want really to have a science-based approach to the topic of brain capital and other initiatives. So this is our journey. It started in 2022, and we are now, this year, we will create the competence center. We are organizing meeting in Switzerland. We are active internationally. This is why we have the picture of the international meeting here in Buenos Aires. And our goal is really to then influence the federal health strategy, which is currently being created and will start in 2030. And I would really like to have your help, your support, your advice, because alone we will go nowhere. So thank you for your attention.
Thank you, Professor Bassetti, for that really important update on the Swiss Brain Health Plan. Continuing with our agenda, we are honored to present a recorded lecture by Andrea Fiorillo, who serves as a full professor of psychiatry at the University of Campania in Italy. In addition to his academic role, he holds several high-level leadership positions, most notably as a president of the European Psychiatric Association. He further demonstrates his commitment to the field as the president of the Italian Society of Social Psychiatry and the president of the College of Italian University Professors of Psychiatry. Beyond his institutional leadership, Professor Fiorillo was a prolific contributor to psychiatric literature, serving as the editor-in-chief of European Psychiatry. His presentation will address mental health systems within one brain, one health.
I'm particularly thankful to the organizers of this second meeting of the International Alliance on Brain Health. In this short presentation, I will bring to you the initiatives of the European Psychiatric Association regarding the issue of mental health systems, but also the issue of the brain, how the brain matters for mental health professionals. In the recent years, we are looking at increased prevalence of basically all mental disorders. If we see the slides from 1990 to 2023, we can witness a significant increase in the prevalence of basically all mental disorders. According to this figure, we decided at the European Psychiatric Association to highlight what is the mental health status of the European population and also of its determinants. Also because we have seen between the prior of the COVID pandemic and after that period an increase of people suffering from mental disorder, so that now we have almost 1 out of 2 European being affected by mental disorders. This is why we wanted to highlight what can be considered the KPIs, the determinants of mental health, but also the mental health status of the population and the responsiveness both from the health system and also from the social welfare. These are the key performance indicators. So we have addressed all these issues. I will show you very briefly some of them, and we know that the determinants of mental health may act at different levels, the individual, the environmental, and the socioeconomic ones. But then what we look at is the prevalence, the incidence, the disability, but also the suicide rate and the mortality for people with mental disorders. What we can see that most of the countries, if we make a comparison between 2021 and 2025, we can see a drop in the responsiveness of the healthcare systems and also of the social system to mental health needs of the general population. And we can see that in most European countries, this drop has been particularly high. Thus, only very few countries can be considered at high level of responsiveness according to the population mental health needs, while most of the European countries are below the threshold of what can be done and shall be done. So we are trying to address the priorities for mental health promotion in 2 main fields: to increase the investment and to move towards a community-based approach. This means, of course, not only increasing human resources and staff, but also infrastructure, also working on prevention, on integration of knowledge and service, and also to move the treatments for mental disorder outside the general hospital, the mental health facilities, to other places such as schools or workplace. On this trend, we have prepared this roadmap that you can read the editorial on the priorities of the European Psychiatric Association. According to this, if you scan this QR code, you will see the full paper, which has been published last year in European Psychiatry. We've been 3 times at the European Parliament to discuss these issues, the priorities. Our manifesto for Europe has been also endorsed by the Association of Family Members, EUFAMI, and of Gamian Europe, that is the associations of users and patients affected by mental disorders. These are the 5 mental health priorities, and according to this, more recently, in December 2025, we have again been invited at the European Parliament to discuss about a new roadmap in brain health according to three main issues: care, cohesion, and growth. So how we can advance mental health also according to the well-being economy. And actually, we have highlighted the three main issues: the need for innovation. Innovation is not only new treatments, but also in the way we deliver current treatments, integration of knowledge, and in this area, brain and mental health should be complemented each other, and also to improve the care for people suffering from mental disorders. These are the 6 key areas on which we are now working. One is, of course, innovation and treatment delivery. Another one is precision psychiatry. A third area is brain and mental health across the lifespan. A fourth area is whole person health, meaning not only mental health, but also physical health, and looking at the patient as a person and not in silos. A fifth area is a public mental health, meaning moving towards a preventive approach and promotion of resilience. And the sixth group is the protection of vulnerable groups, including those who are more fragile, let's say, in a way, and this includes children, elderly, but also migrants, and also people belonging to minority ethnicity. Of course, all these plans should have a long-term plan. So this means that every year we see if this increases the knowledge from mental health professionals, from the general population, if we are ready to increase the advocacy level, but also these approaches should be sustainable along the years. I will briefly discuss with you today just the innovation and the brain health, because the topic of this meeting is particularly devoted to these aspects. So we started this task force by this viewpoint, which assessed the value of mental health treatments in Europe according to recipients of mental health care, so patients and carers. And we can see that innovation, there is no innovation in mental health, in psychiatric care. Treatment advances for mental health disorders like depression have been painfully slow if we compare with other disease areas. This is HIV, but if we look at cancer or other diseases, of course, we don't have as much as the others, despite the fact that mental disorders are increasing. We also need to design new psychiatric facilities in order to increase positive social interactions and to reduce loneliness and feelings of stigma belonging to people who are admitted to psychiatric hospitals or facilities. There is also the important need, the important growing field of digital psychiatry. There are lots of new technologies that can be used, actually are used in some continents, in some countries for mental health, but despite this, in our Europe, they are not really available. These are mainly due to lack of legislative regulation, but also of lack of financing. But nevertheless, this is an area on which we are working on. And the other important area for us is brain health. This means looking at genetic, biological, and psychosocial determinants of brain development. Exactly as for the cardiologist, the organ of interest is the heart. For psychiatrists and neurologists, the organ of interest is the brain. And if we look at the brain from different perspectives, I mean the mental health professionals and neurologists, Nowadays, we should try to have a view, a comprehensive view, looking at genetics or lifestyle choices or social and cognitive and affective impairments from one end, and from the other, the social determinants that we have seen before, the shared physio-psychopathological mechanisms, and also the neurocognitive models. This is a very nice paper that is now in press in European Psychiatry, One Brain, One Mind. I like very much the incipit of this paper. The human brain does not recognize the boundaries we have constructed between neurology and psychiatry. But despite these boundaries continue to organize much of our clinical practice, research, design, and training. So this is something that now it is time that to try to ensure that the respective strengths contribute to a coherent and comprehensive approach to brain health. Also because schizophrenia and multiple sclerosis, just to give you a few examples, now we know that they share lots of characteristics, for example, age at onset or sex differences, in some cases some environmental risk factors, but also the involvement of the immune inflammatory processes or the association with the specific loci. So this means that in the diagnosis, maybe mental health professionals should move toward a more biological pathway. Of course, both of us recognize the symptomatic manifestation as the first symptom, but then we need to do some more. This is the European coordination plan for the brain, which involves as endorsements the most important association in the field of brain health in Europe, the European Academy of Neurology, the European Psychiatric Association, but also the ECMP or FENS or Vibro, or we can name all of them. But basically now we need a collaborative platform for research, for governance, for organization of healthcare systems, for the socioeconomic impact and brain capital, but also for asking for more investment and innovation. This is something that at EPA, under my presidency, we are working very hard. Just to give you an example, these are two meetings that we are organizing this year. This is the Psychiatry in Action meeting. It's a first regional meeting which will take place in Italy, in Naples, at the end of October this year. And that is the European Congress of Psychiatry, the 35th European Congress of Psychiatry, that again will take place in Italy, to Florence, next April. And the motto here is innovating mental health towards personalized and integrated care, meaning that we need to personalize our approach, but only according to an integration model, which includes, of course, the importance of brain and mental health. This is my very last slides, and this is my message that we took from the forum this year. We design systems around specialties, but patients experience one life. So the challenge is that our systems are still built in silos. Mental, neurological, and physical health are treated separately, fragmented care pathways, and limited accountability across disciplines. If we are serious about closing this gap, 3 shifts are needed, trained differently, so we should equip clinicians to think and act beyond disciplines, to organize care differently, make integrated pathways the default, and align systems and incentives. Collaboration now is not optional. Because I think, and this is my very last message, integration is not innovation. It is already overdue. Thank you very much for your attention, and I'm really sorry that I'm not there with you.
Thank you to Dr. Fiorello for a very informative talk. Next, joining us from Belgium we are privileged to have Professor Paul Boone, a leading figure in international neurology who serves as the chairman and senior full professor of neurology at Ghent University Hospital. In addition to his clinical leadership, he is the director of the Brain Research Group at Ghent University. Furthermore, Professor Boone holds significant international leadership roles, notably as the past president of the European Academy of Neurology, an organization committed to fostering excellence in neurological care, research, and education throughout Europe. Building on this vast experience, Professor Boone will now share his insights regarding European neurology and integrated brain health policy. Please give a warm welcome to Paul Boone.
So there we go. Well, thank you very much, Mr. Chairman, Professor Lewis. Thank you for the nice introduction. Ladies and gentlemen, dear colleagues and friends. First of all, I would like to thank the organizers, Dr. Manes, Professor Bassetti, and the local crew for organizing me, and I would also like to congratulate you with an impeccably organized Congress. I mean, this is really, really nice in one of the most beautiful cities of South America. So I was glad to be back in Buenos Aires. I have known the city quite well for a while. That being said, I'm here to, first of all, transfer the greetings and the salutes of the European neurological community to you as an Argentinian audience and a South American audience. And I would like to do so by first maybe informing you about how we are organized on a neurological level in Europe. The European Academy of Neurology, we like to call it our child, our home of neurology. The feel is very important. When people come to our meetings, when they are in our organization, they should feel at home. We basically represent 45,000 neurologists serving about 900 million people in the European space, Europe being defined not only as the European Union, but as the WHO definition of Europe. We have 48 member countries in Europe and 13 countries outside Europe. This comes with the slogan that EAN is a European organization with global ambitions. We have, through our national neurological societies, direct contacts with authorities in these different countries, and we cooperate on an institutional level with all relevant European bodies and WHO. I will try to avoid repetition, but basically the message is that important that maybe it would not, well, we could all benefit from some repetition. First of all, according to the same data set that has been called by different speakers, among them Professor Rost from the American Academy of Neurology, 43% of European citizens are affected by neurological conditions. It's the leading cause of DALYs, main contributor to DALYs, a major cause of mortality. And I would like immediately to dive into the gap. Only 10% of all European funding in terms of health is spent on neurological disorders, including neurological research. Now, we have hammered on the nail for years. As a result, the European Union has decided just recently this year, and this is a 10-year program, to spend an extra €500 million on neurological research alone. But the total expenditure of European research is 65 billion euros. So, I mean, it's still a gap, but I mean, we're happy with the results that we have achieved for now. What about the cost? Well, this is very, very new data. It's not even published yet. But based on the IHME data rather, and local calculations and extrapolations in different European countries, we have calculated the bill of neurological disorders in the European space. And you see the pie, basically the colors representing the different diseases, the total bill, 1.7 trillion euros yearly. So what is our message to the politicians? Our message to the politicians is that by any action you could diminish this bill by 1%. That 1% represents the healthcare expenditure of one European country. So I mean, even minor advances would make a huge difference. Now, which brings me to how did we organize on a European level brain health in the way that we all desire? Well, and what is that way? Well, to be collaborative, to be multidisciplinary, to work across sectors, and to be as most inclusive as possible. Well, this initiative is called the Brain Health Mission, and the Brain Health Mission basically strives at improving and promoting brain health according to the definition of WHO, and I'm fully aware of that, and I saw that in different presentations yesterday. What is the definition of brain health? Well, I honestly believe it's not going to lead us any further to keep working on that. Let's use the operational definition that we all know, basically a state in which every individual can realize their own abilities, optimize cognitive, emotional, psychological, and behavioral function to basically live their life and cope with life situations. Life is not only positive, life can be very negative. Well, people have to be able, have the faculty to enjoy life, at the same time cope with anything that happens in their lifetime. And brain health clearly is throughout lifespan. Brain health starts actually in the womb of the mother, right? It's not at the end of the life. It is not limited to dementia. It is not limited to cognitive dysfunction. It's a much wider concept. Now, this slide does the impossible, trying to summarize what we know about brain health and all the limitations as well. First of all, there's known determinants of brain health, and Professor Bassetti just eloquently showed also the brain bubble. This is our famous brain bubble. It's like the last version. We kept working on the brain bubble, starting with the original publication of Claudio and myself in the European Journal of Neurology, and we kind of refined it. We know the determinants, and we work on that in some kind of infographical way in 3 levels. What can an individual do? What can the healthcare provider or the care around people do? And what can societies do? And I mean, these are the different levels: plan, protect, and preserve. I will not dwell upon that any further. There's kind of a pitfall there. If I talk to my colleague internal doctors, they say, well, you know, brain health's not a major issue. We know the cardiovascular risk factors, we're done. Just make sure that you try to protect yourself, avoid the cardiovascular risk factors, and we're done. We are not. I mean, really, where the challenge, at the same time the fun starts, is where we are able to determine and to develop brain-specific risk factors, and derives from that mechanistic knowledge biomarkers that are actionable, that are affordable, that are accessible, that obey the laws of equity. And that is basically summarized in one slide, everything that what are the issues, what are the opportunities, what are the limitations. I wanted to stress on one thing. We have heard lots of talk about prevention. Prevention is fine, but let's be honest, while we know that many neurological disorders are preventable to a certain degree, it is maybe not completely realistic to assume that we will be able to prevent all neurological disorders in our lifetime. The word delaying the occurrence of a neurological disease is equally important. If any intervention would allow us to delay the dementia in a patient, the level of dementia, cognitive disorders that affects daily life of a patient, with 10 years, we would already have made a massive step. So apart from prevention and cure, that we know, many of us are doctors, delaying a diagnosis, I believe, is very, very important. And I believe that one of the examples, key examples of how this chain of knowledge leading to better brain health is obviously in Alzheimer's disease, where through developments of molecular imaging, amyloid PET, tau PET, we've been able to also genetically screen the patients, leading to access to disease-modifying treatment, and we have 1 or 2 now, and I believe the market is very shiny for this type of drugs. This will eventually lead to improved outcome, and I will not go into the details whether or not this should be approved and should be reimbursed, because there's many issues. You know that the main problem with disease-modifying drugs is that while the washing out of the amyloid is very high, 85%. The clinical efficacy is rather in the 30% range, which obviously is a problem. But that is not the issue. The issue is that for the first time, we do have, based on mechanistic research, a disease-modifying treatment strategy. I cannot explain or emphasize enough the accessibility, the affordability of innovative treatments. If you want to have this Brain Bubble, the most recent version, it has been translated in 29 languages. So if you want to scan this, you can basically disseminate this through a larger part of the world. What is the Brain Health Mission now more concretely doing? We've been working quite a while on our strategic plans, and you may have seen actually the way we try to do this in a systematic way reflected in other presentations. We are not reinventing the wheel. This is not rocket science, but what we want to do is basically pursuing 3 goals. Elevate the understanding of brain health. And let me put it this way, what is the dream of these 3 goals? The dream is, in elevating the understanding of brain health, that every child in Europe would have a minimal knowledge about brain health, just like every child has a minimal understanding of dental health. In primary school, kids learn how to brush their teeth if they have not learned that at home, which I would assume they should have, but it's being re-emphasized in school. Well, a very similar, it's a metaphor, and any metaphor has a limitation, but the dream is from early age on, people are aware of what their brain does and what brain health means. Second, strengthen public health strategies. And I think we just saw a shining example of how on an individual national level, a brain plan is being developed, and Switzerland paved the way in a wonderful way. In the meantime, 10 European countries have something that is worth quoting as a national brain plan. But we have 27 European member states, and we have 48 nations. So there's still a lot of work to be done. The dream is, within a foreseeable period of time, every European country has a national brain plan, right? Third dream, establish brain health as a societal and economic priority. A lot has been said about brain economy, brain capital. What do we mean? And just very briefly, the idea is that apart from natural resources, and we are in a country, Argentina, has huge natural resources. Some of the smaller European countries have no natural resource. My country had coal and iron ore. They're completely depleted. The only resource we have is the resource of the brain capacity of our citizens. And to a certain degree, even with countries that have lots of oil or other natural resources, the other half of their resources is the brains of the citizens. So this is why brain health is basically exceeding the level of healthcare. It is exceeding the level of people suffering from any kind of disease. It should be considered a national priority because it's the precondition for a healthy economy. How do we do that? Obviously, I'm here as a humble servant of the European Academy of Neurology, as past president and as the co-chair of the Brain Health Mission. But this is the team that basically is steering the Brain Health Mission on a European level. The way we work is that neurologists and psychiatrists are the main drivers. It is the people that take care of people with brain disorders, but we have been involving, in the meantime, 32 strategic partners, basically coming from the clinical world, from the advocacy world, so all the relevant patient organizations are in. Corporate perspective, also very important to have industry on board. What do we do? And you've seen some of the pictures before. we organize brain health summits. The way the European Union is being structured is that the government of the European Union shifts every 6 months. It rotates every 6 months, and one country becomes the president. And that's the legislative, that is the executive body. The legislative body is the European Parliament, right? Highly democratic, directly elected body. We organize 6 monthly, yearly brain health summits. And the idea is basically to influence the policymakers. Who are the people that we want to influence? Well, like in the US, people, the American Academy wants to influence the congressmen and the senators. We want to influence our members of the European Parliament. So we have members of European Parliament interest groups. We have a brain awareness week every year. And we have kind of created the, the insignia of a European brain health capital city. Now, 2 cities have that title in the meantime. Helsinki twice, and Geneva will get it this year at the occasion of our annual Congress. We have basically spanned the entire spectrum of the society. You see the Queen of the Belgians, if you don't know her, obviously a very important person in the Brussels arena, Queen Mathilde. I saw to my delight that Claudio also showed that picture, so that is a picture that you also like, Claudio. I think we had her as the ambassador for brain health last year. We've worked more recently in the European Parliament, and let me show you this. We had the Brain Health Day just 2 weeks ago, where the focus was on founding a brain healthy society and an economy. So we talked a lot about brain capital, about resilience, about economic aspects of brain health. And the key person of that event was the President of the European Parliament. We went with the entire team, and you see the leadership group there, to meet the President of the European Parliament, really in the heart of European democracy in Brussels. And basically what we did is that we had this person basically reiterating the political points that we wanted to put on the agenda. So I would say, first part of the mission completed, right? This is the first part. This is, for us, extremely important. You see Elena Moro, the current president of the European Academy of Neurology, in the company of Roberta Metsola, who is the president of the European Parliament. The other side of the spectrum, I'm nearly done. The other side of the spectrum is that, think about the dental health. We have developed a brain health school challenge. This is directed to pupils of primary schools or junior students in secondary schools, basically empowering them to make a challenge where they develop ideas and strategies, campaigns to inspire their peers to prioritize brain health. So it's basically a competition on knowledge on the brain. Primary school level to secondary school level. It started in Vienna, which is not a coincidence because this is the basis where the headquarters of EAN is. But in the meantime, we've rolled out this project in many cities in Austria, Finland, Greece, Montenegro, Germany, Switzerland, and Belgium. More that we have said, I'm done, yes. Postgraduate programs on brain health, you heard about Bern. In the meantime, Ghent University, Cambridge University have a postgraduate program for brain health, very successful programs. We have to basically say stop to patients. There are too many applicants, which does not mean that international candidates are not welcome. And we've also established a network of academic chairs, so junior professorships, basically dealing with brain health at different universities in different countries. And you see a couple of pictures showing that. The Ambassador for Neurology and Brain Health program that is chaired by Mathilde Leonardi, who is present here, very successful program, basically that shows, what is the dream there? I like to talk about dreams. Every neurologist trained now should become an ambassador for brain health, and the existing neurologists should be trained, if they are not yet ambassadors, they should become ambassadors for brain health. And this is a program specifically aimed at learning the basics of advocacy to our colleagues. If you like to know how our call to action and how we managed to develop a roadmap towards promoting and improving brain health, please scan the QR code. This is the recently published paper by the European Academy of Neurology, which basically defines the entire strategy. How do you do this, and what are the key factors? If this could be helpful for any of you, please get in touch with us, and we will be very happy to help you out. I would like to end here by thanking again the audience, by saying again that I'm incredibly impressed by the organization here, by the level of commitment and engagement. I would like to thank again the two co-organizers who are basically doing pioneering work. And just like my psychiatric colleague, I would like to invite you to our next Congress, the EAN Congress in Geneva. Last edition was Finland, 8,000 people. This is a wonderful, high-level Congress with a wonderful feel of the home of neurology. Thank you very much.
Thank you, Paul. That was really, really great. To conclude the presentations from the first session, we will listen to the virtual contribution from Dr. Andrea Winkler. Dr. Winkler is a neuroscientist, specialist neurologist, senior researcher, the co-director of the Center for Global Health of the Technical University of Munich, and the founding director of the Center for Global Health at the University of Oslo, where she holds a professorship in Global One Health. Her lecture is entitled The Lancet One Health Commission, Harnessing Our Interconnectedness for Equitable, Sustainable, and Healthy Socio-Ecological Systems. We will now proceed with her presentation.
Good morning, and thank you so much for having me. My name is Andrea Winkler, and I'm a neurologist and a professor for Global One Health, working out of the Technical University of Munich, Germany. I'm also the co-chair of the Lancet One Health Commission, and together with Claudio Bassetti, the co-chair of the Lancet Global Brain Health Commission, which is currently under construction. It is my hope that we can apply findings and lessons learned from the One Health Commission to the Brain Health Commission. This slide shows the Lancet One Health Commission with the two co-chairs, Professor John Amoasi from KNUST Ghana and myself, and our commissioners and advisors from around the globe representing different disciplines and sectors. One Health is actually an old concept, and so far was very much concerned with the human-animal interface, mainly in the context of spillover of zoonotic diseases. The Lancet One Health Commission is expanding on this concept, now including the environment and expanding holistically to different kinds of collaborations, also in the context of non-communicable diseases and brain health, which also includes mental health. Hence, the vision of the Lancet One Health Commission is healthy socio-ecological systems achieved and sustained through an equity-oriented, transdisciplinary and multi-sectoral One Health approach to advancing health amongst humans, other animals, plants, other biotic and abiotic elements, and the environment at large, including soil, water, and air. The report of the Lancet One Health Commission, which was published last July and can be found online, synthesizes the current state of knowledge on One Health and appraises its added value for addressing global health and sustainability challenges. It offers a systems-based understanding of health interdependencies among humans, other animals, plants, and the environment. And it is also a roadmap that proposes concrete avenues for operationalizing, implementing, and institutionalizing One Health across sectors. Now, this is one of the core pieces of the Lancet One Health Commission, the One Health map. It portrays different settings from forests and savannas to mountains and from oceans to cities, amongst others. It also shows the different threats that can be encountered from infectious diseases, antimicrobial resistance, non-communicable diseases, climate change, biodiversity loss, and much more, portrayed by the small icons that you can see. What this map also shows clearly is that health is shaped by dynamic interactions between natural ecosystems and human social, cultural, political, and economic systems, that socio-ecological systems are complex but adaptive and interdependent. Changes in one part of the system affect the whole, that climate change, biodiversity loss, and pollution are interlinked and have cascading effects across species and geographies, and that One Health brings holistic and systems thinking to understanding these relationships. In the interest of time, I have summarized the key messages in the next slides without going too much into details. One Health is a collaborative, interdisciplinary, and multi-sectoral approach that addresses global health and sustainability challenges. It is rooted in the understanding of the health of humans, animals, plants, and the environment that are deeply connected. Socio-ecological interconnection is central to One Health. Climate change, biodiversity loss, pollution, etc. threatens this balance, which impacts felt unequally across populations. One Health considers these risks and calls for urgent actions through climate mitigation, conservation, and ecological restoration. And One Health expands the scope of surveillance beyond disease detection to include the broader determinants of health. This approach supports resilient ecosystems and promotes environments that sustain health and well-being. One Health is vital for transforming food systems. It helps addressing complex challenges like food safety, security, equity, while also promoting the health of people, animals, plants, and ecosystems in a connected and sustainable way. One Health also plays an important role in shaping global health and sustainability futures. It calls for systemic changes in governance, economic models, and knowledge systems, prioritizing equity, inclusion, and collaboration to achieve lasting socio-ecological health. And guided by principles such as holism, equity, and sustainability, One Health provides a comprehensive framework for tackling both infectious and non-communicable diseases, antimicrobial resistance, and other systemic threats. It promotes integrated, fair, and context-sensitive responses across all levels. We suggest implementing those key messages through reforms in governance, policy, economics, finance, and education, summarized in 10 key recommendations. Now, each one of these recommendations is detailed in great depth in the appendix of the Lancet One Health Commission pertaining to who, what, how, and when. This is something that I could also envision for the Lancet Global Brain Health Commission. And here are the 10 recommendations. First, institutionalize One Health within global, regional, and national governance architecture. 2, achieve coherent One Health policy and governance through One Health in all policy. 3, integrate human, animal, and environmental health and surveillance systems. 4, achieve a transformation of global economics that prioritizes equity, sustainability, and well-being as key measures of progress. 5, operationalize, implement, and institutionalize adequate, innovative, transparent, and equitable financing for One Health. 6. Harness the full potential of the private sector to contribute to and promote equitable, sustainable and healthy socio-ecological systems. 7. Mainstream One Health throughout the higher education sector as the overarching framework for the education and training of a new cadre of professionals to drive and sustain systemic transformations. Cultivate enabling conditions for One Health research and knowledge production. This is recommendation number 8. 9. Achieve a One Health literate global citizenry. 10. Achieve a One Health oriented transformation of food systems in service to equity, sustainability, and health. Well, it is now up to us to implement those recommendations and to use them to make systems more equitable, fairer, and more just. We need to collaborate inclusively, empower communities, and integrate different disciplines and sectors to arrive at better outcomes. One Health has been picked up at high places, the latest one being in Lyon, France, where 2 weeks ago the French president, together with the president from Ghana, invited heads of states together at the One Health Summit. I will now carry that message to the German Ministry of Economic Cooperation and Development this week, the very reason why, unfortunately, I cannot be with you. Thank you very much for your attention.
We have time for one question, previous to go to Dr. Lewis' presentation. And if nobody has a question, I have one for Claudio and Dr. Boone. And I would like to know which was your experience with the exchange with all these projects with the politicians.
Well, how much time do I have? So the experience with politicians is very diverse. So I can report maybe on the Swiss experience, and I let Paul to talk about, although I've been also at the European Parliament, but change the mic. So maybe I can say in Switzerland. So I had the chance, I mean, Switzerland is organized with 7 executive ministers. So we have one minister who is actually in charge of the health system, but she has many other duties. So it's very difficult to get really to talk with the important stakeholders of health in Switzerland. But we had the chance with Ingrid and Alexander. We were there already twice, and we will meet her in June. So one of the main challenges is really to understand what is there or what is her goal and try to really fit in your proposal with what she wants to achieve. That's probably the most important point. So, I mean, we have understood that our health minister is very interested in prevention, but we know she's under pressure from many other stakeholders. So we actually are phrasing our proposal in order to try to fit with what she wants to achieve and that she can use us, you know, to get what she wants to achieve. Now, one of the key questions that she asked us at the first meeting was, if we give you a mandate, who will be unhappy? And and who would you like to be, supporting you? And so she was very, very direct. And I think the most challenging part is really to be inclusive and to be convincing in, joining forces with one common goal.
Well, on the European side, complicated, as I said, 27 European Union countries, 48 countries in the European space. Most of them are democratic countries, but there's also non-democratic countries, so it's complicated. Just one, well, I could say a few things. Maybe on a political level, what politicians typically are completely allergic to is that people who have a request or want their attention do not speak with one voice. So I will just give you a very quick example. Day one, somebody from dementia comes. Day two, somebody from the epilepsy world comes. Day three, another person comes, completely confused, and it becomes a competition among different stakeholders. The better thing is to unite first and then go with one voice and a clear message. Obviously, what is the message? And there I reiterate what Claudio just said. Is your message in line with their political agenda? Then you're fine. If it is not, then you simply don't get the attention. What typically works on a non-political level is to do a little bit of research and to see whether politicians, high-level people, have a problem in their own environment. And I mean, just looking at the prevalence, 1 in 2 people have a neurological disorder. So if I look at the European Parliament, 400 and so many MEPs, half of them either has a neurological problem or they certainly have family members with a problem. So what I'm saying is that the personal experience is a very strong motivator. We have had a couple of ministers of countries that were leading the European Union who were either neurologists, doctors themselves, or had a family member, direct relative, a wife, a spouse who had a neurological problem, and that was an additional way of getting their attention.
Thank you very much. This gives us a lot to learn from your experience. Let's move with our next lecture. This is Dr. Stephen Lewis. Stephen Lewis, he's the president of the World Federation of Neurology. He brings a global perspective to the stage. He's a physician-in-chief and Dole Chair of Neurology at the Fleming Neuroscience Institute in Pennsylvania, adjunct professor of neurology at Thomas Jefferson University in Philadelphia, and regional chief for the Lake Valley for the Vicky and Jack Farber Institute for Neuroscience of Jefferson Health. Today, he joins us to share his expertise on overcoming fragmentation, national and regional lessons. Doctor.
Thank you for that generous introduction, Dr. Chetkovich. So here is the title of my talk. I'll give you a little bit of an outline. I'm going to start with first of all, thank you so much, Claudio and Facundo and the organizing committee for this incredible invitation to present at this wonderful conference. And I've met so many amazing people, and these are collaborations that started yesterday and will continue for many years to come. So this is really an incredible experience and a great opportunity. The outline of my presentation is I'm going to start with a little bit of an introduction to what the World Federation of Neurology is. I'm going to go into a little bit of a history of the term brain health, which I think is sort of interesting. I'm going to talk then about ways we can sort of break down silos at the WFN level, followed by a little caveat about unproven therapies I think is worth mentioning in the context of brain health as brain health has exploded, and then a conclusion. So this is a box that's been sitting on my desk for the last 25 years, interestingly. It's yellowed a bit. I thought it was kind of cute. I bought it about 25 years ago. I think its efficacy is dubious, but it's so interesting that that these healthy brain pills, so the actions are to improve mental function. So it's brain pills, mental function, and helps one sleep well. So it really brings all of our concepts together in a nice way. What is the World Federation of Neurology? The World Federation of Neurology is a federation of neurological societies. It was formed on July 22nd, 1957 in Brussels, Belgium. It's based in London. It's a United Kingdom charity. and the defined mission, which I believe was restated or created by Vladimir Hachinsky about 15 or so years ago, is to foster quality neurology and brain health worldwide, with the emphasis placed in under-resourced areas of the world. So brain health has been part of the mission statement for about 15 years, which is interesting because we'll talk a little bit about the terminology about brain health in a moment. There are currently 126 member societies. So you think about how many members does the WFN have? It has 126 members, 126 delegates. Of course, each delegate is a delegate from a member society that can have anywhere from 5 to many, many thousands of members themselves. And those member societies live within 6 independent regions of the world, sort of corresponding to the WHO regions, in no particular order: the African Academy of Neurology, the Asian Oceanian Association of Neurology, the Pan-Arab Union of Neurological Societies, the Pan-American Federation of Neurological Societies, of which Argentina is a member, the European Academy of Neurology, and the American Academy of Neurology. In 2017, the World Federation of Neurology was privileged to participate in a project with the World Health Organization, helping create this atlas of country resources for neurological disorders. It's a long PDF you can find online. Anyone can look up online, just Google Atlas, Country Resources for Neurological Disorders, WHO. But this to me is the take-home point of the whole atlas. This is the distribution of neurologists throughout the world. And it's a little hard to see, but at the top you see it organized by regions, and those 2 little humps, the smallest humps, are Southeast Asia and Africa, Africa being the smallest, with less than 0.1 neurologists per 100,000 population, and some areas of Southeast Asia being not that far ahead. And then if the bottom figure is number of neurologists per World Bank income group, and in the low-income areas, it's less than 0.1 neurologists per 100,000 population. Some places it's 0 per 100,000 population. So what are the main activities of the WFN? Well, we're trying to help address neurological disparities despite those imbalances in neurological care. We do it by 3 main categories of activities: capacity building, such as training and grants. We try to increase the number of neurologists, particularly in Africa. Advocacy, with our work with the WHO and the UN. And publications, including World Neurology, which is available to everyone online for free, and our research journal, Journal of Neurological Sciences. Many, many other activities, but these are the 3 sort of major endeavors. We're all aware from our previous talks of the global burden of disease from the Lancet in 2024, and we all know that neurological diseases are very, very, very prevalent, whatever number we want to put to that, incredibly prevalent. An IGAP, the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, which is a 10-year plan. We're about halfway through it now. And this past year, just a few months ago, the WHO created their global, or printed their global status report on neurology, showing that not only did many countries not respond, including, unfortunately, the United States. You see the U.S. is white there, not green. Even the countries that did participate in the survey showed that they were pretty far behind in enacting the activities of the IGAP plan. The WFN is pleased to help support the WHO in a project to help implement IGAP in Ethiopia as a model for other low middle-income countries. So I'm going to move on to my next part of my talk, which is the emergence of brain health as a concept. I don't know if anyone knows about Google Ngrams. It's my favorite toy to play with online. It's you can look it up. Just go to Google and go to Google Ngrams. What Google Ngrams is, it's a look at words, at least in the English language. I'm not sure if it exists in Spanish or not. I'm sorry, but for English words at least, there is. If you put in a word, you can see how often that word exists in the printed book literature. This is not journal, but book literature. So the sample is of Albert Einstein, Sherlock Holmes, and Frankenstein. So how do those words, some are double words, Albert Einstein, Sherlock Holmes, and Frankenstein, how have they evolved over time? So looking here, you can see that as of about 2020, the word Frankenstein existed in 0.000110% of words in the English language. So the actual number doesn't exist, but of all the words, that is the percentage of words that have the word Frankenstein in it. The actual number isn't important, but just watching the evolution of how that word has been printed over years is quite interesting. So what does that have to do with brain health? Well, let's put in the word brain health. Is that interesting? So it essentially did not exist in the English language literature until around 1999. Did not exist. Those two words were not even put together in any printed book until around 1999. It's a nice toy. You may want to play with it if you haven't done it before. So that's the printed book literature. Let's go to journal literature and PubMed. So this is putting brain health together, in quotes together. And you can see that 1998 and around 1998, zero publications had the word brain health in the title. The first I could find is in 2007, where brain health actually was about the brain health we're talking about, was 2007, the very first printed article. And of course, now we're at around 4,000 articles as of 2025. So this is explosion of articles and initiatives and discussion about brain health. And it's quite new. So that leads to the next part of my talk, is the brain health concept has expanded in the last really 10 years. The 6 World Federation of Neurology regions have independently and appropriately created or are creating their own brain health agendas, and we learned so eloquently today and yesterday about the brain health agendas through the EAN and the AAN and their massive efforts within those regions. At the WFN, the World Federation of Neurology, our charge is to help ensure communication between all regions and learning best practices from each other and not reinventing the wheel where we don't have to reinvent it. Additionally, and you've seen these, at least the first two, you've seen the World Psychiatric Association mentioned a number of times, maybe not as much the Child Neurology or World Federation of Neurosurgical Societies. But so well modeled on today's and yesterday's talks. We need to actively engage related general societies, particularly the Child Neurology Association, because brain health starts in the womb, as Dr. Boone said. And psychiatric societies, particularly the World Psychiatric Association, as well as the World Federation of Neurosurgical Societies, particularly in relation to brain trauma. Of course, we also can engage and need to engage countless other organizations, including subspecialty organizations, stroke organizations, World Federation of Neurorehabilitation, and so on. And that's our charge. And we're beginning it now, and this examples like today are just wonderful examples of that interdisciplinary communication. Another example of this increasing communication and engagement is our recent recent World Federation of Neurology Global Leaders Roundtable. It took place at the AAN annual meeting just a week ago, and prior to that at the World Congress of Neurology. And at that meeting, the last meeting, we had 22 stakeholders from all around the world. We had high-level involvement by the EAN and the AAN, just meeting together for several hours, talking about brain health and things we can do together. What we learned from that meeting were that, which as I think we all know today, that priorities for brain health can vary among countries and regions. I think we're all in agreement, at least, again, there was purely neurology, no psychiatrists at that meeting, but we need to have psychiatrists at the table. That brain health and mental health are intertwined and impossible to separate. Systemic, a big part of our discussions were systemic health is critical for brain health. We talked about metabolic syndrome, cardiac health, but really all systemic health is critical for brain health. The brain can't exist without a functioning body, and we all know that from delirium and toxic metabolic encephalopathies, and as came up yesterday. So brain health is the pinnacle, but we need body health as well. We need validated tools to measure brain health in multiple domains. This has come up in several other talks. And what really came out of this meeting, and we had 22 stakeholders plus high-level executive involvement, was the most impactful and measurable intervention is public awareness. So public awareness committee, we all sat around figuring out what are the ways we can try to make a difference in brain health in a year or two, and how, and assuming we can measure that difference. Public awareness campaigns was sort of number 1, 2, and 3 on the list. And interventions, as we've learned so eloquently from Dr. Boone and others in the last few days, they optimally begin in early life and childhood, and of course in the womb. One other thought is that perhaps a globally informed redefinition of brain health may be needed. In addition to the WHO definition that we all know so well, perhaps neurologists and psychiatrists can get together for a revised, maybe updated definition of brain health. Also, to help improve communication among all of our stakeholders and improve collaboration within the WFN regions, within the WFN societies and organizations such as the Alliance today and many others throughout the country, throughout the world, I'm sorry, we have developed the WFN Brain Health Strategy Committee. This is forming just this month, coincidentally. Professor Riyad Guider, who I believe is in the audience somewhere, there he is, waving way back there, who's the vice president of the World Federation of Neurology, is the chair of this committee. And there's a number of people in this room today who are already been invited to be part of the strategy committee. The idea is to bring together multiple high-level stakeholders representing multiple regions and brain health initiatives. And our aim is to enhance communication, break down silos, and this will help inform at the WFN Brain Health Strategy. We will ensure representation from psychiatry, neurosurgery, child neurology, and many others. So we're very excited about this, and again, this meeting we're at today is just a great example of how important it is to break down silos and work together, and we're trying to do that now at the WFN level, which we have not done so well until now, frankly. So we need to break down silos. We need to increase communication and collaboration among neurological societies, among regional associations, among neurology and psychiatry, and other related organizations. So that's between and within disciplines. We need to share evidence-based interventions and guidelines. We need to involve patient groups. We need to ensure geographic reach and equity, which I think we are doing fairly well now. The highlight must be on prevention, which is a paradigm shift among clinical neurologists, as well as early diagnosis and treatment, which is a little bit less of a paradigm shift. And all of these should be done independent of provider resource imbalance, which from my earlier slide, you know so well. So there are things we can do despite 0 to 0.1 neurologists per 100,000 population. There are things we can do, and we can enable non-neurologist providers in a very thoughtful way as well. So let's go back to my unproven therapy, which was sitting on my desk. As the brain health concept has exploded, so have other endeavors throughout the world, like brain health clinics and many other endeavors, some of which are endorsing or touting unproven, perhaps ineffective, perhaps expensive medications, which may or may not be efficacious, may even be harmful. So it's important for us to think as brain health leaders to be sure we are critical of and endorse only those activities which have evidence-based. So if you Google these things, you'll see lots and lots of interesting activities and interesting machinery and so on that's being touted, used under our umbrella, if you will, of brain health. So this is a picture from the Lancet, keeping with the Lancet theme. Just we have to be sure that we are endorsing only those activities that are evidence-based and staying away from people who might be charlatans. Anyway, in summary, brain health is a very, very new concept. We are building the plane as we fly it. There are many views on brain health despite one brain. No single institution, society, or initiative is the owner of brain health. We all should strive, as I ended with the most evidence-based interventions. We should support proven global endeavors in the mission of brain health in this ever-expanding group of interested and committed stakeholders. And it's critical that we have inter-society and interprofessional communication and collaboration, as is being exemplified here today. Thank you so much. Oh, finally, World Brain Day 2026 is on brain health access for all. Thank you.
Thank you very much, Professor Lewis, for such an outstanding approach. And talking about silos, I remember this paper from Andy Kanner some years ago, whose title was, "When did psychiatrists and neurologists stop talking each other?" Which is the silo between psychiatry and neurology, for your point of view? Which is the main risk or the main challenge to afford it?
So the question is, when did we separate, or when did we stop talking to each other? Probably about 30 or so years ago, when I think in many countries neurology and psychiatry did separate. I was fortunate to be the chair of the American Board of Psychiatry and Neurology for a few years, just a couple of years ago, where we do get together, and yet we divide up when we talk about certifying neurologists and psychiatrists. So I've learned more and more as I become more involved in the certification world of neurology and psychiatry. I'm no longer there, but when I was a few years ago, that we do share a very, very common bond. Different diseases, but a common bond. I think this brain health initiative is bringing us back together. All of our brain health initiatives, that's what I'm saying, the brain health is bringing neurology and psychiatry and together, you know, mental health, neurologic health, all as one. Again, hearing about, you know, depression as a marker of impending depression, and depression as a symptom of neurologic disease, and many other specific ways we are intertwined. But yeah, we were quite separate for a number of years in reality, but now it's turning around, and this brain health initiative is critical.
I hope so. We have a question.
Thank you. Thank you very much. I have one question, because I think that, do you foresee the role of WFN as bringing hope? Because these millions of people with neurological disorders, they are expecting from us, from the neurologists, some hope for a change. Do you think, what is the hope that you think, the message of hope that we can bring for all those millions of people waiting from us an answer, because we are doctors? Do you think the WFN can help us to convey a main message of hope for improving this burden? What would be the key message that we should all share, provided by the WFN? What do you think?
I think the key, if I'm hearing the question right, I think the key message, the hope, is that we are now not ignoring this disease, which is incredibly common, if you will, brain disease. We're not ignoring it anymore. This is number one on our agenda. So that is the hope, and we have brilliant people around the world devoted to the care of neurologic disease and psychiatric disease.
Claudio?
I have two short comments. One is an historical comment, and another one, a comment that you made, Steve. In fact, I think one of the reasons that the two disciplines separate is psychoanalysis. It was in the 1850s, 60s that in Zurich, Professor Griesinger said, all psychiatric disorders are brain disorders. And it was actually then Austria and again Switzerland with Eugen Bleuler who actually gave support to psychoanalysis, and this actually brought to the separation of the two fields. And I know that Facundo and others here in Argentina stressed the fact that psychoanalysis has been also a problem for biological psychiatry in this country. So I think this is probably why the two fields then separate, or at least was one element of the separation. The second one is that, and you said, Steve, I think we should stop talking about brain and mental health as two separate things. There is one brain and we have a biopsychosocial environment that plays a role in how we experience and how the disorders develop. So we need to really work for a united definition that includes both perspectives. But if we continue talking about two types of health, we just foster division, and it's time really to reunite. So this is a statement that
Thank you, Claudio.
think
Could not
here.
agree more. Thank you.
Dr. Minzer,
First of all, great lecture, really great presentation, and inspiring. And one of the things I think is I heard today that people are working on certifying people with specialization in brain health. On the other hand, I heard you, and I saw it in the US and everywhere, that for-profit, not always responsible, brain health clinics are emerging everywhere. And the question is, why not to provide some type of certification or monitoring of these brain clinics and establish some kind of a protocol where actually they will be promoting what we know scientifically that makes sense in terms of brain clinics?
So the question is, there is a push for certification in brain health?
You have mentioned that there is a certification for brain health in European countries, right? So the second question is, why, and there are clinics that coming, why not to merge both? And why not to start to promote that only people that they are certified in brain health and have a knowledge and use scientific data are the ones that are in the clinic, and clarify those that they are not?
Oh, no, I didn't mean to, I hope I'm hearing the question right. No, I'm not aware of any absolute certification in brain health. I'm saying that as those of us in neurology and psychiatry and who are working in brain health should be aware that there are some people utilizing the brain health terminology to tout unproven therapies. That's a concern of mine, and it's something I see perhaps more in the United States than elsewhere. I don't know that, but it's a bit of a concern of mine that our message could be diluted by others. But I'm not aware of any certification. Thank you.
thank you, Professor Louis, for this enlightening lecture and the questions. We have to move to the next keynote lecture. This new keynote lecture is Dr. Danuta Wasserman. Dr. Danuta Wasserman is head of psychiatry at the Karolinska Institute. She has led a lot of research on suicidal prevention, and she's currently the president of the World Psychiatric Association. And her talk will be psychiatrists' role integrated in brain health strategies.
Hello, my name is Danuta Wasserman, and I am professor of psychiatry and suicide prevention at Karolinska Institute, which is well known internationally due to the awarding each year Nobel Prize in Medicine or Physiology. I am also the president of the World Psychiatric Association. I would like firstly to thank you, Professor Claudio Bassetti, for inviting me to this important international alliance on brain health, which comprises national, by that I mean Swiss Brain Association, regional, European regional, comprising several organizations like European Psychiatric Association, EBC, EAN, etc., and also international partners like WHO, WPA, and World Federation of Neurology. And this conference is, of course, under auspices or stimulated by the Lancet Commission on Brain Health. I will speak today about psychiatry's role in integral brain health. My disclosure statement is following. I am partner in 2 companies at Karolinska Institute, one research and development company on mental health in young people, and the other one educational company providing training on mental health first aid. Why it is important to speak about integrated brain health strategies and why collaboration is so important in my case between neurological associations, neurologists, and psychiatrists and World Psychiatric Association. We all know that there is rising multimorbidity and burden due to the global aging population. We know also that there are several gaps in access to effective treatment, but also when using effective treatment. We know that stigma and discrimination and inequalities hit patients belonging to both groups, both psychiatry and neurology. And we know also when we collaborate, they are very big opportunities to save money, to have better effects in the society and better funding for research. Firstly, I will show some figures on prevalence of neurological and mental disorders. 1.1 billion people suffer from mental disorders, and almost 3 billion people suffer from neurological disorders. On the top of that, we have some categories which are not included here, like, for example, some other brain conditions and stroke in neurological disorders, and self-harm and substance use disorders in mental disorders. We can see also on the left side of the diagram that, for example, Parkinson's disease increased since 1990 to 2023 by almost 244%. Alzheimer's disease increased by 185%. Anxiety disorders by 160%, and major depressive disorders by 101%. Of course, we can also measure burden in DALYs. It means disability adjusted life years. And here you can see that mental disorders increase or will increase between 1919 and 2023 from 85 million people hit to 171 million people hit. And neurological disorders marked with the green line from 60 million people hit in 1990 to 117 in 2023. So in 2023, brain and mental conditions belong to the brain also. However, we also speak about the soul and experiences, not only about the changes in the brain and central nervous system. So they accounted for 546 million disability-adjusted life years, more than in cancer. Together, conditions in brain, comprising both mental disorders and neurological disorders, account for 1.7 trillion annual direct spending on care, and of that 700 billions on inpatient care, which is a lot of money, of course. Then, as I mentioned before, we have an aging global population on our globe. When we look at those who are 60 years or older, 1 billion people in 2020 will become 2 billion people in 2050. Almost 1 in 5 people will be older than 60 years. When we look at those who are aged from 80 years and over, the numbers will triple between 2020 and 2050, and we reach 426 million people. We know also that not always the last years in the life are very healthy years, and there is some discrepancy in between how long we live and how is our healthy life in those older ages. Current prevalent cases of dementia are 27 million, and they will become 152 in 2050. And so it will be 3 times more than in 2020. And concerning depressive disorders, it will be doubling of depressive disorders from 67 to 148 millions. There is quite high prevalence of mental disorders in patients with neurological disorders, comorbidity. Let's look at the example of Parkinson's disease. Depression in Parkinson's disease patients is about 38%, anxiety, 48% of Parkinson's patients has anxiety, and 20% have psychotic symptoms. When we look at headache, we see that depression is present in 27% of patients with headache, anxiety in 25% of patients with headache, etc., etc. And if you look at the global population, I mean comprising both healthy and unhealthy subjects, depression and anxiety has prevalence among 4.2 and 4.6 respectively. So we go now to stigma and discrimination. There is a very interesting investigation from European Federation of Neurological Associations showing that 92% of persons who have neurological disorders, they feel that they are affected by stigma. 74% feel that they are not adequately treated. 35% avoided to seek treatment because they felt embarrassed. And 30% have been denied insurance or mortgage because of their conditions. 32% have been made to feel that they are inadequate parents, and 20% feel that people avoid them because of the neurological conditions. They are very, very serious numbers. Another study on psychiatric population by Thornycroft and his group showed that both media and governments should do something more about perceived stigma and discriminations. And it is an important call to increase awareness about those perceptions of being stigmatized and discriminated. Coming back to biological correlations now, one can or many asks themselves if there are genetic correlations of common disorders of the brain, both neurological and psychiatric. And there is a limited evidence for common genetic risk sharing between psychiatric and neurological disorders. The only exception in those studies was migraine, which was significantly correlated with major depressive disorder, Tourette syndrome, and ADHD. In another study, also published quite recently, both psychiatric and neurological disorders show robust correlations with cognitive and personality measures, as well as health and lifestyles, which is extremely important. Cognitive functions are important to have under control and try to counteract deterioration, and personality measures can also be taught by different kinds of therapies how to act, and lifestyles are very important as well. Another mechanism, biological mechanisms, are inflammatory processes and hypothalamic pituitary adrenal axis overaction. Studies show clear link between epilepsy and depression and inflammations. And other studies show that hyperactivation of HPA axis is seen in many mental health disorders and also in some worsening of some neurological disorders. We know also that dysfunctions in the serotonergic system are very well studied in association between migraine and depression, and that brain serotonin imbalance seems to be implicated in both diseases. We know also that the coexistence of neurological and psychiatric disorders results in poorer quality of life, in poorer functional outcomes, in basic daily activities, in poorer physical and cognitive function, increase in recurrence of different neurological and psychiatric diseases, increased risk for overall mortality, and increased risk for suicide. Treatment of depression and anxiety symptoms in neurological disorders is very often, you remember the prevalence table of coexistence of neurological disorders and depression and anxiety. And of course, antidepressants are the primary treatment. However, we still need to have better efficacy of the medication we have, and safety needs to be improved. We use also cognitive and behavioral interventions, which show small to moderate improvements in depression and anxiety, and also mindfulness-based and experience-based interventions can enhance well-being and diminish depressive symptoms. But gaps in access to effective treatments also is dependent on specialized workforce. And unfortunately, either in high-income countries and low-income countries, we have enough psychiatrists, neurologists. Child neurologists are almost non-existing, especially in globally and low-income countries. And neurosurgeons, mental health nurses, and psychologists. That means that the treatment gap for epilepsy, for example, exceeds 75% in low-income countries and around 40%, which is very, very high percentage in Europe and United States. For common mental disorders, we have 50% global gap in treatment and up to 90% in low and middle income countries. In a very good study published in World Psychiatry on 650,000 patients enrolled in 3,700 randomized controlled trials, on which 102 meta-analyses were done, show that the efficacy of pharmacotherapies and psychotherapies is almost similar, 0.36 to 0.34, which means that we need to have more studies, and it costs a lot of money and takes time. But what we know also from that article, that not only that efficacy needs to be improved, that we need to have new medications, treatments, and other treatments, but also that evidence-based treatments, both psychological and pharmacological, who have good efficacy on the diagram, which you can study in the article in the World Psychiatry, show that even good treatments are not sufficiently implemented due to lack of resources. And on my previous slide, I show the gap between needs and access to professional staff. So what we can do, we have a lot of studies from neurological disorders and also psychological disorders, showing that physical activity, diet, and sleep, it means important lifestyles which can be improved. They prevent new symptoms or reduce symptoms, both in headache, stroke, epilepsy, Parkinson's disease, multiple sclerosis, and dementia, and all that improves quality of life. And we have similar results, but less studies from psychological disorders, psychiatric disorders, but we can also see symptom reduction and some preventive effects in depression, anxiety, schizophrenia, substance misuse, bipolar disorder, ADHD, eating disorders, and PTSD. And it is one of the fields in which neurology and psychiatry can collaborate more, especially if the location for the patients is not far away for each specialty. But we can also collaborate with our outpatients, maybe in the common groups for patients with mental disorders and neurological disorders. But it is not only sleep, physical activity, and nutrition, but we also know that intellectual stimuli, access to green spaces, it means how you live, how hospitals are planned, is important for well-being and health. Workplace and school satisfaction, and workplace, I mean for us as psychiatrists, nurses, and other professions working in the hospitals, is really very important for our well-being, but also for our patients' well-being. As we can see, healthy lifestyles improve both somatic health, mental and neurological disorders, and quality of life. It can prevent some physical somatic illnesses, and to some degree psychiatric and neurological disorders, at least to see that they are not worsening as quickly as they usually do, and also to improve cognitive function and prevent functional decline or to try to preserve those functions we have and not allowing them to decline too quickly. And target groups are both patients, health and mental health professionals, and general population. Why I mention here health and mental health professionals? Because we need to be aware about our own mental health, and we need to be aware that how to preserve our good somatic and mental health. On the World Psychiatric Association website, there are 6 films which I produced during my presidency now for World Psychiatric Association, and they are about nutrition and physical activity of different degrees of difficulties, which can be used on our wards or in outpatients departments, and nutrition films about how to speak and motivate young people to keep and upkeep healthy eating. And those videos you can find on our website under Healthy Lifestyles Hub. I wanted here to draw your attention to very important initiative by the World Health Organization on a framework, common framework for mental health, brain health, and substance use, when World Health Organization really very nicely outlines common causes and characteristics, shared needs and challenges, both for mental health, substance use conditions, and neurological conditions, which are contributing to poor mental health and poor well-being, and how to work in order to achieve better health. And they use both biosocial approach, prevention and promotion of health treatment, and common policies and programs, and especially programs on healthy lifestyles and programs on how to treat comorbidity. And a few words about the World Psychiatric Association. It is an association present on all continents in 123 countries with 147 psychiatric societies and more than 250,000 psychiatrists. The WPA mission is, of course, to promote mental health through research, clinical activities, prevention, and promotion of healthy lifestyles. And we have a yearly World Congress of Psychiatry, and we collaborate with WHO and other non-governmental organizations, for example, like World Federation of Neurology. The organization now is run by the EDIT principles. It means equality across gender, ages, and ethnicities, to observe developmental stages from childhood to adulthood and beyond during the old age, in treatment, etc. I stands for inclusion of underrepresented groups, and T for awareness about transcultural perspectives and aspects. And just for curiosity, I was looking how those principles are, for example, respected in authorships across genders, equality. You can see that female first authorship is almost similar for neurology and psychiatry, 42% for psychiatry, 39% for neurology. And senior authorship is the same, almost similar, 29% for psychiatry and 26% for neurology, in comparison with cardiovascular sciences, around 2.4 and 3.8% for first authorship, respectively for senior authorship, which means that we are quite advanced, and in spite of the similar field of work, we have probably similar awareness concerning equality in our professions. When we look at the ethnic representation in research, we can see that approximately 60% of study reports, for example, from in JAMA Psychiatry and other American journals, report they do not provide information on participants' identities. And white participants account for 80% or more of the sample in many studies. Asian, Black, and Hispanic participants, as other minority groups, are frequently underrepresented, which of course is violating this inclusion principle. And it is important also not only for psychological inclusion, but also for knowledge concerning different ethnic groups and how they respond for pharmacological and psychological treatments, and also how they perceive stigma and discrimination. I started to work on those topics since I started in 2023 my presidency for the World Psychiatric Association, and we have common symposia on neurology and psychiatry in our respective world congresses. For G7 meeting in Canada in 2025, we prepared a paper with some recommendations how to collaborate. And we have also an article in the World Psychiatry, how integrate brain health in our activities and to have a unifying goal for health, productivity, and well-being, both in psychiatric and neurological disorders. Before I say thank you and finish my presentation, I would like to invite as many as possible of you for the 26th World Congress of Psychiatry, which will take place in Stockholm this year in Sweden between 23rd and 26th September 2026. Thank you very much. And thank you once more for inviting me.
We thank Dr. Wasserman for such an enlightening lecture. We have time for coffee, 20 minutes, right? 20 minutes to be here. And please, the speakers, stay to a group photograph, please.
No, que viene el chair. No quiero decir que la gente se siente y lo invito a Christopher que... No, él quiere ver su presentación si está bien. Hola, hola, hola. Uy, necesitamos que tomen asiento y avanzar con el programa, que estamos un poquito demorados. ¿Les puedo pedir silencio, por favor, que estamos por comenzar? It's okay. So Christopher es el que lo presenta, ¿no? Sí. Chris, ¿no? Sí, pero sí.
I was going to sit down there. So you,
No,
go ahead. No, you sit.
You will introduce
Yeah, I will
Juan, ¿no?
introduce.
Okay.
Okay. Oh, Claudio, please. No, I'll do it from here. Otherwise,
The webcam, the cam. So I need you there.
you need me here. But I can go back down, right?
Yes, of course.
Yes, okay.
Then, but when you speak from here.
Must be from here.
Yes, please.
Is there? Oh,
No, it's not.
people use the same microphone.
No, but we have
I'll put it here. I'll put it here. Okay. Okay, hello everybody. Welcome back from a well-deserved coffee break. We're now moving to our second session of the day, which is entitled Integrated Brain Health in Action, from Global Strategy to Regional Implementation. And our first speaker is Diego Aguilar, who actually works in Argentina. So you were on time. That was fantastic. He's a regional director for the Americas at the Alzheimer's Disease International, and he leads policy engagement and regional strategy across Latin America and the Caribbean. The Caribbean sounds very nice, actually. He serves on the board of IDROS and is a long-standing member of the Fundación Lyon, where he's helped advance Argentina's first subnational dementia plan. He's also had 20 years' experience in non-profit leadership, international collaboration, and importantly, fundraising. So today he'll be presenting on Beyond the Plan, dementia policy implementation in Latin America and the Caribbean. Diego.
Thank you. Buenos días. Well, first of all, thanks to Facundo and Claudio for inviting me to this event. It's been wonderful to listen to all of you, and there have been some great talks. So I'm going to talk a little about From Plan to Impact, which is written there like a question, and the implementation gap in national dementia plans in the region. So a little about ADI. We were established in '84. We're the umbrella organization for 105 Alzheimer and dementia family and people living with dementia associations around the world. We represent our members at the WHO, the UN, the Pan American Health Organization, and other global and regional bodies. We promote the World Alzheimer's Month, and we publish the World Alzheimer's Report every year, among others. Our vision is prevention, care, and inclusion today, and a cure tomorrow. So why, the first question is why this is not only a planning problem, but an implementation problem. So we know that 66% is the pooled dementia prevalence in the region, in Latin America and the Caribbean. 21% is the prevalence among people with no formal education, and over 155% is a projected increase in the Caribbean by 2050. In Latin America and the Caribbean, dementia prevalence is unequal, not just high. So we can see here in the graphs that more women have dementia than men in the region. More people living in rural settings have dementia than people living in urban settings. And more people with no formal education, which is actually a very high number, over 21%, have dementia over people with more than 1 year of education. So the region really needs a last mile public health analysis. So let's talk a little about ADI's journey. As you know, we've been tracking the progress of national dementia plans worldwide through a report that's called From Plan to Impact. And so what we can see is that initially we had a target, which was the WHO target of 146 countries getting national dementia plans. And we got 45 national dementia plans worldwide. 21 countries or territories were developing or integrating dementia plans in 2025. So what changed in 2025? The WHO extended the Global Dementia Action Plan to 2031, which is actually an implicit recognition that targets were off track and that implementation now matters as much as adoption. So we can see here that we got a plateau in 2022, 2024, and we didn't grow until 2025 when there was an uptick with the extension. So what's the new insight? ADI's own trend line suggests that the bottleneck has migrated downstream from write a plan to fund, communicate, implement, and refresh a plan. So the Americas and from Plan to Impact, we've been doing this for 8 years. We have 8 editions from Plan to Impact. And what we can see in the Americas, it's not just only a yes or no map, but actually a maturity ladder. So we can see we've kind of devised these 5 stages. So we have one stage that's no traction, such as Nicaragua, El Salvador, Venezuela. The second stage, which is only the agenda stage, such as Bahamas, Barbados, Jamaica, and others. The third stage is in development. The plan is in development, like Argentina, Panama, Peru, Dominica, Suriname, Trinidad, and Tobago. The fourth stage is adopted but fragile, such as Brazil, Mexico, Canada, Costa Rica, Cuba, Dominican Republic. And the fifth stage, which is operationalizing, like Chile and the USA. So the regional story is not only the absence of plans. It's increasingly a stage 4 problem. Plans do exist, but financing, communication, and execution are weak. So I would like to spotlight a little bit on the Caribbean, which is the hardest implementation context in the region. Why? Well, we know that over 155% of forecast increase in Caribbean dementia cases by 2050, and only 16% of territories in the Caribbean had made any progress in dementia plans in ADI's 2023 regional campaign. So selected Caribbean territories show a split profile. We have early traction, like Jamaica, St. Lucia, and Cayman Islands, drafting space, like Dominica and Trinidad and Tobago, adopted but not implemented, like Bonaire or Curaçao, or adopted like Puerto Rico. So the Caribbean is not just behind. It faces a compound implementation challenge: small state capacity, fiscal fragility, thin data systems, and heavy family care reliance. So if we look at all this through the implementation science lens, we can detect where the gap actually sits. So let's say we have these 6 phases. We have the first in policy adoption, where the plan or strategy is approved. So the typical implementation gap there is policy signal without delivery design. When we're in the stage of financing authorization, budget line, costed package, and purchasing rules, the gap is going to be no protected budget or weak budget execution. If we're in the stage of delivery architecture, with primary health pathway, specialist referral, the gap is going to be in the plan not embedded into the primary healthcare or social care workflows. If we're in the stage of workforce capability, the gap is going to be in training that does exist but does not change routine practice. In data and learning, the gap is going to be in no feedback loop, so gaps stay invisible. And in sustainment, where we're going to see refresh, protect funding, and expansive national reach, the plan expires, fragments, or never scales. So the key message here is that many Latin American and Caribbean plans do not fail because the policy text is wrong. They fail because functions 2 to 6 are thin and funded or never routinized. So at ADI, what we did is we kind of divided plans into 3 categories: symbolic, fragile, and embedded. So symbolic plans in the region, the policy signal is much bigger than the delivery capacity. So they're often adopted after strong advocacy or legislative pressure. The budget is absent or not operationalized. Executive ownership is very weak, and examples are in Brazil and Mexico. We've been working in Mexico, for instance, for ages. The policy text is wonderful. They have a wonderful dementia plan, but it's really a symbolic plan because the executive ownership doesn't exist, and the implementation outcome profile here would be adoption without feasibility or penetration. Fragile plans, where the policy exists but the operating model is thin, we are going to see plans that are underfunded, unevenly communicated, or stalled in rollout. They can have legal or strategic status but weak execution. An example is Costa Rica, Canada, Dominican Republic, and Cuba. So what we do every year, which is very interesting, is that we go and we ask different stakeholders, among them obviously our member associations, to kind of score what their national plans are looking like. And this way we figure out where they would, in which category they would fall. We have the third category, which are embedded plans that are linked to entitlements and delivery routines. So here the budget, pathways, monitoring, and refresh mechanisms do exist. They're usually better connected to primary health care, social care, or legal guarantees. And examples are the United States, Chile, which is the strongest regional move in direction because of the guaranteed state health, and the primary health network. Although I'm very worried about Chile because we were talking with Andrea, and she's saying that the current government of Chile is decreasing the budget for the National Dementia Plan, and Chile's National Dementia Plan is really a star in Latin America. So here in embedded plans, implementation outcome, the profile will be better penetration, accountability, and sustainment. So here are some cases that are interesting where we can read the region. So for instance, Chile, which I was talking about, is the most important near-embedded case. So here we have legal access through the GES, which is very important for Chile, and a care network emphasizing primary care, specialized mechanisms for complex cases, workforce training, and stigma campaigns. Chile is also reviewing and relaunching its plan. So Chile started in 2017, and it's now relaunched its plan until 2031. We hope that it gets a budget with President Cast. This is what translation from policy into delivery functions look like. In Mexico, it has a strong design logic, but stage 4B, which is no funding. So Mexico's updated plan emphasized it. They also updated their plan. They started their plan pre-Global Action Plan, so it's from 2014. And now once they hit their 10 years, they did a relaunching. They emphasize in primary care screening, long-term care, research, and stigma reduction. But what we've seen is the classic implementation trap. Technical architecture exists on paper while financing is not secured. So nobody really knows in Mexico who's supposed to finance a plan, and so it doesn't ever get financed. In the Dominican Republic, there's policy adoption without execution. So ADI classifies here as the country stage 4F, which the plan is adopted but not implemented. This is the purest example of the implementation gap as commonly discussed in implementation science. And Brazil and Cuba, which are the same stage family but different political mechanisms. So Brazil's policy push has been driven more by civil society and the legislative branch than the executive. But Cuba frames the WHO plan as a guide and says implementation is monitored annually. So I think we have to stop asking, do you have a plan? And start asking, can your plan be implemented? So we've been talking a lot about, in Leon and now here in Buenos Aires, we've been talking a lot about implementation. So we have different functions, budget, implementation units, which is the primary health care pathway, the caregiver package, the workforce metrics, data system, and subnational rollout. And so we really have to start measuring plans and monitoring plans, looking at this and understanding how different governments and countries are working and if there's minimum evidence that the plan is real. No? For instance, if we want to talk about budget protection, we have to see if there's really a dedicated line item and named purchasing and reimbursement mechanism, and so on. So a 24-month plan to impact agenda for ministries in the region would kind of look like this. So in the first 100 days, we would have to name the implementation lead and cell, cost the plan, protect the budget line, and choose 2 to 3 sentinel territories. In the next 8 months, we would have to embed dementia into the primary health care and older person pathways, launch caregiver support packages, and train frontline teams and referral hubs. In the second year, we would scale subnationally with adaptation, publish a dashboard and annual review, and refresh targets based on what is learned. And always on, we would have to co-design with people living with dementia and carers, use stigma reduction as an implementation strategy, and track equity by race, education, rurality, and income. So implementation science does contribute to all of this because it's a sequence for feasibility and learning, not just for political visibility. And we should avoid the common failure mode, which is launching nationally before the service package, workforce, and data loop exist in any territory. So this matters even more now because of biomarkers and new therapies, which are real implementation stress tests. What good is having treatment if people can't access it? Becomes an implementation question about pathways, eligibility, workforce, MRI, safety, monitoring, and equity rules. So therapy readiness is not a research test, it's an implementation test. So just to finish up, the bottom line, Latin America and the Caribbean do not simply suffer from a shortage of dementia plans. They suffer from a thin implementation design. ADI stage data shows the bottleneck is increasingly downstream. Financing, communication, delivery, architecture, data, and sustainment. The expert move is not only to count plans, but to start rating implementable functions, equity of reach, and learning capacity. Thank you.
Thank you very much, Diego, for those insights and perspectives and analysis of these tricky situations. I'm really pleased to introduce our next speaker, who is Professor Stephanie Debet, and she joins us virtually. Professor DeBet is a very distinguished stroke neurologist and epidemiologist. She has trained with wonderful people like Hugh Marcus and Sudha Shasderi, and she's now the executive director of the Paris Brain Institute, which, as you know, as many of you know, organized a wonderful World Brain Health Symposium earlier this year. So today, she's going to be talking to us about vascular brain health and integrated brain health approaches, a European perspective. Stephanie.
So I'll be speaking here about vascular brain health, and we'll be referring to some recent European initiatives around brain health. The vascular contribution to brain health is enormous and extends far beyond that of clinical stroke. Obviously, the contribution of clinical stroke itself is already huge, stroke affecting over 100 million people worldwide, representing the second leading cause of death and also the leading cause of disability. But beyond that, it is now widely recognized that the vast majority of dementia cases in the population are due to a mix of Alzheimer and vascular pathology, and vascular brain lesions also contribute to other neurodegenerative diseases as well as late-life depression, often in a treatment-resistant fashion. And I'd like to highlight here one particular vascular contribution, which is cerebral small vessel disease, arguably the most common vascular brain disorder. It is the leading cause of stroke, both ischemic and hemorrhagic. It is also the major pathological substrate underlying the vascular contribution to dementia, including Alzheimer-type dementia, also modulating response and tolerance to novel anti-amyloid therapies. But importantly, very often, cerebral small vessel disease is covert and detectable on brain imaging in the absence of clinical stroke or dementia. And the prevalence of covert small vessel disease is huge in the population, affecting over 400 million people worldwide, as is estimated. And it is associated with a considerably increased risk of stroke and dementia, therefore representing a major target for prevention and for improving brain health. And importantly, these covert small vessel disease lesions are now quite straightforward to detect and also to quantify. They have been defined through international criteria, here the STRIVE-2 criteria, and these white matter hyperintensities, now also cerebral microbleeds, perivascular spaces, and increasingly lacunes, can be detected in an automated way and in a quantitative way using increasingly machine learning derived methods that can also be used to monitor these lesions longitudinally. In addition, guidelines are now available for the management of covert small vessel disease lesions, such as the ones recently published by the European Stroke Organization, which in particular provide recommendations on how to manage risk factors and how to use anti-thrombotic drugs. Here, in particular, recommending effective treatment of hypertension and to refrain from using antiplatelet drugs because of the risk of intracerebral hemorrhage. There is obviously a strong evidence that blood pressure lowering and particularly intensive blood pressure lowering slows down the progression of white matter hyperintensity lesions. However, in older age, the percent of variance of these small vessel disease lesions that is explained by vascular risk factors is quite small. And what we are thoroughly lacking is a mechanism-based drug for cerebral small vessel disease, which is quite problematic given its major public health impact. Therefore, there is currently an urgent need to discover novel mechanism-based drugs for cerebral small vessel disease. However, the current drug development pipeline on the right-hand side is quite limited, very much in contrast with the AD drug development pipeline. So there has been increasing interest in exploring whether genomics can accelerate the discovery and development of drugs for cerebral small vessel disease, and this emerges from the observation that drugs with human genetic support are much more likely to advance through clinical trial phases and be eventually approved and be put on the market. And this can be particularly relevant for conditions that are highly heritable, that have a strong genetic contribution, as is the case for cerebral small vessel disease. And for this reason, we were recently commissioned with a large number of collaborators to draft a consensus statement and provide guidance on how to accelerate genomics-driven drug discovery and development for cerebral small vessel disease. Over the past years, through large international consortia, over 100 genes and proteins have been found to be associated with cerebral small vessel disease, and these have revealed biological pathways underlying this condition, such as, in particular, the extracellular matrix pathway, or more recently, also immune response pathways. And the combination of genomics with multi-omics and also, in some instances, experimental evidence has enabled to identify a smaller number of genes out of these over 100 with very strong triangulation of evidence, making them strong, compelling putative biotargets for cerebral small vessel disease, so targets for drug development. So this can be the development of novel drugs, but also the identification of opportunities for drug repositioning if genes associated with small vessel disease are targets for drugs that are already on the market or being tested in clinical trials for other indications. And this can considerably accelerate the drug development phase and also potentially enable more equitable access. However, a number of regulatory and especially commercial hurdles often need to be overcome, such as limited patent life, for instance. But they are quite promising yields. One of them is currently being investigated in several clinical trials, in particular, in this case, cilostazol. And these multi-omics studies have also revealed lifespan determinants of cerebral small vessel disease, indeed by showing that genetic susceptibility to cerebral small vessel disease appears to impact brain microstructure measured on diffusion tensor imaging, starting in early adulthood and even in childhood to a certain extent. In addition, genes associated with markers of small vessel disease actually appear to be enriched in genes that are predominantly expressed in fetal brain vascular endothelial cells, so during development, suggesting that susceptibility and resilience to small vessel disease may be determined throughout the lifespan. So one difficulty is that these genomic studies have largely been conducted in European ancestry populations so far. There have been huge efforts to try to enhance non-European contributions, which has been a little bit successful for stroke genomic studies, but much less so for studies on brain imaging markers of small vessel disease. And this is a problem because vascular brain health is a global challenge that requires global solutions, and we have to ensure that these findings are transferable to populations around the world. The incidence of vascular brain diseases, as shown here for stroke, for example, is particularly high in low and middle income countries where the severity is also greater. And this geographic distribution is actually inversely proportional to the density of MRI scanners in the world. And this lack of access to imaging is obviously not only a problem for research, but is also one of the main limiting factors for enabling access to prevention and care of brain. So related to that, there has been increasing interest internationally in low-field portable MRI scanners as an emerging opportunity for reducing brain health inequalities, and we have recently been engaging also in this direction, both through the Vascular Brain Health Institute in Bordeaux and more recently in collaboration with India through the Indo-French Center for AI in Health with the Paris Brain Institute. Obviously, advancing brain health requires strong international cooperation across sectors, across disciplines, across continents. And in that context, we were privileged to, together with the International Alliance on Brain Health and the CureND European Alliance, to host the World Brain Health Forum at the UNESCO House and at the Academy of Science in January this year, with about 1,000 participants, including 80 international world-class speakers from a scientific background, but also representatives of the leadership of the largest international organizations. And this ended with a roundtable discussion aiming for a framework for action that we are currently working on drafting. A very small summary of the event has been recently published in the Lancet Neurology. More recently, in April, in the context of the G7 that is hosted by France this year, The One Health Summit has taken place in Lyon, and a number of commitments were announced, amongst which one related to brain health, with the creation of a global One Brain Health Observatory dedicated to measuring the impact of environmental and social transitions on brain health, and again featuring the International Alliance on Brain Health and the Cure&D Alliance, together with the Paris Brain Institute, in relation with the World Brain Health Forum. And finally, the Academies of Science of the G7 countries, gathered under the S7 engagement group, have been working over the past months to provide recommendations on 3 scientific topics for the G7, and one of them is brain health, with the title of Advancing Brain Health, Including Mental Health for Global Societal Resilience, and these recommendations will be announced on May 19th. Thank you so much, and again, my apologies for not being on site, and wishing you a very successful conference. Thank you.
Well, thank you so much, Professor Debet. To conclude our session, we now have Mitchell Elkine with us, present in this room. Mitchell is the American Health Association's Chief Clinical Science Officer and serves as the Senior Staff Science Leader for all the association's initiatives related to stroke, brain health, and new integrated efforts, including cardio-renal metabolic health. So today in his lecture, he's going to address the role of cardiovascular leadership in global brain health. And we had a little conversation before coffee, and I told Mitch that I would introduce him as a really nice guy. And he said he's only sometimes a really nice guy.
Before the pointer, and you have 15 minutes.
Okay, thanks. Thank you so much, Christopher, for that great introduction. Appreciate it. And thank you to Facundo and Claudio for the invitation to me and the American Heart Association, which includes the American Stroke Association, to be here as part of this conference, which I've totally enjoyed. I know it's only been 6 months since we had the first one in Bern, and it's amazing how much progress this group has been making, and I look forward to the future meetings as well. So I'm going to talk from the perspective of a neurologist, a stroke neurologist, who works in a leadership position at a cardiovascular organization, and these are the topics I'm going to talk about. And I thought I would start with something that should be, I think, familiar to everybody in this room, right? Which is that the brain exists in the body. And that leads to a truism that we use all the time. We say that brain health requires health of the other organs. We know, as we've just heard from Dr. Debet, hypertension leads to strokes and dementia, and in fact, we can reverse that by treating hypertension as well, atrial fibrillation, cause of stroke, and so forth. This is all familiar territory to us, but what's less well appreciated is that what's good for the brain is also good for the heart. We know, for example, that mental health problems will lead to poor adherence to healthy lifestyles, worse nutrition, less exercise, smoking, and so forth. And so as a cardiovascular organization whose goal is to reduce the burden of heart attacks and heart failure and improve cardiovascular health, we can't achieve our goals if we don't account for brain health. So in fact, brain health is core to the mission of any cardiovascular organization, and certainly the American Heart Association. One thing that organizations like us can do is really to double down on those vascular risk factors that we've heard so much about and their importance in brain health. And we've developed something called Life's Essential 8, which has been tested and validated in multiple populations and really provides a simple way for the public to understand their risk factors, right? So it includes 4 key health factors: blood pressure, blood lipids, a healthy weight, and blood sugar, and then 4 behaviors as well. Don't smoke, eat a healthy diet, usually Mediterranean diet, and engage in plenty of physical activity. And the 8th item here, which I was really excited about because this used to be Life Simple 7, but then we added sleep to this as well, which is really the first brain-related measure to be included. There are others, of course, that I advocate should be included as well: stress, social engagement, depression, anxiety, and so forth. And so this is obviously an evolving area. But even with Life's Essential 8, what we see is that optimal health using Life's Essential 8 is associated with lower risk of, let's say, the big 3 brain health disorders associated with aging: stroke, dementia, and late life depression. And this is data from very large cohorts, UK Biobank, and all of us from the United States. Another thing that the cardiovascular community has been very good at doing, I would say, over the last several decades, is educating people about the importance of cardiovascular fitness, right? We all understand that apart from preventing heart attacks, there is something good about being more physically fit. You can enjoy your life better, go for hikes, lift a grandchild, whatever it is that you do in your life. And so we encourage those positive aspects of fitness as well, and that's become, second nature to most people, I would say. Can we do the same thing then for brain fitness? Can we use that experience of the cardiovascular community towards brain fitness in terms of emphasizing those positive psychological and cognitive traits that we recognize to be important: creativity, leadership, social engagement and activity, and so forth, resilience, and so forth? And if we can measure those attributes, then perhaps we can also test and see whether there are certain things that could be done, crossword puzzles or some other intellectual activity perhaps, that would train the brain just like we train the body to be more fit. One thing that the cardiovascular community has been good at doing is building these kinds of alliances of organizations. So in the United States, there's something called the Physical Activity Alliance, which focuses on one of the most important risk factors, physical activity. And their goal is really to lead efforts to create, support, and advocate for policy and systems changes that support active living for everybody. And the Heart Association serves as a leader of this organization, but there are many organizations that are part of it. And you can see listed here organizations like sports organizations and Lifestyle Medicine Academy and Sports Medicine Academic Association, and so forth. So these are not organizations that we might typically think of going to with our brain health, or for that matter, cardiovascular interests, but they are great allies in tackling some of these problems. And they have a national activity plan. We've heard about dementia plans and brain health plans and sleep plans. There is a national activity plan in the United States as well. It involves, again, policy and systems changes, as well as professional development activities. Another paradigm that's been very successful in the cardiovascular community is that of early detection of heart disease, right, before somebody presents with an acute MI. And so nowadays we measure coronary artery calcium. We can measure intimal medial thickness. We measure lipids. We barely think about that at all, in order to identify people who are at high risk before they're even having symptoms, and then we can treat them and hopefully avoid the clinical outcome events. Well, the old paradigm for brain health is very similar to the old paradigm for heart health. Wait till somebody develops memory loss and then try to fix it. But of course, we're beginning now also to move towards this idea of early detection based on biomarkers, and then treating people with medications where possible, or with lifestyle change in order to reduce their chance of cognitive problems long term. And I remember when I used to go to meetings several years ago, and people would talk about the fact that Alzheimer's begins 20, 30 years before the clinical symptoms come on, and that in order to be effective, drugs would have to start decades before the symptoms begin. And people said that as if it meant, there was no way we'd ever be able to do it. But people take statins for 30, 40 years in order not to have a heart attack. So we just need to change people's way of thinking about this, and the cardiac organizations can help with that. One way in which they have really dived deep on this is these risk prediction algorithms, right? So if you go to see your primary care doctor, in the United States at least, they will calculate or estimate your risk of having a cardiovascular event, give you an absolute risk of that over the next 10, 30 years, and then that's used to determine whether you should be on lipid lowering or other therapies. And we actually recently developed a new risk calculator called Prevent, which was based on over 3 million individuals from electronic health record data and then validated in another 3 million separate individuals. So heavily validated. It's very different from the old ASCVD risk predictor, which was based on epidemiological observational cohorts of 20 or 50,000 individuals, so huge amount of data, well validated, uses predictors including kidney disease, which wasn't included before, and looks at total cardiovascular outcomes, including stroke, as well as heart failure, which was new also. And then the models, interestingly, predict out to 30 years and are relevant to people ages 30 to 79, and they don't include race anymore. Instead, they substitute a measure of social determinants of health. And then your clinician can look up the results online and deliver them at the bedside. And when I went to see my primary care doctor last time, they did exactly that and were able to make recommendations. And it's all based on these actual absolute risks of having an event over the next several years. So we can predict disease based on these risk factors, tell people what their risk is. We have that science now, but we then need to take the next step and do implementation. And so we have a number of programs at the Heart Association, other organizations similarly. We use our Get With the Guidelines programs, right? So we put out the guidelines, and then we can measure how well hospitals are actually implementing those guidelines. You can see we have over 14 million people enrolled in one of our 5 registries of Get With the Guidelines. The largest registry, in fact, is our stroke registry, which has over 10 million people over the last 20 years and has been shown to reduce disparities in care. It improves clinical outcomes, and it improves the quality of care as well. So an obvious question then is, why can't we have registries for migraine, traumatic brain injury, dementia, and other conditions as well? The final reason I'll say for the role that cardiovascular organizations might play is just resources. I don't know how many people here are familiar with Willie Sutton, if that name means anything to you. Willie Sutton was an American bank robber in the 1920s and 30s, and he used to get arrested over and over again, and the police would say, Willie, why do you keep robbing banks? And he said, well, that's where the money is, right? And the same thing is true of cardiologists and cardiology organizations. So here it's really hard to see it because of the size. But basically, it turns out that most deans of medical schools, and this includes not just the top dean, but everybody in their cabinet, dean of education, faculty affairs, and so forth, most deans come from internal medicine, and most of those internal medicine doctors are from cardiology. It's actually not most are from that, but the highest represented specialty is cardiology. And you can see that that's neurology and psychiatry, have a very low representation among school deans. So if we want the resources, we got to talk to the cardiac folks. And what that means then is that we get resources, and so the Heart Association has been able to fund over $6 billion since 1949, and we have thousands of awards, many reviewers involved. We've been able to fund more than 3,000 stroke-related awards, over $500 million. And in fact, our research funding goes to heart, stroke, or brain health. And so one reason that I was really excited to be able to come to this meeting is just to make a plea to the brain community. Like, my job at the Heart Association is to get neurologists, psychiatrists, psychologists, people from the brain community to apply to the Heart Association. It says we will fund research on brain health as well. It's not just stroke anymore. So I encourage you to apply, especially if you're in the United States. A little trickier here in Argentina, but you can also come to the US and work there with somebody and get funding. It also means that we can fund advocacy efforts, right? So we have advocacy teams in the federal government. Each of our state governments, we're the only organization in the US that has only health organization in the US that has lobbyists in every one of the 50 state capitals. We have them also in local markets around the country, and then we have our global advocacy efforts as well. And so we're then able to create this kind of virtuous cycle where we fund research, We write the guidelines then lead to advocacy recommendations, and then that finally results in legislation. And finally, we have one other initiative recently that's worth knowing about, which is our venture fund. So although we are a nonprofit, we do have a venture fund which includes several different sub-funds which fund research on, again, heart, stroke, and brain health. And we look for startup companies. And the first company that our Go Red Fund, which is focused on women's health, funded is a startup called Neura Health, which provides rapid access to neurologists for care of patients with migraines. And so I encourage people who are looking at startups to consider us. We actually do provide funding to startups internationally. They don't have to be in the US. So we can talk about that more at another time if you'd like. And so I will end there and just thank you for the opportunity to talk with you all about the, again, I'm a neurologist. I'm part of this crowd, but my goal is to leverage what the cardiology community has for the benefit of brain health in the future. Thanks so much for your attention, and look forward to chatting. Stay up? I should stay?
Yes. So I invite Diego and Christopher for the question. You are the co-chair. So there is a question. There is only one question, so but you can have it. You are the guest. So Claudio.
Mitch, thank you for the great talk. I have one question. I mean, there are 0 neurologists as deans. If I saw that in Switzerland, 2 of the 5 deans of medical faculties are neurologists. So how do you explain the fact that neurologists are not selected or not interested?
Yeah, and you are a perfect example of one of those neurologists who's a dean in Switzerland, so that's terrific. I think, again, it probably has to do, again, with resources. In the United States, the way healthcare is funded is pay for service, right? And 20, 30 years ago, the cardiologists started doing interventional procedures, paid a lot, they were bringing in a lot of money, and I think that's where it comes from. And it's really exciting to see the changes in neurology, neuroscience, stroke, for example, where the equation is changing back a little bit, perhaps. I think that's why there's so much enthusiasm around brain health now.
So I know there is no more time, but I will do the last question. How do you think, because when we see the story about air prevention, cardiovascular prevention, is a quite success story, even if there is a lot of cardiovascular risk. But what do you think that we can translate or transfer some of what has been achieved from the cardiovascular field in the dementia, in the brain health field, and how do you think also we can try to understand people that the interlink between the heart and the brain?
Yeah, do you want to take that? Yeah.
Well, I think that there's lots of lessons to be learned, and now that dementia has been officially recognized as a non-communicable disease, I think there's lots of links between the heart and the brain. And so we really have to think maybe on a regional level, but I always say that we have to be very aware, because lots of people are talking about making regional plans or sub-regional plans, and I would be a little more pragmatic on this, and I would think, what is working, what are the best practices in the region, who is doing things that are doing really well, and just try to implement that in other countries, adapting, to country context. I would kind of steer away from doing these regional plans, because we already have a global plan. We already have many national plans. Why are we doing so many plans? Just recently, we were told that the Mercosur is doing a regional Mercosur plan. for dementia, which is, I mean, it's great, and it's great that we can put it on the public agenda, but we really need to start implementing things that work. And I think we can see that in the heart sector, there's lots of things that have worked, so why don't we take some of those lessons and do it with dementia and Alzheimer's?
And just quick follow-on comment, I agree with everything Diego said. And part of that, I think, is simplification. It's just making things simple, not overwhelming people with information. And I know some of the folks in the US who've been interested in this, like John Roseanne, for example, instead of referring to brain health, he actually talks about brain care. And an emphasis has been on not telling people, even like I showed you 8 things people should do to be healthy. You don't want to come to people and say, here are 8 things to do. It's overwhelming to most people. We get it, but they don't. So instead, encouraging, choose one thing. You know, that's what some programs are doing now. Choose one thing. Let's just work on that. We have success there, then we can introduce another one. So it's, you know, it's getting people who understand psychology. Maybe final point I'll make is we think about brain health as being about, you know, dementia and all these neurological disorders. I would say that brain health should also include behavior change, right? We're trying to get people to change behaviors. That is brain health. And again, that tells us that the cardiologists can't achieve health for, you know, what they need to do without incorporating, you know, an understanding of behavioral economics, the neuroscience of decision making, and therefore brain health as well.
So I think we are on time. So see you later after lunch. Thanks a lot for the talk.
Okay, moving forward with our program, it is a great honor to introduce our next speaker, who is Argentinian, is living in Switzerland, and is showing us live on a stream today. We are privileged to have Deborah Ketzel, Director of the Department of Mental Health and Substance Use at the World Health Organization, with over 25 years of international experience in implementing public health policies. She has been a leading voice, she is a leading voice in transforming mental health system around the globe. So, hola, Deborah. Can you hear me? Hola, Deborah.
Facundo, yo si me estás escuchando te veo, pero no escucho lo que dicen, así que no sé si tengo que empezar, si me escuchan o no. Si haces un gesto con la cabeza, ok. Esa es una señal positiva. Ok. Bueno, imagino que me habrás ahí está, ahí escucho el mensaje. Bien.
Okay,
imagino entonces, Facundo, que me habrás presentado.
Can you hear me now?
Escucho el audio de la sala. Esto sería bueno si me pudieran hacer escuchar.
Can you hear me now?
No sé por qué.
No?
Pero me veo, ahora me estoy viendo.
Can someone write to her that we already gave her a great presentation? Okay, Karen is writing to you and saying that I gave my best presentation ever.
Ok, y como estamos entre lo que voy a decir y el almuerzo de ustedes, mejor empiezo y voy con mi presentación. Ok, de acuerdo. Entonces, muchas gracias, Facundo, por la introducción, imagino, y muchas gracias. Oh, sorry, and I need to switch to English. Thank you very much, then, for that introduction, and thank you for the invitation, Claudio Bassetti and Facundo Manes, who kindly invited me to be in person, but unfortunately, it has not been possible to travel. And as usual in these cases, I don't know what has been discussed before, except in the last couple of presentations. So I hope that what I'm about to say is relevant to all of you, and it's a bit grounding or trying to present something that is grounded on concrete life of people. That is perhaps what we do in WHO. So I hope that you see now my presentation. I'm counting on Karen to tell me. Yes, okay. And so what I wanted to present to you is a bit then from the perspective of the World Health Organization, what are the integrated approaches to mental health and brain health, and the roadmap for action that WHO has developed. And I will try to continue with all this idea of integrating between the different areas that we also just heard about, right? And what is more important, as I was saying earlier, is what countries can do with this integration. I'm trying to see how to move the slides here. Give me a second, and probably is here. Yes, okay. Yes, I'm here. Then, again, apologies if you already heard a lot about this, but what we know is that the global burden of neurological disorders is significant. We are talking about 3.4 billion people affected with neurological conditions, and 11.8 million deaths due to those conditions. There is a huge inequity. The burden is concentrated in low and middle income countries. Up to 85% of dailies are occurring in low and middle income countries. And of course, systems are and resources. We just heard a lot of funds available for the US context, but globally resources are obviously lagging behind. And another inequity that is clearly related to the resources is that there are a very limited neurological workforce available. The gap is huge. There are 2.7 neurologists per 100,000 people in high-income countries versus 0.03 neurologists per 100,000 population in low-income countries. So that means that there is no way to meet the needs of people with business as today. So we know on one hand that threats are growing and needs are increasing, but the policy response hasn't matched that burden so far. So let's look a bit quickly at the mental health conditions from a global burden perspective. And we know that mental health conditions are common. More common ones are depression and anxiety, and we are talking about nearly 1 in 7 people globally living with one of those conditions. They are long-lasting, and they are absolutely under-resourced as well. So in mental health, we talk about the triple gap. We talk about conditions that are under-treated, or people that do not have access to the treatment that they would like to have. The area is absolutely underfunded, and you can see there in the diagram the 1.4% of the health budget that is allocated to mental health. And we know also that most frequently than not, this area of work is completely outside of broader, bigger health reforms that may take place in a country. And as a result, 71% of people with psychosis, 71% of people with psychosis do not receive service. And I repeated it because we know how disruptive psychosis can be for the person, for the family, for the community. And still, 71% globally do not receive care. And the budget that we just said. So the idea is, can we afford keeping these areas separated? Is this what we need to look forward to, or is there a way of integrating in a better way all these needs and situations. We developed a few years ago, the WHO position paper on brain health. This position paper provides the definition that WHO came up with support and contribution from many colleagues, many of you in the room, I'm sure, that in a way says brain health is considered brain health as a functioning across domains over the life course with or without disorders. And you have it there. Brain health is the state of brain functioning across multiple domains, allowing a person to realize their full potential over life course, irrespective of the presence or absence of disorders. So why this matters? Because there are different terms being used, and this creates fragmented services and policy gaps. That is again what we try to avoid. So what we are trying to do as WHO, working with all these almost 200 countries, is let's bring together shared definitions and try to work together towards achieving common goals, common targets, and not just continue with the fragmentation. In this context, WHO has a mechanism that is called the Strategic Technical Advisory Group. I'm trying to remember the acronym, that advised our Director General on technical issues. And in order to come up with some conclusion, we convey experts in an open process from all fields of interest, and then there is a selection of those experts that then for 2 years will work on a given issue, a given question that we need answer for. And so last year we finished a round of the STAG of 2 years, and one of the conclusions or the outcomes of that effort was this framework, where we were asking to the experts coming from the field of neurology, brain health, the field of mental health, and the field of substance use, saying what is common, what can we do as a common framework for all these areas that we call MNS, mental, neurological, and substance use conditions. And in that context, and thanks to those inputs, we developed an integrated public health approach to or across mental, neurological, and substance use conditions. And you see in this figure that MNS conditions shared common causes and characteristics, common determinants, neural pathways, comorbidities, and stigma, huge for all three of them. They also share common needs and challenges, poor awareness, limited access, human rights violations, limited budgets, scarce workforce, but also common strategies to address the issue, right? Biopsychosocial approach, promotion and prevention, treatment and recovery, policies and programs. So we are, from keeping this in mind, we focus on primary care capacity together with joint advocacy of the different areas and integrated country support that will focus on universal health coverage. We want these areas to be part of a health system in any given country or area. And then the solution is not more programs, vertical, but is how do we connect what already exists into something that helps those in need to get the answer they need, and with the resources that are available, not only a model for the rich countries, basically. So the principles in this framework are that we want to highlight here are the person-centered, rights-based, equity, life course, biopsychosocial, lived experience, multi-sectoral, and the areas of work are leadership and governance. I heard the previous comments about the need for policies, for plans, etc., but also for a system that holds all those areas of work. Then services that will provide the direct answer to those in need, promotion and prevention, because we need to avoid and prevent whatever is avoidable and preventable, and an information system, evidence research that will inform all of the above, right? So that's what we are trying to promote for all these areas. We, as WHO, we have what we call global mandates. That is when ministers of health from all our member countries come once a year to WHO, to Geneva, this is in a couple of weeks now, and tell us what are their priorities and what do they want us to work for. They are asking us to develop a technical area of work that they will endorse and will try to implement later on at country level. And these are the global mandates that we have in this area of work that we are talking about. We have the oldest one is the one on mental health, an action plan on mental health in 2013. Then we have the one on dementia in 2017. Then we have two in the same year, 2022, one on intersectoral global action plan on epilepsy and other neurological disorders, and the other one, the alcohol action plan, and more recently, meningitis roadmap. So we need to work with all these. Countries need to work with all these. So again, what do we do to make sure that, other than setting targets, that countries find ways to achieve those targets and get, again, closer to what people need. As an example, using one of these action plans that I just mentioned, we have the neurology roadmap for action, and we have a vision that clearly states brain health as a value protected area, and the disorders that can be prevented and treated. People and carers need to be supported with rights and autonomy. That's a bit common in each one, with a specific, of course, of each one of those areas. And then we have the way to get there, right? From prevention to early detection, to treatment, to rehabilitation, palliative, and caregiver support, depending on the area. And this, again, is repeated with specific targets, that is what, and indicators, what helps countries move ahead, moving forward towards that. Now, I just heard earlier that it was mentioned, now that, for example, dementia is considered an NCD, and it makes me a bit smile, right? Because we know that dementia is not a communicable disease, which means that it's a non-communicable disease, right? But the reference was to this, what happened last year, and is that in the context of the UN General Assembly, there was a high-level meeting on NCDs and mental health, and there was an endorsement by big majority of countries, with the exception of two. Every other country endorsed this political declaration, and the political declaration highlights the areas that are relevant for countries, not just in the health sector, but above the health sector, for governments altogether. What are the areas that they need to work on? And in that political declaration, there is a clear mention to mental health. Mental health in general is heavily present in the political declaration, and then neurological disorders are also specifically mentioned. Here you have the names of the dementia, stroke, Parkinson's disease, and epilepsy, but also autism and ADHD. Others are mentioned, whether it is in the recognition statements or in the commitments for action. The political declaration calls for 3 main targets to achieve by all countries by, don't remember anymore which year, but in years to come. And one of those 3 is, one is on tobacco, 150 million people not smoking, so less 150 million people smoking. There are also 150 million people in other non-communicable diseases, but what is important is that we are talking about 150 million more people with access to mental health care. So in a way to say, mental health is one of the 3 main targets that the political declaration has incorporated, but then there are many other process targets that need to be drafted and that we are working on in order, again, to make them implementable and achievable by member states. And more information is available if any of you would be interested, of course. So as I was mentioning before, we work in WHO in order to make sure that we support countries to achieve those, not only a target, but to produce the changes that they need for people in their own context, in their own countries. And we work through different elements. So we try to translate the global commitment to operational change at country level. We will try to land those commitments to country level, and we work in these areas that are here listed: leadership and coordination, health system strengthening, norms and standards, and the whole research is there, obviously a priority, then capacity building, research and data. And I will give you some examples of the way we do that in some of these areas. One is we developed some years ago the WHO Special Initiative for Mental Health that has, at the time, it was launched in 2019, right before COVID, but the goal was to reach for 100 million more people with access to mental, neurological and substance use services. And last time we measured, I don't have the number here in the slide, but we were around 90 in a few years, working only in 10 countries. So what I'm trying to say that once there is a commitment from a government to transform the services in order to answer to the needs of people, those numbers are not so difficult to reach. It is doable, it is feasible, even in low-income settings with different strategies, of course. And the issue is that from WHO, we can't be in every country providing the same support, but we are zooming in, as one would say, in some of the countries with implementation support and not just the policy guidance to show to other countries what kind of changes are needed and how that can be possible for all. And the impact, as I was saying, is huge, and we have different countries working on different elements, from policy and governance reform, new legislation, new plans developed, but also what is the most powerful tool is the integration of mental, neurological and substance use conditions into primary health care and general health services, but also in special programs with HIV, with maternal health, in emergency settings, as well as in health insurance schemes, benefit packages for people, so part of the universal health coverage approach. And in all that, we have been working, and we are working very hard trying to strengthen national health information systems, because we need to know what countries are doing. They need to know what they are doing in order to do more and better. So in a way, what we are trying to say here is not just a single project or initiative, but rather approaches that help transforming the system. Mostly the health system, but not only, because implications are all over, but also ensuring that there is continuity and sustainability. It's not a one-off intervention, but is a long-lasting initiative. And some examples from other countries, we have here a couple of countries showing, for example, the importance of national plans. It was mentioned also earlier. Not too many, but not too little. Why national plans are important. And I have here in the slides the one on South Africa, but also on NCDs that includes neurology as well, but also the brain health strategy in Norway, and I was recalling that also Switzerland, right, was recently working on that. So we try to encourage replication in a way using similar principles that are in the global action plans in each one of these areas, and translating them into the local reality, so that there is, again, no need to reinvent the wheel every time. Other example or other important area of work is the health workforce development. We are working, because we know that this is very frequently a bottleneck, and there is the limited number of specialized professionals, whether they are neurologists or psychiatrists or psychologists, and then is everything stuck there because people in need don't have where to go to. So a big effort has been from 15 years probably, the shifting of some of the tasks, sharing some of the tasks from the specialized level to a non-specialized level. And we have a tool that many of you may have heard about, is MHGAP, and it has been used in more than 100 countries. It's translated in many other countries, languages. I'm running and I'm making mistakes in what I'm saying, so I'll slow down, but it covers main mental, neurological and substance use conditions, and conditions for those areas that there has been evidence of treatment available. And so we are also right now have finalized the completion of the MHGAP e-learning in the WHO Academy that is available for access for anyone who might be interested. And there are standardized trainings that can be replicated and combined with in-person exchange that we know in these areas is very important, right? Real case discussions, etc. Another area that is very important in our field is and is part of the health system strengthening, is the issue of access to medicines, because many neurological conditions are treatable, more neurological than other of these conditions are treatable with medicines, but access is often scarce, even when the medicine is not necessarily expensive, right? So there are issues, systemic issues in terms of availability, affordability, supply chains, and guideline alignment. So we used what we call tracer conditions. We started with epilepsy and Parkinson's disease, and a entry point to see how we can transform the system. And now we are working also on with psychosis and depression and bipolar disorder in some countries, and we are working very close to some of the areas in the non-communicable diseases to see how we support countries, including these areas with job aids, with updating essential medicine lists by countries, what kind of training is needed at primary care, what administrative implications are there in order to make sure that the medicines, the medicaments are available at primary care level whenever it's feasible, not anything at any case, right? So this is another area of work that we are following. And I think that what is important is that from our perspective, is not one area, obviously, that can do it all. No single actor can deliver integrated brain and mental health at scale, right? And we think that people with lived experience should be at the center of whatever it is that we are trying to do here, and the different stakeholders can play different roles working together towards these shared common goals. There is still a big silos kind of approach, and we need to be able to put our egos aside and to work together in order to achieve these goals if we want to see any change in the near future. So, I was running, but I think it is important I leave you with this slide, because you can see some inspirational quotes on what brain health means to people. So thank you very much, and on behalf also of the billions of people around the world that are affected by MNS conditions. Over to you, except that I don't know if I hear you, so maybe no questions and you go directly to lunch. Thank you. I will remove this presentation.
So, Deborah, can you hear us now?
Yes, I can. Yes, I can.
Oh, what a relief. Okay. We have a few minutes for questions. I don't know if someone have a question. Okay, I have a question. So, Deborah, fragmentation remains a major barrier. What does an integrated approach means in practice, and how countries realistically achieve it with the existing brain health system or health system? Hello?
Thank you, Facundo. Yeah, no, I was thinking because I'm listening in Spanish and I would like to answer it in Spanish.
Oh, en Spanish. ¿Cómo hacemos los países pobres para
no,
aplicar
no.
todo lo tuyo?
Gracias. Cambiemos, por favor, que no tengo muchas ocasiones de hablar en español.
Okay, let's switch to Spanish. Hablamos
you.
en español.
Gracias.
Entonces, con esta fragmento, ¿entendiste la pregunta o te la repito?
La entendí.
Perfecto.
Es un poco esto lo que traté de presentar en estos minutos, ¿no? Cómo la salud del cerebro, la salud mental y el uso de sustancias están interconectadas a lo largo de la vida y comparten factores de riesgo, suceden simultáneamente. Frecuentemente encuentran respuestas por los mismos trabajadores, particularmente, como decíamos antes, en sectores de bajos recursos, ¿no? Donde no hay un especialista por cada una de estas disciplinas a la mano. Entonces, si no logramos esa integración, estamos limitando la posibilidad de acceso, estamos limitando la posibilidad de que un mismo trabajador dé respuesta a la persona en diversas condiciones que impactan en un mismo momento, ¿no? A un mismo tiempo. Como ven, mi español a veces no es tan fácil. Entonces, una de las estrategias importantes, nuevamente lo dije en algún momento en una de las diapositivas, es la integración en atención primaria y en servicios generales. Yo hace 35 años que trabajo en salud mental y siempre me pregunté por qué un obstetra nunca jamás se preocupa de la salud mental de la mujer que tiene delante, o por qué alguien cuando tiene un problema, un accidente de tráfico, no le preguntan cómo está o cuánto esa situación le ha generado estrés, etcétera, etcétera. Tenemos cantidad de ejemplos que cada uno de nosotros podríamos mencionar. Entonces, lo que estamos tratando de promover es esa integración a nivel de atención primaria, a nivel de servicios generales, pero luego también a nivel de los servicios en la comunidad, que puedan manejar también distintas condiciones a partir de de compartir ese conocimiento y técnicas que puedan ser usados a ese nivel de atención. No estamos pretendiendo que un profesional no especializado pueda dar una respuesta altamente sofisticada como la que puede dar un especialista, un neurólogo, un psiquiatra, pero hay una cantidad de situaciones y de condiciones que no requieren ese alto nivel de especialización y que pueden encontrar respuesta en un nivel de atención primaria. Estamos ahora enfrentando a lo mejor no es la palabra, pero estamos a diario escuchando y en contacto con cantidad miles de aplicaciones, por ejemplo, que aspiran a dar respuesta a algunos de estos problemas. Está todo el tema de la inteligencia artificial. Bueno, ¿cómo manejamos eso a un nivel concreto que pueda estar coordinado y supervisado de algún modo a un nivel comunitario, que luego encuentre la especialización al nivel más alto, probablemente más lejano, probablemente físicamente, digo, a mayor distancia, con mayores complicaciones y costos y dificultades de acceso, pero que pueda a través de un intermediario, a veces tal vez, poder encontrar respuesta. Creo que cuando empezamos a trabajar en esos países de la iniciativa especial, empezamos a ver eso, que bueno, que sí que es posible lograr una mayor casi que infiltración en un sistema de salud comunitario de estos temas, para que de ahí puedan ir elevándose a los niveles de complejidad requeridos, ¿no? Y nosotros es como que empezamos al revés en estos ámbitos de salud mental, de salud del cerebro, etcétera. Empezamos casi que del tercer nivel para abajo. Empezamos del nivel más complejo y sofisticado hacia un nivel más generalizado y accesible para todos. Bueno, a lo mejor algunos ya lo están haciendo hace muchos años, hace décadas, pero a nivel global creo que es tiempo de revertir esa situación y mirar las cosas desde otro modo. Así que eso es lo que estamos tratando de hacer y promover, y esperemos encontrar muchos adeptos entre quienes están en la audiencia.
So we have a question from Matilde here.
Yep.
Hi, Deborah Matilde Leonardi here in your country, but sharing the common Italian love because you've been also working in Italy for a while. My question is concerning the issue that you also say that mental and neurological disorders is 40% of the total burden of all diseases. How can the international community that is so concerned for the problem support WHO in ranking higher the brain health and the mental health? Because with the restructuring of WHO, we do think that you need also external pushing. And how can, your suggestion, how can the international community really be represented with this issue within WHO, where we do see that our issue is not as relevant as others? So we have 40% of the burden, but we don't have the 40% representation in a sense of the efforts of not yours, but of the big policy of WHO. What do you think that we should do to support WHO to put mental and neurological disorders in the right place where we do think the attention of policy should go?
Grazie Matilde, thank you for the question. And many of you know that until less than a year ago we had a Department of Mental Health, Brain Health and Substance Use, but right now that department has merged with the Department of Non-Communicable Diseases. So we kind of lost the autonomy of the area. I think that the way to support or to promote visibility within WHO and then globally reflecting that attention is through the member states, through the countries, through your governments, through your ministers of health here and speak. They will come here now. Sorry, I'm not. Yes, here. Confused. In a few weeks' time, they will come here to Geneva and they will talk about these issues. So that is the moment when member states can loud and clear say, this is relevant, this is important, this has occupied right now a big portion of the political declaration on UN, on NCDs and mental health, and therefore it has to be translated into also equal attention at WHO, not only in Geneva, in HQ, but also at the regional level, also in every country office. The academia can do the same by reinforcing and working with us on what we are trying to promote, and by acknowledging and recognizing that this is a strategy that has a value also by those who do the research in their own institutions. Because if we want that research to translate into something concrete, again, we can be a means to achieve that or to facilitate that. So I think that is the way, is by, the third element is that, as you know, because many of you have been here during the World Health Assembly in May, in a few weeks, there are plenty of side events that are called, and more, some of those side events are on mental health and brain health and substance use. And that's another way to call for attention, because ministers are invited to come and speak in those events, and by being invited, they have to learn what's going on in their country, and they have to talk about that, and they have to make commitments about that. So that's another strategy that is a combination of what you do at home, which is your science or your practices, depending on where do you sit, and a component of advocacy. Both have to come to that level, central level, to speak up for the area. Advocacy and science, when together, I believe they can change the world and how people live in this world, particularly for those affected by these issues, of course.
So, Deborah, we thank you for your time, for your great talk, for your patience, and also I have to say that we are ashamed that we don't have relation with the World Health Organization, but we are going to fight to have you back in Argentina. Thank you so much.
Gracias a ustedes.
So we have a break. We have a break for lunch, and we are going to be here at 2 p.m. Thank you. We have 15 minutes more, 2:15.
Vale, pásame el programa de la lapicera. Ay, qué estrés. Qué estrés. But when something that you have already proved and don't work, and you start to... Okay.
Lo que pasa es que mi hijo está viviendo con mi papá porque me prometió que lo cuidara y lo está cuidando. Perdón, no está enfermo. Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de contarle la vuelta todos los días. Qué cagazo, nos haces pegar, ¿no? Nos estoy buscando hace 2 horas. Vamos para casa.
Okay, okay. Okay, can you open it just so that let me around there? Okay. Up.
Me tengo que ir.
Sí, pero tenés que comer algo. A ver cómo se yo ya vuelvo.
Fresco afuera.
Tengo que ir ahora. Vamos.
A las 8:15 cuando retomaron y a las 2.
Es mi deber.
Me tengo que ir ahora.
Entonces vamos.
Esta pelotita de tenis puede generar un montón de cosas.
Puede hacer que todos se rompan las manos aplaudiendo.
Puede hacer que estalle la tribuna.
Puede generar un grito ensordecedor.
Pero también puede traer calma.
A la mitad de los niños con autismo, el sonido del mundo los lastima.
El sonido de una silla que se arrastra a ellos les molesta 10 veces más.
100 veces más.
1000 veces más.
Pero podemos dar vuelta a este partido.
Con 4 pelotitas de estas puestas debajo de una silla, en las patas, podemos silenciar ese ruido.
4 pelotitas.
4.
4.
4. 4. Así que si tenés pelotitas viejas,
Que ya no usás.
Que ya no pican.
O con las que tu perro ya no juega.
llévalas a clubes,
Canchas.
O escuelas.
Para que vuelvan al juego dentro del aula.
busca puntos de recolección en www.fundacionineco.org.
Cada pelotita suma.
Démosle pelota al autismo.
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 ¿Y este quién es?
Papá, soy yo. Enrique, ¿no me reconoces?
Yo vi una cara conocida, pero no me acuerdo de dónde.
¿Desde cuándo te importa el abuelo? Vos si se puede saber.
Sabés, si no le
Estás todo el día viendo la televisión.
Vamos a ir a buscar sus cosas y lo vamos a internar.
¿A quién van a internar?
¡A vos!
No, nos vamos para casa.
Sí, soltá, yo no le conozco. ¿Qué haces?
Arrancalo por la buena, te lo digo.
¿Qué pasa?
Mi hijo está viviendo con mi papá.
Pianta,
Porque me prometió que lo cuida y lo va a cuidar y no lo está cuidando.
Perdón, no está enfermo.
Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de encontrarle la vuelta todos los días. Qué cagazo, nos haces pegar, ¿no? Nos estoy buscando hace 2 horas. Vamos para casa.
Sí, estoy descargando lo que faltaba. Sí, me falta la última presentación que mando por celular, no puedo editar. ¿Eh? Sí. Ah, ya la cargó. Ah, listo. Esperá que estoy descargando el de Batia. Sí, como la de ayer, para preguntas. Sí.
Me tengo que ir.
Sí, pero tenés que comer algo. Al conocer yo ya vuelvo.
Está fresco afuera.
Tengo que ir ahora.
Vamos.
Es mi deber.
tengo que ir ahora.
Entonces vamos.
Esta pelotita de tenis puede generar un montón de cosas.
Puede hacer que todos se rompan las manos aplaudiendo.
Puede hacer que estalle la tribuna.
Puede generar un grito ensordecedor.
Pero también puede traer calma.
A la mitad de los niños con autismo, el sonido del mundo los lastima.
El sonido de una silla que se arrastra a ellos les molesta 10 veces más.
100 veces más.
1000 veces más.
Pero podemos dar vuelta a este partido.
Con 4 pelotitas de estas puestas debajo de una silla en las patas, podemos silenciar ese ruido.
4 pelotitas.
4.
4. 4.
4. 4. Así que si tenés pelotitas viejas
Que ya no usás.
Que ya no pican.
O con las que tu perro ya no juega.
llévalas a clubes,
Canchas.
o escuelas,
Para que vuelvan al juego dentro del aula.
busca puntos de recolección en www.fundacionineco.org.
Cada pelotita suma.
Démosle pelota al autismo.
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 ¿Y este quién es?
Papá, soy yo. Enrique, ¿no me reconoces?
Yo vi una cara conocida, pero no me acuerdo de dónde.
¿Desde cuándo te importa el abuelo? Vos si se puede saber.
Sabés, si no le
Estás todo el día mirando la televisión.
Vamos
no
a ir a
haces
buscar sus cosas y lo vamos a internar.
¿A quién van a internar?
¡A vos!
No, no. Nos vamos para casa.
Sí, soltá, yo no le conozco. ¿Qué haces?
Arrancalo por la buena, te lo digo. Lo que pasa es que mi hijo está viviendo con mi papá. Porque me prometió que lo cuidara. No le eché la está cuidando.
Perdón, no está enfermo.
Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de contarle la vuelta todos los días. Qué cagazo, no sé pegar, ¿no? Lo que estoy buscando hace 2 horas. Vamos para casa.
Me tengo que ir.
Sí, pero tenés que comer algo. Para con ustedes, yo ya vuelvo.
Fresco afuera.
Tengo que ir ahora.
Vamos.
Es mi deber.
Me tengo que ir ahora.
Entonces vamos. ¿Vamos caminando?
Esta pelotita de tenis puede generar un montón de cosas.
Puede hacer que todos se rompan las manos aplaudiendo.
Puede hacer que estalle la tribuna.
Puede generar un grito ensordecedor.
Pero también puede traer calma.
A la mitad de los niños con autismo, el sonido del mundo los lastima.
El sonido de una silla que se arrastra a ellos les molesta 10 veces más.
100 veces más.
1000 veces más.
Pero podemos dar vuelta a este partido.
Con 4 pelotitas de estas puestas debajo de una silla en las patas, podemos silenciar ese ruido.
4 pelotitas.
4.
4. 4.
4. 4. Así que si tenés pelotitas viejas
Que ya no usás.
Que ya no pican.
O con las que tu perro ya no juega,
llévalas a clubes,
canchas
O escuelas.
Para que vuelvan al juego dentro del aula.
buscá puntos de recolección en www.fundacionineco.org.
Cada pelotita suma.
Démosle pelota al autismo.
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 ¿Y este quién es?
Papá, soy yo. Enrique, ¿no me reconoces?
Yo veo una cara conocida, pero no me acuerdo de dónde.
¿Desde cuándo te importa el abuelo? Vos si se puede saber.
Sabés, si no le
Estás todo el día
interesa,
viendo la televisión.
vamos a ir a buscar sus cosas y lo vamos a internar.
¿A quién van a internar?
¿A vos?
No, no. Nos vamos para casa.
Sí, sí, soltá, yo no le conozco. ¿Qué hace?
Arrancalo por la buena, te lo digo. Lo que pasa es que mi hijo está viviendo con mi papá. Porque me prometió que lo cuidara. No le eché la está cuidando.
Perdón, no está enfermo.
Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de encontrarle la vuelta todos los días. Qué cagazo, nos haces pegar, ¿no? Te estoy buscando hace 2 horas. Vamos para casa.
Capitán.
Me tengo que ir.
Sí, pero tenés que comer algo. Ahora con ustedes yo ya vuelvo.
Fresco afuera.
Tengo que ir ahora.
Vamos.
Es mi deber.
Me tengo que ir ahora.
Entonces vamos. ¿Vamos caminando?
Esta pelotita de tenis puede generar un montón de cosas.
Puede hacer que todos se rompan las manos aplaudiendo.
Puede hacer que estalle la tribuna.
Puede generar un grito ensordecedor.
Pero también puede traer calma.
A la mitad de los niños con autismo, el sonido del mundo los lastima.
El sonido de una silla que se arrastra a ellos les molesta 10 veces más.
100 veces más.
1000 veces más.
Pero podemos dar vuelta a este partido.
Con 4 pelotitas de estas puestas debajo de una silla en las patas, podemos silenciar ese ruido.
4 pelotitas.
4.
4. 4.
4. 4. Así que si tenés pelotitas viejas
Que ya no usás.
Que ya no pican.
O con las que tu perro ya no juega,
llévalas a clubes,
canchas
o escuelas,
Para que vuelvan al juego dentro del aula.
buscá puntos de recolección en www.fundacionineco.org.
Cada pelotita suma.
Démosle pelota al autismo.
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 ¿Y este quién es?
Papá, soy yo. Enrique, ¿no me reconoces?
Yo vi una cara conocida, pero no me acuerdo de dónde.
¿Desde cuándo te importa el abuelo? Vos si se puede saber.
¿Sabés? Si no le
Estás todo el día
enseñas,
viendo la televisión.
vamos a ir a buscar sus cosas y lo vamos a internar.
¿A quién van a internar?
¡A vos!
No, no. Nos vamos para casa.
Sí, sí, soltá, yo no le conozco. ¿Qué hace?
Arrancalo por la buena, te lo digo. Lo que pasa es que mi hijo está viviendo con mi papá. Porque me prometió que lo cuidara. No le eché la está cuidando.
Perdonen, no está enfermo.
Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de contarle la vuelta todos los días. Qué cagazo, me haces pegar, ¿no? Nos estoy buscando hace 2 horas. Vamos para casa.
Capitán.
Me tengo que ir.
Sí, pero tenés que comer algo. Ahora con ustedes yo ya vuelvo.
Fresco afuera.
Tengo que ir ahora.
Vamos.
Es mi deber.
Me tengo que ir ahora.
Entonces vamos. ¿Vamos caminando?
Esta pelotita de tenis puede generar un montón de cosas.
Puede hacer que todos se rompan las manos aplaudiendo.
Puede hacer que estalle la tribuna.
Puede generar un grito ensordecedor.
Pero también puede traer calma.
A la mitad de los niños con autismo, el sonido del mundo los lastima.
El sonido de una silla que se arrastra a ellos les molesta 10 veces más.
100 veces más.
1000 veces más.
Pero podemos dar vuelta a este partido.
Con 4 pelotitas de estas puestas debajo de una silla en las patas, podemos silenciar ese ruido.
4 pelotitas.
4.
4. 4.
4. 4. Así que si tenés pelotitas viejas
Que ya no usás.
Que ya no pican.
O con las que tu perro ya no juega,
llévalas a clubes,
canchas
O escuelas.
Para que vuelvan al juego dentro del aula.
busca puntos de recolección en www.fundacionineco.org.
Cada pelotita suma.
Démosle pelota al autismo.
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 ¿Y este quién es?
Papá, soy yo. Enrique, ¿no me reconoces?
Yo veo una cara conocida, pero no me acuerdo de dónde.
¿Desde cuándo te importa el abuelo? Vos si se puede saber.
¿Sabés? Si no le
Estás todo el día
interesas,
mirando la televisión.
vamos a ir a buscar sus cosas y lo vamos a internar.
¿A quién van a internar?
¡A vos!
No, no. Nos vamos para casa, ¿eh?
Sí, soltá, yo no le conozco. ¿Qué hace?
Arrancalo por la buena, te lo digo. Lo que pasa es que mi hijo está viviendo con mi papá. Porque me prometió que lo cuidara. No le eché la está cuidando.
Perdonen, no está enfermo.
Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de contarle la vuelta todos los días. Qué cagazo, nos haces pegar, ¿no? Te estoy buscando hace 2 horas. Vamos para casa.
Me tengo que ir.
Sí, pero tenés que comer algo. Ahora con ustedes yo ya vuelvo.
Está fresco afuera.
Tengo que ir ahora.
Vamos.
Es mi beber.
Me tengo que ir ahora.
Entonces vamos. ¿Vamos caminando?
Esta pelotita de tenis puede generar un montón de cosas.
Puede hacer que todos se rompan las manos aplaudiendo.
Puede hacer que estalle la tribuna.
Puede generar un grito ensordecedor.
Pero también puede traer calma.
A la mitad de los niños con autismo, el sonido del mundo los lastima.
El sonido de una silla que se arrastra a ellos les molesta 10 veces más.
100 veces más.
1000 veces más.
Pero podemos dar vuelta a este partido.
Con 4 pelotitas de estas puestas debajo de una silla en las patas, podemos silenciar ese ruido.
4 pelotitas.
4.
4. 4.
4. 4. Así que si tenés pelotitas viejas
Que ya no usás.
Que ya no pican.
O con las que tu perro ya no juega.
llévalas a clubes,
Canchas.
O escuelas.
Para que vuelvan al juego dentro del aula.
busca puntos de recolección en www.fundacionineco.org.
Cada pelotita suma.
Démosle pelota al autismo.
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 ¿Y este quién es?
Papá, soy yo. Enrique, ¿no me reconoces?
Yo veo una cara conocida, pero no me acuerdo de dónde.
¿Desde cuándo te importa el abuelo? Vos si se puede saber.
Sabés, si no le
Estás todo el día viendo la televisión.
Vamos a ir a buscar sus cosas y lo vamos a internar.
¿A quién van a internar?
¡A vos!
No, no. Nos vamos para casa.
Sí, sí, soltá, yo no le conozco. ¿Qué haces?
Arrancalo por la buena, te lo digo. Lo que pasa es que mi hijo está viviendo con mi papá. Porque me prometió que lo cuida y no lo cuida, y no lo está cuidando.
Perdonen, no está enfermo.
Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de contarle la vuelta todos los días. Qué cagazo, me haces pegar, ¿no? Te estoy buscando hace 2 horas. Vamos para casa.
Capitán.
Me tengo que ir.
Sí, pero tenés que comer algo. Para con ustedes, yo ya vuelvo.
Está fresco afuera.
Tengo que ir ahora.
Vamos.
Es mi beber.
Me tengo que ir ahora.
Entonces vamos. ¿Vamos caminando?
Esta pelotita de tenis puede generar un montón de cosas.
Puede hacer que todos se rompan las manos aplaudiendo.
Puede hacer que estalle la tribuna.
Puede generar un grito ensordecedor.
Pero también puede traer calma.
A la mitad de los niños con autismo, el sonido del mundo los lastima.
El sonido de una silla que se arrastra a ellos les molesta 10 veces más.
100 veces más.
1000 veces más.
Pero podemos dar vuelta a este partido.
Con 4 pelotitas de estas puestas debajo de una silla en las patas, podemos silenciar ese ruido.
4 pelotitas.
4.
4. 4.
4. 4. Así que si tenés pelotitas viejas
Que ya no usás.
Que ya no pican.
O con las que tu perro ya no juega,
llévalas a clubes,
canchas
O escuelas.
Para que vuelvan al juego dentro del aula.
busca puntos de recolección en www.fundacionineco.org.
Cada pelotita suma.
Démosle pelota al autismo.
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 ¿Y este quién es?
Papá, soy yo. Enrique, ¿no me reconoces?
Yo veo una cara conocida, pero no me acuerdo de dónde.
¿Desde cuándo te importa el abuelo? Vos si se puede saber.
Sabés, si no le
Estás todo el día viendo la televisión.
Vamos a ir a buscar sus cosas y lo vamos a internar.
¿A quién van a internar?
¡A vos!
No, no. Nos vamos para casa.
Sí, soltá, yo no le conozco. ¿Qué haces?
Arrancalo por la buena, te lo digo. Lo que pasa es que mi hijo está viviendo con mi papá. Porque me prometió que lo cuida y no le eché la está cuidando.
Perdonen, no está enfermo.
Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de encontrarle la vuelta todos los días. Qué cagazo, me haces pegar, ¿no? Lo estoy buscando hace 2 horas. Vamos para casa.
Me tengo que ir.
Sí, pero tenés que comer algo. Ahora con ustedes, yo ya vuelvo.
Está fresco afuera.
Tengo que ir ahora.
Vamos.
Es mi beber.
Me tengo que ir ahora.
Entonces vamos. ¿Vamos caminando?
Esta pelotita de tenis puede generar un montón de cosas.
Puede hacer que todos se rompan las manos aplaudiendo.
Puede hacer que estalle la tribuna.
Puede generar un grito ensordecedor.
Pero también puede traer calma.
A la mitad de los niños con autismo, el sonido del mundo los lastima.
El sonido de una silla que se arrastra a ellos les molesta 10 veces más.
100 veces más.
1000 veces más.
Pero podemos dar vuelta a este partido.
Con 4 pelotitas de estas puestas debajo de una silla en las patas, podemos silenciar ese ruido.
4 pelotitas.
4.
4. 4.
4. 4. Así que si tenés pelotitas viejas
Que ya no usás.
Que ya no pican.
O con las que tu perro ya no juega,
llévalas a clubes,
canchas.
O escuelas.
Para que vuelvan al juego dentro del aula.
busca puntos de recolección en www.fundacionineco.org.
Cada pelotita suma.
Démosle pelota al autismo.
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 ¿Y este quién es?
Papá, soy yo. Enrique, ¿no me reconoces?
Yo vi una cara conocida, pero no me acuerdo de dónde.
¿Desde cuándo te importa el abuelo? Vos si se puede saber.
Sabés, si no le
Estás todo el día viendo la televisión.
Vamos a ir a buscar sus cosas y lo vamos a internar.
¿A quién van a internar?
¡A vos!
No, no. Nos vamos para casa.
Sí, soltá, yo no le conozco. ¿Qué hace?
Arrancalo por la buena, te lo digo. Lo que pasa es que mi hijo está viviendo con mi papá. Porque me prometió que lo cuidaba. No le eché la está cuidando.
Perdón, no está enfermo.
Sí, ya sé.
No entiendo nada de lo que dicen.
Este señor trabaja en retiro. Vamos para casa nosotros.
¿En retiro? ¿Qué decís? ¿Te volviste loco vos también?
No, papá, acá no se volvió loco nadie. El abuelo tiene Alzheimer, que es muy distinto, es una enfermedad. Y no hace falta ser un especialista para cuidarlo. Se trata de quererlo mucho, de acompañarlo, de encontrarle la vuelta todos los días. Qué cagazo, nos haces pegar, ¿no? Nos estoy buscando hace 2 horas. Vamos para casa.
Ni siquiera está Facundo, ¿no? ¿Y esto? Sí, digamos. Uy, se cayó este papel. Well, welcome back, everyone. We are ready to begin our afternoon session. To begin this segment, it's my pleasure to welcome Dr. Marcelo Cetkovich. Dr. Marcelo Cetkovich is the Vice President of the Argentine Association of Psychiatrists and the Medical Director and Head of INECO's Psychiatry Department. He also leads the Department of Psychiatry and Mental Health at the Favaloro Foundation. He is specialized in the diagnostic and treatment of bipolar disorder, endogenous psychosis, including schizophrenia and anxiety disorder. With an extensive background in interdisciplinary mental health, he joined us to discuss mental health stigma in this burnout society. Please join me to welcoming Dr. Cetkovich.
Thank you very much. I would like to thank and congratulate Facundo and Claudio for this amazing journey we have had these 2 days. It's amazing really what we are seeing. And this talk is a little bit out of the box. It happens to me that this tiny book appeared in my desk, I don't know how, and start reading. And it happens to me that sometimes I understand, I thought, this guy is talking about my job. This is what I thought about Byung-Chul Han. So these ideas, I lead it, I push it by some of his thoughts. As a psychiatrist, I would like to start with a paradox. We are living in the most technological, advanced, hyper-connected moment in human history, and yet we are witnessing a global deterioration in our mental health. This is not a marginal issue. Mental health is now one of the leading causes of disability worldwide, and it directly threatens what we call brain capital. Today, I would like to propose that to understand this crisis, we need to go beyond data. And this era of information gets too much communication, and this communication, as Hans told us, gets no community. We are communicated, but we are not gathering community. And this information has less meaning, and this impacts in our health. Mental health is not a clinical issue. It is an economical and societal one. Mental health is the cornerstone of brain capital because brain capital is our cognitive and emotional resources that creates productivity, innovation, and social cohesion. Without mental health, this can happen. This will not happen. So this data have shown over and over these 2 days, so I don't need to go further. But from the point of view of a specialist of mental health issues are one of the most important causes of disability. And what it is more important, that this affects mostly young people. Almost 300 million people between 5 and 24 years have some mental issue. So this is the way we have to look when we thought about mental health, and we start to move in this new paradigm of brain health. I really celebrate this idea because as a psychiatrist, I came from biology. I became psychiatrist studying the brain. So what this philosopher tells us? Late modern society is no longer disciplinary, but rather a society of performance. We are no longer objects of obedience, but subjects of performance. We are entrepreneurs of ourselves. This framework makes that self-generated stress and paves the way for mental illness. I see this idea as a good understanding to go further with the study of mental illness. Fatigue is, in this framework, is not social, it's not individual, it's social, not individual. We have lost the ability to do nothing, to contemplate. Life is work and performance. We do not rest to contemplate, we rest to perform better in production. And this is generated with this performance society. This is psychological devastating, and this leads us to another aspect that Han philosophy, that is the loss of narrative. Storytelling, the thing that we do with our social media, is not narrative, it's not story. Have no continuity, no story, meaning disappears and we lose identity. And with losing identity, suffering becomes pathology. Han also describes a very powerful metaphor. We have moved from the hand to the finger. The hand creates things that we can handle, stable, meaningful, enduring. The finger scrolls, selects, reacts, and we no longer build meaning. And once the finger reacts, it's just looking for another stimuli to go further. So we don't stay to the story, we don't get narrative. This is really hard to the situation right now. From my point of view, what I find a key to understand Han philosophy was to understand how stress is the key to understand this situation. This performance society generates a situation where all of us generate a lot of self-generated stress. This allows allostasis, adaptation to fails, and all of us know that when adaptation fails, brain-body maladaptive change occurs, and this leads to disease. We do know that psychiatric risks arise when environmental stress and genetic vulnerability converge on the brain's emotional regulatory circuits. For example, social determinants significantly drive disease risk. For example, living in a big city or being an immigrant enhances the risk for developing schizophrenia. And this is related with the genes that disrupt our ability to communicate. And these risk factors converge to the circuits that regulate emotions and stress. On the other hand, we do know the biological blueprint of early life stress. Childhood trauma creates a biological memory that rewires multiple systems, leading to lifelong disease risk. The three-hit concept of vulnerability says that there's a first hit that is related with genetic predisposition, a second hit that is related with early trauma, and the third hit that is actual stress that leads to disease. This is called the trajectory of lifetime stress events. This situation affects in a permanent way the form our stress systems regulates new stressors. In this framework, the stigma and the society of performance, we are dealing with a situation where the perfect storm to generate stigma arise. Because in a society of performance, illness are not seen as diseases, but a failure. We have to remember the three main ideas that are below the stigma. That's the idea of being guilty of the disease, the idea of being insufficient for the disease, and the idea of being dangerous for the mental disease. And this is a reality that we psychiatrists copes every day. In the society of performance, mental illness is seen as failure, and depression is not suffering, it's inefficiency. Or ADHD, for example, is not vulnerability, it's lack of discipline. In this framework, psychiatric process means that we have to balance biology and humanity. In the face of this narrative collapse, modern psychiatry often retreats entirely into biological and neurochemical explanations. While crucial, this purely quantitative approach risks losing the human subject, the person experiencing the crisis with the clinical data. But Karl Jaspers warned against this more than a century ago, when he explained to us something that is really current. The idea that psychiatry must balance two approaches. The scientific approaches, that is explanation, clearing, that is related with biological causes, with etiology, with the scientific basis, and mostly with descriptive psychopathology, that means to understand, to know the several clinical pictures. But on the other hand, we have balanced this to understanding, firsthand, that is to recover the narrative, the experiential aspect of the suffering that is related what he called the hermeneutic. Modern psychiatry risks are clear. We are strong in explanation, we are a little bit weak in understanding, and we risk treating the brain when losing the person. This is when I guess that artificial intelligence as a co-pilot could be something helpful to solve this. There is a fear that in artificial intelligence dehumanize medicine, but I would suggest the opposite possibility. AI can automate data processing, documentation, pattern recognition, all of them aspects time-consuming of our day clinical activity. So in doing so, artificial intelligence can give us something extremely valuable. That is time. Time to pay attention, time to listen, time to recover the narrative. But when dealing with massive language models, we have bear in mind two things. Only humans can listen, can understand. See, when you are dealing, when you are chatting with your artificial intelligence platform, whatever you use, you must remember that nobody is listening. No matter how empathetic, how kind, how smart you are, it's told to you, nobody is listening. For this reason, specialists in artificial intelligence have called them the stochastic parrot. Just a parrot that reproduces just with the prompt we give. So this is quite important. I guess I'm among the people that think that artificial intelligence will change medicine forever and is quite helpful. For example, as you see, some of our slides were made with artificial intelligence, but we have to remember this. But my point is that AI could help us to recover the capacity of listen to the people, to recover the strategic value of narration for mind health, to help people rebuild a story where they can live inside. So my final slide is, brain capital is not merely optimized neural pathways, it's the capacity for rich, connected human narrative. But uniting biological explanation with profound human understanding, we can transcend the burnout society and secure the future of humanity. In this framework, brain capital, firsthand understanding, and deep meaning could help the flourishing of human future. Thank you very much.
Well, thank you, Dr. Marcelo Sotkovich, for this talk about a very important topic. I have a question, Marcelo, for you. Regarding your experience, why do you think about Byung-Chul Han philosophy is important in this context?
I guess Han is I guess Han is some kind of translational philosophy. It's a person that is clear that he's a deep known of modern philosophy, mainly Heidegger and so on. And for me, that I'm not a philosopher, I'm a psychiatrist, it seems that he helps me to understand. And he puts him in the way, as a philosopher, he looks at questions that are really important from the clinical point of view. And this is what moves these ideas.
Thank you. We will not have more time. So thank you, Dr. Zetkovich. That will perform time for reflection.
Okay, thank you all for being here. Moving forward with this afternoon, and thank you for staying on a Saturday afternoon. We have the honor to present today our next speaker, which is Professor Dr. Oscar Gershanik, who is a former professor of neurology of the University of Buenos Aires and a current professor at the University of Favaloro. He's also the scientific director of the Institute of Neuroscience at Favaloro Foundation Hospital, as well as the emeritus director of the Unit of Movement Disorders at our clinic. He has been the mentor of many of us. Probably every single neurologist here knows him or has been trained by him, but he has also trained several basic scientists, where he created a few decades ago the neurobiology and Parkinson's disease and Laboratory of Experimental Neurobiology in the University of Buenos Aires in collaboration with CONICET and Universidad de Entre Ríos. Today he will be discussing in his lecture entitled Parkinson's Disease, a growing burden of public health, diagnostic and therapeutic challenges. Thank you, Dr. Gershanik.
Siguiente, anterior, entero.
Este siguiente, este es el puntero y este es para atrás. Well, hello, good afternoon, and thank you, Blas, for your kind words and introduction. And as all of the speakers have done, I would like to thank all the organizers, Claudio Vassetti, Facundo, Teresa. Nobody mentioned Teresa, who has been also instrumental in the organization of this meeting. I must confess I feel a little out of place here. We have an expression here in Argentina called un sapo de otro pozo, a frog from a different pond. Why is that? Because I'm not a policymaker. I do not have any influence on what goes on in the world of brain health. I don't have the language. I don't speak about silos, stakeholders, implementation, roadmaps, action plans, gaps, etc., etc. I'm just a clinical scientist who's been in the field of Parkinson's disease and movement disorder for the last 50 years. I think I'm one of the oldest living movement disorder specialists in the world, together with a handful of others. And I've been seeing patients for the last 50 years, PD and movement disorder patients. I've been doing clinical and basic research. I have educated, trained, and mentored hundreds, I would say, young neurologists, not only in Argentina and Latin America and in some other parts of the world. So I'm going to be talking as a clinical scientist, not as an epidemiologist or a policymaker. We're going to talk about Parkinson's disease as a growing burden of public health, but also the diagnostic and therapeutic challenges that we face in Parkinson's disease. And my talk will deal with three major points. One is what we call now the Parkinson pandemic. Second, the impact on public health. And third, what are these diagnostic challenges and therapeutic unmet needs, which I think are the major challenges we have in the field. Why do we call this the Parkinson pandemic? And this is a term that was coined by Ray Dorsey and Michael Oken in the States. They are very much into trying to organize a Parkinson prevention plan. And it's a pandemic because the prevalence is 8.5 million people worldwide, and it's projected to more than double by 2050, and is, as you have seen in a previous lecture, one of the fastest growing neurological disorders. If we look at the age-standardized prevalence of Parkinson's disease population by location from 2016, you're going to see the distribution in the places in which Parkinson's disease is more prevalent. If you look at the colors there, the color coding, well, I don't think this is working. Oh yeah, here, these are the countries that have the highest, or had the highest prevalence. But if we look at the latest figures, even though the color coding is different, you're going to see that in some regions of the world, the increment in the prevalence of Parkinson's disease is amazing. Look at the color coding here, and you can see in certain regions of the world, like the Arabian Peninsula, Egypt, China, for example, there has been an increment in the prevalence of Parkinson's disease projected for 2050 that is absolutely amazing. And why is that? What are the underlying causes explaining this increase in prevalence in PD cases? And it's not only increase in prevalence, it is also increase in incidence. And this is very important. One of the major factors, and this has been discussed previously, is the increase due to extended life expectancy. We know that Parkinson's disease incidence increases with age. We know that access to better medical care has been instrumental in improving the lifespan of people with Parkinson's disease. But there are other factors that are being discussed at present, and these are preventable factors, or in your words, actionable items, is that there is the influence of airborne toxicants or air pollution, pesticides, fungicides, solvents, etc. And there are very interesting figures about that. If you look at the global average life expectancy, it has doubled, more than doubled since 1900. In 2023, the average life expectancy was 73 years, going up from 32 years in 1900. If we look at the figures of increased incidence in the UK, look how it goes up to 85 to 89. And the increase in the older population from 1990 to 2040, it's absolutely amazing. It's almost tripled. But the interesting thing, and this is a new player in the field, is the role of air pollution. And this is a very interesting cartoon. If we look at the incidence of Parkinson's disease in the US here, and we look at the map of release of trichloroethylene and perchloroethylene, and look at the estimated annual use of paraquat in the US, and the map of particulate matter smaller than 2.5 microns in the US, you're going to see there is a significant overlap of the incidence of PD, the map of release of trichloroethylene, the annual use of paraquat, and the map of particulate matter. This is why many people are advocating that the increase in incidence is not only due to increased life expectancy, but it's due to air pollution. And this is a very interesting article published in 2023, and it talks about the risk of Parkinson's disease among service members at Marine Corps Base Camp Lejeune. Camp Lejeune is one of the most important Marine camps in the US, and Camp Pendleton is another one located in San Diego. And they compare the incidence of Parkinson's disease in Camp Lejeune and Camp Pendleton, and saw a significant difference, 1.7 with a p-value of 0.001. And they found out that the reason for this difference is that in Camp Lejeune, the water was contaminated by trichloroethylene. But this is not the only evidence. If you look at a recent article published from Taiwan on long-term exposure to multiple air pollutants and risk of Parkinson's disease, and this is, they used the National Health Insurance Research Database, including individuals aged 40 to 55, they saw that personal exposure levels to particles smaller than 2.5 microns, particles smaller to 10 microns, nitrous dioxide, sulfur dioxide were linked to or were associated with a significant increased risk of Parkinson's disease. So this is another evidence that contamination in the air is one of the major contributors to the increase in the incidence of Parkinson's disease. And there are many other cases, and some of them are quite interesting, and perhaps they sound a little anecdotal. But you know, you get more Parkinson if you live close to a golf course. And that's because of the herbicides and the pesticides that are used. And the incidence duplicates if you live less than 2 miles or more than 2 miles away from a golf course. And another interesting thing, and this is very recent, it was published last week, it's a study from Mexico. In Mexico City, they calculated the incidence of neuropathology in the brain of children and adolescents exposed to particles in the air, particular 2.5 micron or less particles. You know, that smog in Mexico is very important. And they found that even in children and adolescents, there were deposits of alpha-synuclein, there were deposits of amyloid, and deposits of tau protein. So as early as childhood and adolescence, if we're exposed to air toxicants, we can develop pathology. And this is something that is preventable. That's why Ray Dorsey is advertising his Parkinson's plan, in which he advocates for the absolute elimination of these pesticides and solvents in everyday use. What about public health burden? There has been a 100% increase in deaths related to Parkinson's disease, not caused by Parkinson's disease, but related to Parkinson's disease. And it's the leading cause of years lived with disability, and it produces a significant caregiver burden. And another very interesting publication, it was a couple of weeks ago, a document produced by the Michael J. Fox Foundation, and they analyzed the annual cost in the US related to Parkinson's disease, both direct and indirect costs. And in a previous report, it was reported that the figure of $82 billion was expected to be reached in 2037. But in fact, that expenditure was reached in 2024. So there is loss of productivity, caregiver time, non-medical cost, out-of-pocket, direct medical cost, disability benefit cost. So it's a major, major impact in expenditures in public health. And of course, and as it was mentioned in some of the other talks, there are severe inequities in low and middle income countries because of the lack of access to medication, diagnostic procedures, specialists, etc., etc. In the end of my talk, I would like to briefly touch upon the fact of diagnostic challenges and therapeutic unmet needs. And we've been talking in relation to Alzheimer's disease about the access to newer medications, disease-modifying medications. In Parkinson's disease, we have also the same challenges and the same aspirations. but we have difficulties. We have pitfalls. We know that diagnosis is still based on clinical criteria. And we have to apply clinical criteria very carefully, very comprehensively in order to ascertain, or at least partially ascertain, the diagnosis. We know that even though there are many new imaging techniques, these supportive imaging techniques are not conclusive. I mean, if you do a PET scan with fluorodopa, or if you do a Trodet scan for the dopamine transporter, the only thing that informs you is that it has a nigrostriatal dopamine deficiency. But that doesn't mean that the patient has Parkinson's disease. So, and morphology imaging, structural imaging also is inconclusive. The other thing that is quite a challenge, and experience has taught me that this is something that has to be taken into consideration, is that diagnosis is uncertain during the first 5 years. You can see a patient for the first time and diagnose Parkinson's disease, and 5 years later, supranuclear gaze palsy appears, or postural instability appears, incontinence, autonomic disturbances, and what you thought it was Parkinson's disease, now it's multisystem atrophy or PSP. And the last thing is that even though the alpha-synuclein seeding assays have been heralded as the first specific biomarker, it has not yet been standardized. It's not accessible everywhere, and the differentiation between Parkinson's disease and atypical Parkinsonism is not well defined yet. So even though many of the biological classifications of Parkinson's disease resort to alpha-synuclein seeding assays as the major determinant biological marker, I don't think we are there yet. I think we have a long road ahead of us to have a definitive biomarker for Parkinson's disease. And finally, in regards therapeutic unmet needs, we have a significant, important, diverse portfolio of therapeutic options, both clinical, pharmacological, and surgical. But despite that, we have to accept that no therapy provides sustained symptomatic benefit, effectively controls dyskinesia, or improves gait and balance problems, which are non-dopaminergic mediated signs. There are no disease-modifying therapies yet, and clinical trials have been disappointing. And this is something that has to be thoroughly discussed, because I think that perhaps we're not hitting the right target. And the majority of non-motor symptoms, and we have heard a lot of this, about this, depression, anxiety, apathy, etc., and many other systemic non-motor symptoms like constipation, deglutition disorders, hypersalivation, etc., orthostatic hypotension, they lack very effective therapeutic options. So we have major challenges ahead of us, and perhaps one of the very few actionable items, and I'm using that terminology I learned here, is that perhaps abolishing the use of air pollution toxicants is one of the major factors that could prevent the rise in the incidence of Parkinson's disease. And thank you for your attention, but I would like to conclude with a few items that I think summarize what I have talked about. We recognize PD as a rapidly escalating public health issue. There's a rising prevalence and incidence, mortality, disability, and costs. And this is something that the politicians should understand. There are shortcomings in diagnosis and unmet needs in effective symptomatic and disease-modifying therapies, and these need to be addressed. And there's an urgent need for global and regional action, which means assignment of resources, better access to specialized care medications, training of PD specialists, and allied health professionals. And now, thank you.
Thank you, Dr. Gershanik. That was a very, very informative lecture about Parkinson's disease. Anyone has any question now? There are? Klaus.
Thank you, Dr. Gershanik, for a beautiful lecture. I do remember that there were old studies from Canada already in the 1980s suggesting that herbicides would co-cause or be a trigger or a cofactor in, and then it was kind of lost. So could you explain why historically this was unproven or considered unproven and why it is rediscovered today? Do we have better data? But it has been there for at least 40 years, I think.
Yeah, that's very interesting, Claudio. There are two hypotheses that were put forward in Canada at that time. One hypothesis was about the consumption of well water and contamination by herbicides. And the other was the genetic component of Parkinson's disease. And both hypotheses were lost for a long time until Roger Duvoisin and Mikhail Polymeropoulos discovered that the alpha-synuclein gene was a determinant, the first monogenic form of Parkinson's disease. And also Ray Dorsey recovered this championship on the role of air pollution in Parkinson's disease. And this happened because we saw the rise in the incidence of Parkinson's disease.
It's more a comment than a question. The Alzheimer's disease, the South Carolina Alzheimer's disease registry is about 350,000 individuals.
Could you put the mic a little further from your mouth, because I don't understand.
The South Carolina Alzheimer's disease registry have roughly about 350,000 South Carolinians have been followed with Alzheimer's disease through their lifetime. We randomly selected 125,000 people and compared the death certificates and the diagnosis of people that were serving in the military versus not. Those that were veterans have double the diagnosis of Parkinson's disease versus those that did not. And I think that supports your comments about exposure to stress and probably exposure to toxins.
Yeah, that's absolutely right. In the case of the military, it's probably a combination of factors, exposed to physical environmental things, and stress.
Hi, have you guys looked at the epigenetic aspect of it? Yeah, that's kind of my question. The epigenetics possibly correlated with the environment, stress, and Parkinson's disease.
I didn't understand what you said.
We didn't get it. Can you repeat it?
Have you guys looked at the epigenetics of Parkinson's disease and its relation to environment and stress and all these other environmental factors?
Well, that's a very interesting question, and I think one of the things that we missed in this meeting, but I know it's dedicated to policy making more than science itself, is the role of genetics and epigenetics. I think only one of the talks gave a little aspect of what genetics influences the development of disorders of the brain, and I think it's quite important. One of the most surprising things that I've read lately is that many, many years ago we thought that the impact of genetics on life expectancy and successful aging was of the order of 20%. Now it is considered that it's almost 50%. And there are many papers that support that both genetic and epigenetic factors influence the development of disease, without disproving the fact that environmental exposure, the exposome, the social exposome, the toxic exposome, et cetera, are things that are quite important. But we cannot leave genetic and epigenetic factors as major determinants. Christopher?
Maybe I borrow you. Oh, yeah.
There's another microphone.
Thank you. Can I just ask, an experienced clinician like you, to go and sort of comment on the envy that many neurologists have for movement disorder specialists. That you have so many wonderful symptomatic treatments, you can treat people from early on, and you have deep brain stimulation, so many toys to play with. Why do you want disease-modifying treatments?
Well, that's very interesting. I would say that movement disorders specialty, it's a very, very fancy specialty, I think, and we all movement disorder specialists are fascinated with what we do, and I agree with you, we have many toys to play with, neuroimaging, lots of drugs, symptomatic treatments for many disorders. When I started in the field 50 years ago, there was nothing. There were no movement disorders. We called extrapyramidal diseases at that time. The specialty of movement disorders did not exist. And in the course of these 50 years, I have experienced the exponential growth of knowledge in pathophysiology, in the neurobiology, in therapeutics, in surgery, et cetera, et cetera. What about disease-modifying treatments? I think it's because Parkinson's disease is a multifactorial disease. It's a very heterogeneous disease. There are monogenic forms of Parkinson's disease. There are more than 90 risk factors, genetic variants. There are multiple mechanisms, oxidation, mitochondrial damage, so on and so forth. And most of the people that work in the field of disease-modifying therapies are focusing exclusively in removing alpha-synuclein. And most of the trials of alpha-synuclein removal have failed dramatically. None of them has succeeded. And I think it's because they are looking very narrowly on a single factor. And it's not a single factor. It's multiple factors. As I said, genetics, genetic predisposition, endogenous factors, inflammation, infections, trauma, aging, exposure. So we cannot deal with Parkinson's disease just by looking at the end pathological product and interpret that as the neurobiological substrate of Parkinson's disease. It is just a pathological end product, and that's it. And we're trying to remove it. We have invested millions of dollars, billions of dollars in developing monoclonal antibodies to remove alpha-synuclein, and none of them succeeded.
Thank you so much. Now we are continuing with the presentation of Professor Kailash Bhatia, who is the President-elect of the European Academy of Neurology and Professor of Clinical Neurology at UCL Queen Square Institute of Neurology in London. He also develops as an honorary consultant neurologist at the affiliated National Hospital for Neurology and Neurosurgery, Queen Square. He's a fellow of the Royal College of Physicians at UK, and he trained under the legends of neurology like David Morsell. He will present a lecture virtually today entitled Key Clinical Lessons from Parkinsonism and Neurodegeneration.
Claudio Bissetti and the organizers for giving me this opportunity to do this presentation on key lessons for Parkinson's and neurodegeneration. I would say in the context of brain health, you have already heard from Professor Oskar Geschanik, my good friend, about Parkinson's and the difficulty with the treatment aspects. So this is really a major problem for us, as well as other neurodegenerative conditions of the brain. And there is a emerging evidence that we are almost facing a pandemic of Parkinson's, with the number of patients with Parkinson's gradually increasing. Apparently, as per this study, this has doubled to over 6 million, and this is primarily related to aging, and it is expected that these numbers will further increase to about 12 million by 2040. So there are, of course, a number of additional factors, including increasing longevity, which we already talked about, declining smoking rates, and increasing industrialization, and apart from the fact that there may be some genetic risk factors too. So this has become a major issue, and obviously therefore a major issue for brain health initiatives. What can be done already in the context of prevention of Parkinson's and similarly other neurodegenerative diseases which are facing us. And in this context, I have given this acronym, which can sort of be called SEEDS, although there is obviously an additional A here, and I'll explain what this SEEDS is in a moment. So one of the biggest risk factors for neurodegenerative disease is aging, but perhaps we can do something for getting good aging rather than aging badly. And so let me suggest that we should sow the seeds of what I'm just about to mention here: sleep, exercise, avoid head injury, environment, diet, and social interaction. So sleep disturbance is one of a potential risk now being considered for neurodegenerative disease, and of course is also a progression factor for Parkinson's disease. And this has been very elegantly shown in this study here by Michelle Hugh and colleagues, mentioning that sleep disturbance is obviously common. We are all aware of RBD in patients with prodromal Parkinson's. But there are also other sleep issues: central sleep apnea, restless legs, nocturnal akinesia, etc., which happen in patients with Parkinson's when they have the condition. Good sleep is obviously important because that may lead to a better clearance of alpha-synuclein or other degenerative protein which we accumulate in the brain. The lymphatic system here is extremely important, and good sleep, if you don't get good sleep, then there might be an impairment of the lymphatic clearance. And the suggestion is that good sleep might even be a potential risk factor if you don't get good sleep for the development of neurodegenerative conditions. So this is important, but as is the good sleep being a progression factor for Parkinson's disease once you develop the disorder. The second aspect is exercise. Now, many different studies, and this is a wonderful article here as a review, which is talking about exercise as medicine in Parkinson's disease. But what they also talk about is that there may be a possibility that people who do regular exercise, they might have a decreased risk of developing Parkinson's. If you do develop Parkinson's, and then compared to those who don't exercise after they've developed the disorder, which is shown in red, compared to those who are doing exercise after the onset of Parkinson's, shown here in green, you can see that there is an improvement in the quality of life, in the motor and in the non-motor scores, and possibly also in the progression of the disorder. So exercise is a very important factor and may be also important for perhaps prevention or reduction in the progression of Parkinson's disease, an area which really needs to be highlighted. The third is avoiding head injury, and I don't need to go into this any great detail, but dementia pugilistica or Parkinsonism related to trauma, for example, in rugby players or repeated head trauma is obviously important. this may be a different form of Parkinson's, of course, but when we are talking about head injury, I think this is an important aspect. We may be thinking also about children who to avoid martial sports or sports where they may be having recurrent head injury, and because this may have a long-term consequence in patients, particularly those who develop tauopathies, but also perhaps related to Parkinson's. We may also consider injury to the brain not just as a traumatic injury, but also perhaps recurrent infections and so on may also play a part here in causing injury to the brain, and which may have consequences later in life. Environment. And this is also a major issue now. And this is the two studies here which I want to point out to you. This one is a wonderful study on pesticide using iPS cells from our dopaminergic neurons from patients with Parkinson's, and looking at the relevant pesticide exposures in those who went on to develop Parkinson's. A really amazing study showing that there are identified nearly 53 different pesticides which have relevance to Parkinson's, and highlighting those in the cotton industry, particularly in South America, where this may be a particular pesticide which is used and has a higher influence of causing Parkinson's. Another interesting study is about this, which had a lot of visibility in the press, about the proximity to golf courses. So if you live within the radius of 1 to 3 miles of a golf course, then that increases the risk of developing Parkinson's. And at first sight, you may wonder why that may be so, but it appears that to keep the golf courses very pristine, a lot of pesticides are used to kill vermin and other things in golf courses, and that may percolate into the water or perhaps in the air, and that can cause increasing your risk of developing Parkinson's. So pesticide exposure, the environment, pollution, all of these things are becoming very relevant. Microplastics as well. Some great studies showing that microplastics may actually affect the nigral area in the brain, and perhaps maybe also causing a risk for developing Parkinson's. And diet. So a number of studies now talking about diet, and in this context we are all aware that the gut microbiota are important in the development of Parkinson's and other neurodegenerative disorders. And the adherence to a Mediterranean diet is being suggested to reduce the risk of Parkinson's. It may also help those who have prodromal Parkinson's in perhaps developing Parkinson's later. So the suggestion here is that the Mediterranean diet reduces Parkinson's disease risk through a anti-inflammatory effect and improvement of the gut microbiota and mitochondrial function. So diet is extremely important, and it's very crucial that the diet which we are talking about starts at an earlier age. Of course, it may also help after you develop Parkinson's, but it is important to consider this as helpful in preventing neurodegenerative disorders. And social isolation. This is an extremely interesting study using the UK Biobank, although it's from China, where they showed that in dividing the population into 3 groups, those who had social interaction, those who had good social interaction, those who had moderate social interaction, and those who had very little social interaction, those who were very isolated. And when they compared the risk of developing Parkinson's over a 12-year period, it became very clear that the ones who had very poor social interaction, meaning those who were very socially isolated, had a higher risk of developing Parkinson's compared to those who had good social interaction. So social interaction also is very important. So in summary, although clinical trials of disease-modifying agents are on for Parkinson's and other neurodegenerative conditions, results have not shown dramatic benefits. I think prevention should be a major plank in the brain health mission so we can decrease the prevalence of these disorders. There are a number of initiatives which can be taken at an early age, and education about this is important for brain health in this aspect from a very early age. We are talking about school children, young adults, and so on. Good sleep, regular exercise, avoiding head trauma, awareness of environmental triggers and its avoidance, good diet, social interaction, apart from general good medical well-being, may go a long way in preventing the burden of Parkinson's and neurodegenerative disorders. Thank you for your attention.
I believe Professor Bhatia is connected now, so if anyone in the audience has a question for him. Hi, Professor Bhatia. Thank you for your amazing lecture. So we are having one question here from the audience.
Hi, Kailash. This is Oscar. How are you?
Hi, Oscar. I wish I was there with you.
Yeah, I was looking forward to having you here. One of the interesting things you talked about environment, and could you comment on the fact that there is an interaction between your genetic composition and environmental risk factors?
Very good question. Clearly there are going to be genetic and epigenetic vulnerability to environmental toxins broadly. We are all exposed to environmental toxins. So the question arises, why is it that some people may have more inclination of developing a Parkinson's disease or neurodegenerative disorder? And I think you're absolutely right that the interaction between your genetic makeup and the environment may be predisposing some people more than the others. You're absolutely right. That's a very important point.
Thank you. And there is another question from the public.
So, hello, Kailash. Do you hear me?
Hello. Hi. Hi. Yes.
So, thanks for the presentation. Here, Federico Castaño from INECO, Argentina. So, you shared with us the risk factors for developing Parkinson's disease. So, what do you think are the barriers or the main barriers that make difficult that people acquire and execute the healthy habits to not develop Parkinson's?
Great question again, really good question. I think the core problem at the moment is that people are not realizing these issues and there's a lack of education. We've got to learn from the cardiology and the cardiovascular people how they bought into the limelight of preventing cardiovascular disease by having a better lifestyle with regard to controlling your diabetes, controlling your blood pressure, exercising, and all that. And that has led to good results now. And we have to do the same thing as neurologists, that we bring attention to these factors which I just pointed out in that acronym, and educate people that don't wait till it is too late. You got to start early to do these things. So you're absolutely right. We are lacking. And the biggest barrier is that we are not being able to communicate this. And this is the goal for us, I think, in the next decade, to be able to deliver this message.
We can keep on the next session.
Sorry, use this one.
Yes,
Okay.
please. I'm sorry, it's mute.
Right, that was a slightly dramatic end. So there we go. We're now moving into the penultimate session, which is, I will tell you in one moment once I've got my reading glasses on. From evidence to action, brain health policy and system transformation. And the first speaker is Dr. Ingrid Berg. I hope I said that right. My British foreign language is not great, as you know. So she is a psychiatrist and neuroscientist at the University of Geneva and the University Hospital of Geneva. She is a board member of the Swiss Brain Health Plan, where she plays an active role in shaping brain health policy, as Claudio said this morning. Her work focuses on developing brain circuit therapies using advanced neuroimaging and non-invasive neurotechnology in severe psychiatric disorders. And the title of the talk is Insights from Switzerland on the Burden and Cost of Brain Disorders. There we go. Welcome.
Okay, so many thanks for inviting me here. Congratulations of the excellent organization, Professor Manes, Professor Bassetti. Great pleasure to be in beautiful Buenos Aires, where I will say a few words about the cost and the burden of brain disorders in Switzerland. So this work is inscribed in the Swiss Brain Health Plan. And when we say brain disorders, we take neurological and mental conditions together. We want to be inclusive by saying brain and mental health, but the fact that we are putting an "and" effectively divides brain and mental health. So here we're considering brain to be mental and neurological disorders. As Professor Bassetti this morning explained, the Swiss Brain Health Plan aims to be a holistic, intersectorial national initiative to promote brain health and prevent brain disorders. And the rationale was this is a bottom-up initiative motivated by these three insights, so that there is an increasing disability and cost of brain conditions globally. That we recognize as psychiatrists, as neurologists, that brain health is foundational to individual and societal potential, but also we know now from progress in neuroscience that there are opportunities for neuroscience-informed prevention. But we need data to implement and guide the Swiss Brain Health Plan, and so this is the context of this work. So here we ask three questions. What is the burden, health burden of brain disorders in Switzerland? So how has it evolved? How does it differ between age and sex? What is the cost of these conditions? The economic burden? How much do we spend? And this is direct spending that I'm going to talk about here. So please be aware that the costs are even higher. They are not considering indirect costs. And third, we also ask whether brain health burden and health spending are aligned, or whether there are mismatches, and how can that inform us. So we use the framework that was mentioned here before. So this is the Institute of Health Metrics and Evaluation, a global burden of disease. We use the 2021 and the 2023 cycle. And basically, this is just standard measures of how we measure the burden of the brain disorder. So basically, this is DALYs, disability adjusted life years, and measures overall burden. And it's a combination of years lived with disability and years to life lost. Then we wanted to look at the direct spending. So here, what we are going to see here is the total direct spending in 2021 US dollars, split by types of spending. So these are the two measures we're going to look today. So let's start with the first one. So what is the burden of the health burden of brain disorders neurological, and mental disorders in Switzerland. So here you see a ranking. This is a ranking of all conditions. It was mentioned previously, it's a very useful data set, but of course it's not complete, so sleep disorders do not appear, head trauma does not appear, so personality disorders do not appear, they appear as other. So also this, take it with a little bit of salt. However, the ranking is very useful because it's a zero sum of all conditions. So here you see the top 10, you see that these are the top 10 ranking of disorders in Switzerland. And if you see that these top 10, they constitute 85% of the total brain burden from all brain conditions. So you have Alzheimer's and other dementia, depression, anxiety, stroke, headache, self-harm, suicide, alcohol use disorder, drug use, schizophrenia, and bipolar disorder. And when you look into this top 10, you also see that like half of it, more than half of it, is these 5 conditions: dementia, depression, anxiety, and stroke. So how is this burden distributed across the lifespan? So of course, it's not a surprise. Older populations, they have higher brain health, right? And this is like what we say, this is an aging population, so of course the burden is very high. But actually, if you look at the actual numbers, you'll see that those that are here, 25 and 29, have the same brain burden as those who are 60 to 64. So of course, this is not to reduce our brain health into a productivity measure, but it is very interesting that those that are entering the workforce are as sick as those exiting the workforce. What happens when you see across the lifespan? So you see this is divided by conditions. So you see that in older ages you have more dementia and stroke, and in the younger ages you have more depression and anxiety. Again, again, this is not to pit conditions against one another, but this is to say that maybe we need also lifespan-informed interventions. Then we looked at what happens, how can we split it by sex, right? And so these are official Switzerland data, so you see that females live a bit longer than males, by 3 years on average, but actually when you look at the DALYs, they live in worse brain health than men. And this is it's a gap that is projected to grow to 2020. And if you look at across the lifespan, so you are looking now at total DALYs split by male in blue, female in pink, and this is across the age. You see that, not surprisingly, there is much more weight burden for women across transitions, so key transitions like entry, so puberty, entry, peripartum, partum, perimenopause, but also caregiver burden, meaning that women are more likely to have a wear and tear. I have not presented here the ranking, but basically women in Switzerland have a 2.5 times more risk to suffer from dementia than men. So again, we see here that this can provide us some insight on potential subgroups, conditions, and also temporal windows. So there is no one-size-fits-all. There's not one condition. There is one condition for a certain biological sex and temporal window. So overall, the first takeaway, brain disorders represent a huge health burden for Switzerland. There is a consistent burden that spans young population and to older ones, and there's a higher burden in women, in particular around key transitions. So let's see a little bit about the spending. So you're looking at direct spending. So Switzerland is rich, and so this is why this is interesting to see how the system is funded in a well-resourced country. And so if this is happening in a well-resourced country, then I let you take your conclusions for other less advantaged countries. So all healthcare in Switzerland costs around 82 billion Swiss francs, which is 82 billion 2019 US dollars, and it's 100 billion in 2024 US dollars. So this is around it. And when you see how much the brain represents, so the brain is 23% of all health. So this is communicable, non-communicable, and injuries. So this is in every 4 francs, 1 franc is spent for the brain, which is pretty amazing. Consider that this is 1 organ. And so this is costly. So when we're looking at direct, this is not investment. This is costly, how much hospitals and ambulatory cost. And when you see, and unsurprisingly, the top 10 is dominated by the top 10 conditions that we saw in the first burden slide. And now you can see that 3 to 4 conditions, they occupy more than half, with dementia occupying 30% of the budget. So 30% of the budget comes to cover costs rising from dementia. When we look at the lifespan, then we see, yes, older population, they cost more, but of course that younger, as young as 10 to 14, the cost is as much as those that are 60 to 64. This is the total spending across the lifespan for the main conditions. And one of the reasons why I wanted to show you this is that, so if you compare, if you put side to side spending and burden, you'll see that in this midlife section, and this is the section that is covering, you know, the young and the old, this is like the glue of the society, well, you see that the burden is very high, but the spending is very low. So these are people that are maybe busy caring for the younger ones and the older ones, but they're not taking care of themselves. And I think that this is a key, the midlife section is a key section, and from these women in midlife is a key section of the population that deserves more investment. I told you before that in dementia is 30% of the health budget in Switzerland, but actually when you split it down by types, so you were seeing here ambulatory, emergency, home health, inpatient, nursing facility, and pharmaceutical, you see that 85% of those costs in dementia are arising for nursing. So a lot of money is coming for nursing. So obviously the question, the key question is like, how much can we invest now in research to be able to remove this high cost of nursing? So brain conditions costly, taking up a large share of health spending. Spending could be further improved to reflect actual burden across age, sex, and condition. So this brings me to the third point. So how is burden and spending aligned in Switzerland? So ideally, you'd want that the budget is planned in response to the burden. But there is this very interesting study in the US where they studied the allocation of National Institute of Health funding by disease category, and they see that actually there is no, that the NIH spending is a historical one. So for most diseases, it seems to be based primarily on the level of NIH spending more than 10 years later. So there is not really an update on the funding. And so we asked, okay, is spending mainly explained by budget in Switzerland? How do decision makers decide? And so we saw, we ran many analyses, but I'll just present this and very happy to respond later. And basically we saw that Swiss health spending is almost entirely explained by spending history. When you regress this, you see that actually the main predictor of current spending is previous spending. And when you do the opposite, when you explain the burden, you also see that there is no relationship between burden and spending. And this is very impressive. So basically, you'll decide next year budget based on previous year budget. However, not everything is depressing. So I think that there are 2 lessons from Switzerland that we can take. The first is for drug use disorders and for cell harms. So if you go to the individual conditions, you'll see that for these 2 conditions, spending becomes more efficient because you spend less. And these are medical spending. So this is what you spend for hospitalization, ambulatory care, and so on. So you spend less, and the burden goes down. And the same for self-harm. You spend less, but the burden goes down. And why is that? So, unsurprisingly, these are the two conditions in Switzerland for which there is a national plan. So, for drug use, Switzerland has been very pioneer in this four-pillar policy of combining extra-medical prevention and promotion. The same is for self-harm. So this shows that coordinated strategy, cross-sectoral strategy works. We see this in our own data. So I leave you with these key messages. The first is that brain disorders, their prevention and their promotion is a major public health priority for Switzerland, and that coordinated intersectoral response that aligns obviously with life course and sex-informed biology is working to curb burden and cost. And we have two examples of that. The second message is that we need burden-informed allocation. So it's not just because to give more money. So sometimes, we have to be very careful, because sometimes spending more money actually not only does not translate into population health gains, but can have the opposite effect by displacing more effective uses of resources. And here I'm leaving you with this London School of Economics analysis on the cost of high cancer drugs, where you see that actually you could have generated with that amount of budget that is invested for cancer costs 5 million years of good quality. So we have to be very careful on how not only we invest in a burden-informed way, but also how we couple it with effectiveness and value. And the third one is that these results strengthen the case for neuroscience-informed prevention and early intervention. And this is, we have to proactively invest in prevention rather than paying it as a reactive costs. And this is a key to reduce the pressure of a rising cost of the healthcare system due to a rising age of population and so on. And finally, I will leave you with this phrase of my favorite writer, which is Julio Cortázar: "Sean realistas, pidan lo imposible." Be realistic, ask for the impossible.
Great, thank you very much. So, our next speaker is Augustine Ebeners, who's going to appear virtually behind me. He serves as the Director of Global Research Networks at the Global Brain Health Institute in Trinity College Dublin, and he's also the Scientific Director of the Latin American Brain Health Institute in Chile. He leads major multi-center initiatives, including RedLad and ClickBrain, and promoting equitable transdisciplinary approaches to precision brain health worldwide. And as you can see, his talk is going to be One Brain, One Health, integrating neurology, psychiatry, and social contexts.
Hi everybody, it's a great pleasure to share some ideas about how we can connect the One Health approach with One Brain and how this can help us to integrate neurology and social context. Those are my disclosures. And I will bring first an idea that I have been working for a while that is called the Brain Health Synercom. That is a way to understand how we can connect body with brain and environment. Then I will focus in neuroscientifics and this kind of ecological approaches that One Health bring, and we'll try to bring some agendas for the future. So the Synercom, it means the synergetic interactions that happen between the brain across levels in the brain, but also in the whole body health across, inflammatory, immune, metabolic pathways, as well as the environment, the social and physical exposome, the factors that impact in the health across the lifespan. So for that, we really need to reshape what we understand about the brain, moving from brain to a more ecological or One Health approach. Why? It's because if we don't bring this, if we don't bring integrated views, environment and body, we will have disembodied theories that won't apply to real life, to everyday life. This is the main thing. So the first thing is to bring body. Why? Because inequalities, environmental inequalities, have a huge impact, a huge hallmark in the tear and wear, in the allostatic process, in the cumulative effect of stress and responses to environmental demand. This impacts mainly the body, and through the body is how that impacts the overall brain. So when we think in One Health, we bring environment, right? But for connecting environment with health, we need to bring the body. This is how the exposome, the physical pollution, heavy metal toxins, the exposome, social, structural inequality, socioeconomic status, impact your body through epigenetics, allostatic overload, inflammation, immune system, and this is how we need to integrate that in a view, not only to understand disease, but also to understand resilience. One way to understand the body is assessing the interoception, how the brain integrates the body signals in response to environmental demands. We have been shown that these interoceptive pathways that cover, autonomic system, specific body representations and responses to environmental demand are critical to understand complex phenomena like social cognition, emotion, but also health and disease, especially in some neurological conditions like the frontotemporal dementia that have a specific deficit in that regards, but also in less specific conditions, including multiple psychiatric disorders. Other way to understand is to understand how the body is relevant for the brain is to understand that what happens in the body is directly connected with the brain. Brain is part of the body and serves the body. So using aging clocks, for instance, you can estimate the health and the overall aging of 2 or 3 organs like cardiovascular, musculoskeletal, renal, metabolic, and with that you can better predict neuropsychiatric symptoms in the brain. You can also understand how the cardiometabolic conditions, peripheral cardiometabolic conditions, impact the brain in terms of risk of dementia, brain atrophy, and connectivity. There is a lot of research going on in that field that has been shown that. But then we need to expand the zoom, moving from brain to body and from body to environment in order to develop One Health approaches. So the exposome is the cumulative way to understand how physical things like pollution, water quality, green spaces, as well as social factors, like social determinants of health or socioeconomic inequalities or gender inequalities, how these factors impact in the health. We started to study that a few years ago. The first thing that we did was to create a model, an artificial intelligence model to estimate the biological age of your brain. And then we just looked at the brain across global settings. It happened that the people in the global south have, older brains than in the north. Females tend to have older brain, and of course people that have dementia have older brains in comparison with the chronological age. But then we started to realize that living in specific places was associated also, with higher pollution or higher or larger inequality in socioeconomic terms. So we started to realize that the environment can imprint a hallmark in the pace of aging. And this other paper that we did was looking at the exposome regarding multiple indicators of physical, social, and sociopolitical exposome. That we found is that the people age at different paces in the world. So people that is in Africa have the largest accelerated aging, followed by Latin America, Asia, Mediterranean Europe, and the people in the north of Europe have the healthiest accelerated aging or less accelerated aging. And this was associated with multiple factors, including not only physical factors like pollution or standard classical socioeconomic factors, but also, core sociopolitical factors, factors associated to instability in democracy that increase the overall everyday stress of the population. And in this other paper that is coming soon, we develop a better model incorporating 73 exposome factors, including air quality, green space, temperature, precipitations, drinking water, poisoning, mortality rate, agriculture, related metrics, number of disasters, pollutions, but also, more typical socioeconomic structural inequality, gender demand, energy demand, gender inequality, unemployment, GDP, Human Developmental Index, and then democracy factors like rule of law, political representation, participation, etc. And we estimated the brain clocks across Latin America, North America, Europe, Asia, and Africa. And that we found is that these combined factors of different exposomes that doesn't have a direct relation between them, like physical factors with social and sociopolitical, but the combination of these factors induce a 15-fold times more accelerated brain aging than when you look at these factors alone. This has been the classical approach, looking at how environment, physical environment impact health, or how sociopolitical, but not how they are integrated. So these are important reflections for multiple multi-sectoral interventions if we want to change, if we want to really address this kind of, or mitigate these huge impacts. We need multi-sectoral policymakers working together on that. Even, these combined effects, especially when involve strong exposome like multidimensional poverty metrics or GDP, or, very, very poor democratic institutions, can be associated with accelerated aging much more than dementia. That is, by definition, a biological accelerated aging disease. So this illustrates how powerful is the environment, right? We are also starting to go beyond this pure estimation of brain ages and looking at the underlying mechanisms and very basic mechanisms associated with aging, like the excitatory inhibitory balance or the entropy of the different neural networks are directly associated with this kind of phenomena. So those are just examples to try to bring the idea that understanding brain health needs to go beyond brain, focusing body and environment, and for having real impact in real life, we cannot just focus in biomedical science. We really need to do transdisciplinary things. I am a neuroscientist, so in neuroscience we have been proposing biophysical generative models that can, first of all, integrate multiple levels in the brain. This is another thing that most of the research is not really tackling, but also, bringing ways to incorporate whole body. You can do that using priors in your biophysical modeling, or using, external parameters for modulating the interactions in a low-dimensional representation of the brain. And you can use also, extracerebral metrics like, exposome measures. We also need to better understand the environmental factors and the nonlinear interactions, right? So poverty, education, pollution, toxins, natural disaster, discrimination, structural inequality, armed conflict, abuse, household dysfunction, cardiometabolic risks, chronic conditions, infection, nutrition, neglect are just examples of the incredible large number of factors, but the most neglected aspect is the huge synergies, the neurosyndemics that are created at the level of epigenetic aging, telomere attrition, systematic inflammation, whole body health, or brain aging. So this really needs to be a new science. I'm so happy that in RedLab 2 we are trying to bring these connections between the socioeconomic, social, and physical exposome with also genetics, because we tend to think that genetics and environment doesn't interact, which is the wrong assumption. On the contrary, I think that not only through epigenetic, but even in the founder mutations and polygenic risk score, the environment really interacts with genes to shape the phenotypes. And how we can understand this through artificial intelligence and sophisticated computational approaches to integrate this huge heterogeneity. This will be also important to understand our world that is full of conflict, that is associated with higher level of substance abuse, neurotrafficking, distress, polarization, conflict, neglect, a huge impact in communities. If we don't bring these things into our models of brain health, we won't be able to make predictions in real life. This is the most important thing I want to share. It's also to understand resilience. For many years, resilience has been understood as a pure biological entity. Like, if you have the Colbos mutation or if you have the Christchurch mutation, you won't develop dementia, even if you have another mutation that causes the diseases, right? So it's a huge example of resilience. But resilience can be also associated with different resilience organs, like, the overall cardiometabolic system, your musculoskeletal system. It could be also present at the level of pathways, like inflammatory, immune pathways, but also stress management, that is a huge threat for resilience. It's also shaped by multiple social factors, like how you manage stress through your family or your communities across the years in the lifespan approach will have a huge impact in your health. And the way that you can manage this stress, it will be really dependent on the social networks that you have. So this stress is biological, have a huge biological imprinting, and it's important for us to understand that resilience needs to be understood as a combined effect from genetic, cognitive, cultural, environmental, social, and brain health. We need this kind of One Health approach for that. We have been working with this, trying to combine expotype, like the combined set of exposome that one person have with the phenotype, all the intrinsic properties of an individual, through multi-aging clocks, including epigenetic clocks, omic clocks, biobehavioral clocks, or brain clocks, and trying to develop, multiple clocks approach to understand that. This is important also to understand positive aspects, like protective aspects, like, lifestyle change, using multiple language, doing exercise, doing, creative activities that can reduce stress are associated. All these positive things are associated to delay aging at brain or biobehavioral metrics. So I think that it's important that we incorporate this lived environment, lived body phenomenon to understand the brain. It's also important to understand that cultural activities and art activities can have an impact in reducing the stress and improving multiple pathways, immune pathways, stress pathways, and we don't know yet that how this can be done in more systematic way. Through the Click Brain is an example. We are going to develop this kind of transdisciplinary approach to try to create a more integrated framing to understand health. I hope that this wonderful meeting in Buenos Aires will stimulate this kind of discussions that we need to develop across multiple scientists, policymakers, and also companies. So thank you so much for your attention.
There we go, more drama. So finally, Andrea Szalczewska, there we go, terrible, sorry, who you all know. So she is a neurologist and associate professor at the University of Chile, and there's absolutely loads to read about her here, but I'm sure you all absolutely know her. So take it away.
Thank you. We are waiting for the slide. First of all, thanks to Facundo, Teresa, and Claudio Bassetti for the presentation. It's not easy to give the last talk after a lot of outstanding talks, so I hope I will not bore you. But we have to wait for the presentation. Si no, no tengo mi computador. Si no sé. The organizer give me a not very easy topic, but I don't know if there was. Oye, está pesado.
Next, before, and the pointer.
Yeah.
Next, before, and the pointer.
Yeah, okay.
And I'm going to show you this.
Okay. So, as I say, the organizer asked me to talk about not so easy topic, the translated brain health research into policy and care. It's not easy to talk about that. I will talk about that, talking about the story of the dementia public policy in Chile and a recent project, the Remember project. I have no conflict of interest. Lord outline. I will talk about challenge, the story of Chile of the dementia plan and opportunity with real world data. I apologize for my English. I am not French. I am French, but I was not born in French. But I learned English in the school in France, so the brain is very vivid, because when I speak in French, people from France know that I am not French, but when I speak English, people think that I am French. And I am not, though case is quite common. So, in a recent paper published by the Health Policy Stack Group, talking about the problem with the gap between research and public policy, we identify a lot of gap. The paper was led by Juliana Sousa Talarico and Maria Pinson, and there is a gap that we have all discussed during this today in translation. There is also a limit real world data evidence, and there is unequal access to care. We can ask why it's so difficult, why we still have so many gaps in brain health, in dementia, between research and public policy. And if you think, and I think it's relate to the complexity of brain health and dementia. If you think in the COVID crisis, is a very complex situation, but research was able to provide a single response, vaccine, and research was implemented, and we have no more COVID crisis now. So it's amazing. It go very, very fast from research, and it changed the life of all of us. Remember some years ago, we were at home, we were with masks, and now we are here, we are talking, and no one is wearing mask. And almost no one is still dying of COVID. So it's amazing how in some situation, research can change, can go to public policy and change the situation. But what happened about brain health and dementia? First, there is not, the diagnosis is complex, it's multidimensional, and it's dependent at the same time in the when you do the diagnosis. You can do the diagnosis at the level of clinical, neuroimaging, and now we have the molecular biomarker that has make the diagnosis with another aspect of the diagnosis. We can do the diagnosis from people with no cognitive impairment to people with dementia. And also we can act at different points of the disease, from primary prevention to tertiary prevention, and we need to act at the level of the person, or at the level of the caregiver, or at the level of all the society, and action is multidisciplinary and intersectoral. So there is no single response. So talking about why it's so difficult bridging research and public policy in brain health, the difficulty, I will talk about the story of the Chilean dementia plan. If you don't know Chile, Chile is in South America. It's a very long and a small country in the extreme south. It's a small country, very long and very... And there is a very funny story of a Hungarian writer that told the story of the creation of Chile, but the story will be for another time. In Chile, it's an aging population. We have very good, quite good public policy, and public policy was very good for addressing mortality in birth and mortality in children. So we have an aging population, and with a lot of risk factors. So dementia has increased as one of the leading causes of daily or loss of year of life. But there is this impressive increase, but that was the situation not so far ago, and the Ministry of Health has a program with only less than 5,000 people with dementia. This slide says that the number alone are not enough to change the reality, are not enough to drive public policy. So one way to advance is to go to other fields, and there was a French writer that lived in the United States that wrote a very simple thing about political. The public policy and political are driven by what is seen and what is not seen. So if you want to change public policy, you have to make things visible, and it's what we done. We start a campaign, and we draft a national plan. At the beginning, the campaign was very moving, but no effect. It was nice, but we do some ridiculous things. But then we have the chance that we meet someone from the publicity that offer a very disruptive campaign. This one man was the president of Chile, and we put him like dementia, and the campaign was very successful, and he was able to put dementia in the agenda. At the same time, there was some initiative from the government to create some facility for dementia. So we were a success, and there was the new government draft wrote a dementia plan and start the implementation of the dementia plan. It's not only have the document, but start the implementation. The dementia plan was based on the Chilean health system, so it strengthened primary care, but also it created memory clinic at the specialist level and a center for dementia, living with dementia, daily care center. The dementia plan started implementation with only 3 memory units and some daily care center. I think that the distance of dementia plan, Diego Aguilar also said in the morning, so I only will repeat what he has said, lead that dementia was integrated in explicit health guarantee. Explicit health guarantee is a Chilean law. When a disease is integrated in explicit health guarantee, the state, the government, has the obligation to provide health care. And the integration of dementia in public, in this law, changed absolutely the reality. Before that, there was very little people with dementia. According to the Ministry of Health Register, there was only 3 memory units. And 5 years after that, look how number have changed in very little people with the diagnosis of dementia according to the Ministry of Health Register, and the number of memory clinics in public hospital has increased dramatically. Indeed, all the people working in memory clinic in public hospital, we have created a network of memory cleaning to work together. It's a very simple network. It's a WhatsApp group. We exchange information, and we meet, and we try to knock the door of the government if we need. One of the very important things that the memory clinic was created in very diverse situations. These people here are from Chiloé. Chiloé is the south of Chile. It's an island. And these people are from the memory clinic, and they go in boat to visit people with dementia in different parts of Chile, in different parts of Chiloé. That is one of the reality, and that is the reality of my center. We receive an international visit, that is Victor, with a superior woman. So the dementia clinic have to be implemented in a very, very different situation. And here is the problem with what is linked, the missing link of the dementia, of the Chilean story, that it was found on evidence, but there was no research embedded in the dementia plan. And there was not in the new law. There was research is by one hand, and clinical practice is in another hand. And we have discussed that we need more evidence for the global south, from our population, to respond to so many questions that we have about our population. Nilton Custodio talked about that the cutoff of the biomarker, blood biomarker, the impression that we don't have the same cutoff in the Latin American population that in European and North American population. Why? We don't know. So we don't know exactly the relationship between risk factor and the expression of neurodegenerative disease in our population. We don't know really the trajectory of dementia in our population. So we have a lot of questions. And how to advance when you have public policy drive of the Ministry of Health that do not incorporate research as an important point. For us, the opportunity comes for the Alzheimer's Association with the Global Real World Data Platform. There was a call for a grant. We apply, and we win it. We win with the, remember, Red Memoria Viva electronic register. We win with a quite simple project, but what is amazing about our project, and we are very grateful for the Alzheimer's Association because he found a project that was not quite primarily by people doing research. It's a dementia register in 7 hospitals in Chile, in Santiago, and in the south. The project includes harmonization, training, and we have a very simple solution to address fragmentation of data. We don't, because the problem now to capture data is that there is a really fragmentation of data. So our proposal is not to create a new electronic register, avoid the double entry of data, is the integration of what people do in the routine practice. And also implement in each memory clinic REDCap for neuropsychologic data that are not captured in the electronic register of each hospital. What we expect? We expect a scientific impact. We know that to have evidence, we need to have information and evidence for different place. We hope to try to help in more representative research and evidence, to try to increment capacity building by training and by research embedded in care. We hope to contribute to public policy with evidence-based information, and our future direction is to be able to implement biomarker in our memory clinic, and we hope to be adapted by the Ministry of Health. Finally, a clinician, people work in the clinical, they have a lot of work, and they can ask why to do research in the clinical, and there are so many papers. There are so many people doing good research everywhere. Why I have to invest time in doing research? I think it's only because the different countries, there are different realities, and the main reason to do research is, and you are a clinician or you are a politician, if maybe to try to avoid the Choluteca, that is, I think, is in Honduras. It was a very good idea, but now the bridge is there. The question is how to start, I don't know. Maybe some people can start by research and go to practice, but if you start by public policy, you can include research after that. And then all the whole lead to Roma, or to Bern or to Milan. So just to finish, Liné is an Argentinian genius. Learn to fly is not easy. Learn to fall is not easy, but living in the floor is a little boring. Thanks for your attention.
Right, so thank you to both, all three speakers. So, an update on our program. In the interest of time, we are now going to roll straight into the final session. So I'm afraid if you need a wee, you need to hold it in for the last session. And so everyone who is in the final session now needs to come up and we will roll.
Thank you, Lenny. You can have a seat. So basically, we are going to have coffee after the round table. So we are going to do the round table now. I think we need more chairs. Okay. Have a seat. Victor, please. Julian. Perfect. Okay, have a seat. ¿Podemos poner las diapositivas? Sí, sí, sí.
1, 2, 3.
Okay, don't be shy. Have a seat. Okay. Subarna. Ingrid, have a seat there.
No muy cerca de las escaleras, por favor. Bien, ahí está. 3, 4. Ahí estamos. Bien.
Gracias, chicas.
Sí, estamos bien.
Gracias. Subarna. Chris.
Just in case.
Okay, I think we are ready now. And thank you. It's Saturday afternoon. We are all tired, so that is why we decided to cancel the coffee now, and actually to postpone the coffee and to have the round table now. We have the world leader here, plus the new person in the room is Julian Bustin, who is the head of neuropsychiatry here at INECO. He's the head of the memory clinic. He just came from Mar del Plata for this round table. So maybe we can start by reading the question that we put on the screen, and any expert can take one and address that one. We have to be informal. The idea is to be informal, and to basically, Claudio and I are wondering what should we do to follow this momentum. We have a platform, we have many leaders, but we don't want to work in parallel. So maybe, Julian, you can start. In your opinion, how, as an alliance, can move forward to create the following step for brain health?
Thanks.
Oh my God.
There we go. Thanks for giving me the honor of starting. I think that I think that one of the most important things is that we agree on what is the target for each year, as it was mentioned in a previous talk, and gaining the advantage that the cardiologists have on this topic, which they mention that it's very important to focus on one topic each year in order to prevail in the notion of advancing the idea of brain health. So I think we have to agree in which point we want to work in order to succeed in brain health and continue with that program and to bring the results to practice.
Thank you. That's an excellent proposal. In fact, when we thought about this meeting, we decided to have two topics, and the topic of today was really how to create bridges between neurology and psychiatry. So maybe I can take your response and ask around, so what could we do to really promote this cross-disciplinarity between neurology and psychiatry? I mean, it is obvious that in many countries, and to some extent even in my country, the two specialties work in silos. So what could we do? I think brain health represents an opportunity, but what could we do? Do we have one or two ideas that you would like to? Yes. So just picking up from your response and then getting practical.
Well, so I like that point about the neurology and psychiatry, and you know, it reminds me, earlier this year I was at a meeting called the Behavioral Health Technology Conference in the US, and it's a conference all about new technologies around mental health care. You know, it's a lot of devices, and a lot of it's back office stuff, like how do you run a psych practice, but it's also how do you measure brain health. And one of the talks was actually about measurement-based care in psychiatry, which I didn't really know much about. Is that a topic? It's right behind me, I couldn't read it so well. And that, you know, I think in neurology to some extent, especially around stroke, which falls in between cardiovascular disease and neurology, but certainly in cardiology, there's a big emphasis on measurement-based care, you know, and that's where all these registries come in, the quality control, the quality measurement registries and so forth. And I got the sense, I was surprised, because actually the speaker, who is the head of mental health for the state of Massachusetts, said about psychiatry, we need to do what the cardiologists are doing. And I was like, hello, you know, I work at the Heart Association. And so I think that is one area maybe where there's an opportunity to bridge neurology, psychiatry, but also neurology, psychiatry, you know, cardiology, cardiovascular medicine, because those fields have, you know, just because the treatments were there sooner, you know, we're 10, 20 years behind cardiology in terms of our treatments. We're catching up quickly, but they've developed those systems. It's the systems of care that exist for cardiac and internal medicine that are newer to neurology and much newer to psychiatry. But that's a way, I think, in which the different fields can come together, is over how to do these registries and evidence-based care and, again, measurement-based care.
Excellent. So somebody's taking notes.
Yes, we are recording.
I would like to mention that the goal of this discussion is to start then, if I may, a Buenos Aires declaration that will follow the Bernese declaration. Each year we would like to come up with some reflections on what has been discussed. So we'll take notes and then we'll circulate the manuscript and we'll invite everybody to join. So that's just a remark. So you touched on technology. Who wants to address the question 3? In brain health, which digital or AI solution should we scale now? Please do.
I've been actually reflecting over the last 2 days on something that is going to have to merge number 3 and number 4.
I was thinking the same, actually, by the way.
Yeah, because you, in order to use AI to its fullest potential, you have to have the data behind it. In order to have the data behind it, you have to have the measurement defined. So throughout the last 2 days, we've been talking about, in various ways, measurement. Savarna talked about culturally appropriate measurement. Caroline talked about some of the measurement related to sleep. And while I'm obsessed with sleep, it also made me think about how can we harmonize the types of data we may need so that you might not be in alliance collecting the data or creating the registry, but you're creating the knowledge about the data points for each of us as collaborative organizations that have to be built to feed the AI model that will give us the technology or the knowledge or the innovation points into the future. But without that common data set or even defined points to create the data set, then we're not going to be able to utilize AI to its fullest potential.
Other comments on this? Christina? And then...
I can take this. Yeah, thank you very much. As I think it's a very important point, but data generation is very important, and I think it's very important to include the Global South for that. Without them, we can generate evidence right now. So we need data also from the Global South, and to achieve this, yeah, we have to work on the development of equipment and yeah, on the possibility of the Global South to take part part in international collaborations and data generation. And if we would like to do that, then it's very important, maybe 2 points: equity and partnerships. And therefore, we have to work on that, how to do that, and how to do, for example, university development in the Global South, how we could bring forward universities to make high-level education, high-level research, and how we can get the data and include them to the whole. And maybe one more point, I had the feeling in the last 2 days there are so many really great projects running right now. But what we could do is just to go away from this fragmentation and to bring together everything. Maybe we could think about a global program for brain health, and then in this regard generate data. And we could have a leadership on that, and it would be very nice to bring the researchers together and not just doing research. You are really doing excellent research in every field, but we have to put this together.
I was going to say, in the context of AI, I think we also have to think about AI in the context of people who use AI, not just researchers or clinicians who might use AI for an end product, but the public using AI to learn more about brain health or how to take care of their brain health. Website traffic for Google searches, as an example, the number of times people just read the AI synopsis and now no longer visit a website. It's like website traffic has dropped like 40% with the AI summaries that show up now on summaries. And those summaries take good and bad information and spit them back out at the person. And so I think one of the things we have to think about in terms of AI and brain health messaging or communication to the public is that if we don't figure out how to work with technology companies to ascertain or better refine the kind of information being pulled in, we could run the risk of there being a lot of miscommunication and misinformation about what people need to be doing in order to address their brain health in an effective manner.
So I have a question for Lenny. Joan is leading an Alzheimer organization. You are leading dementia institution. We are talking about brain health. What is the right paradigm, the right narrative? Is brain health, Alzheimer, dementia? I have been following you, and you are thinking about this, and I want to know your opinion. So which is the umbrella for us to work under the same term?
So I think humans will always eventually think in terms of disease. Like, it's just so fundamental to us that in the end you will say, I have a disease, I want something to be done about this, or you will be worried about getting a disease, and therefore you will change your behavior. So it is impossible to build a public narrative or a health narrative that does not place the diseases that people are worried about in the forefront. And I think it was your slides that showed from a system point of view, if you were looking at Switzerland and wanted to do something about your long-term health costs, you would look at your slide and go, well, I need to do something about Alzheimer's, because that is what is going to cost me a lot of money. But that doesn't mean that people are incapable of holding the idea of brain health in their head at the same time. And I think it's interesting how we behave, that, like, I've never heard anyone kind of talk about their pancreatic health. There is something about the way we relate to certain organs in our body, but we have a perception of them. You can kind of feel your heart. Like, you can sort of feel your liver if you get a bit shit-faced. Like, we've kind of got that idea of relationships with bits of our body, and that is something you should exploit, because you do think about the health of your brain. Like, it makes sense to everyone. It resonates as an idea. So I don't think you choose between these two. Like, I think they are both possible because we are capable of keeping both in our heads. The only danger is that, as I kind of said in my introductory remarks, but people talk about these concepts like brain health because they want to avoid talking about disease. And you have to have disease at the heart of the way that we engage individuals.
So, Victor, you have been working in the Global Brain Health Institute for 10 years, doing a great job across the globe. What do you think about this concept of brain health, or working on disease, on dementia? What is your opinion? And then my second question for you is, what a meeting like this is something new for you, or we are doing more of the same that you were doing in the last 10 years? Is anything new that you learn from, people from different groups of institutions trying to work on brain health?
Well, I just learned about this disease-centric modeling, which I hadn't thought of, because we were actually trying to be very preventive and positive with the narrative, and yet I can definitely see how with certain stakeholders it's important to use this terminology probably in the healthcare sector. So I'm learning a lot. The comment that I would add to the group probably addresses equity. Even as I was hearing the discussions around psychiatrists and neurologists, as I see across the 65 countries that have come to our program, almost within certain countries, certain groups lead in this space. And it depends on what country you're in. It could be psychiatrists, it could be primary care, it could be nurses, it could be extended officers, it could be neurologists. And so with representation across this group from some of these places, maybe you'll begin to break down on the world level how the groups can work together a bit more. Because it's not owned by any group globally. It's owned by various groups in individual countries. So at a meta level, maybe we'll be able to break that down a bit.
One of the challenges is really to convince politicians to invest in the field. And I had a question for you about the picture. I don't know if you asked the president to use his picture or you use it without asking him, but maybe we discussed this. We discussed it at the coffee break, but it was a turning point. So I relate now to question 4. So which measurement, which indicator could we take to convince politicians to do something? Is the costs? Most people tell me you will never decrease really costs. So costs cannot be the only measurement of brain health improving. So if not cost, but maybe Indrid, you can comment, but what else could we look? Incidence of disease, quality of life, which is very difficult to measure in the different disease, across disease. So which measure of improvement we would like to talk about?
Well,
you have an idea?
No. I think in the last 4 years I learned a bit about politics. So I was a congressman, so I can tell you what I learned, being a neurologist, a neuroscientist, and suddenly a congressman. I think that politicians react to 3 things in my 4 years experience. Crisis, and we have a crisis. We have a dementia crisis, an Alzheimer's crisis. They react to cost, money. If we convince them that investing, they will save money, I think they will listen. And thirdly, they react to popularity, and we need to educate the society. We were talking yesterday in INECO from the beginning, because we needed to survive. We didn't have a system. We have to educate the society about the importance of the brain, of brain health, and now in Argentina the brain is very popular. So I think we need to educate the society about the importance of our topic, and also we have to talk to politicians about the crisis and also the cost that they are taking in not doing anything.
When I speak with our politicians, they say we will not save costs. Costs always go up. So I'm not sure that saying we will save costs will be sufficient. So we need to add something, additional ideas.
So I slightly agree with that, because whenever anyone came to me at DH to say we've got this great idea to save costs, the problem was that you never saw that money come back into government. it was always, the hospital system just used it for anything else. So savings were very rarely realized. But I particularly struck with Andrea's presentation, and that because there was a bit of it that was about campaigning. And I think it's Lyndon Johnson who explained his political strategy as you get them by the balls and their hearts and minds follow. And that is a core bit of what public persuasion is. And it's about you need to engage the public, you need them to care, and then the politicians will follow.
That's interesting, because I cited this morning Professor Zellner, who used to be who is the president of the Red Cross, and he used to be the chair of the public health office in Switzerland. He said, the only way you can really move politicians is to take them and put them in the crisis. So, and whatever you do, and they are in the media, they will start doing something. And as a neurologist, I'm not used to do this. I'm not in the urology, I'm more on the upper stage. But in a way, we are discussing now with media to see whether we should do something like you did with the picture. So please explain. So you took the picture, and then what happened with the president? He said, oh, nice picture.
We choose politicians because two reasons. Because they were important. There were 4 politicians: the president, the first minister, and 2 parliament. And we choose politicians from the different, not only from the government, but we choose a senator that was in the opposition. So we were care not to polarize. Second, we choose politicians because that as the people from the publicity that have this genial idea, I say, a politician will not go against you, because if he go against you because you are using his image for Alzheimer, it will not be very popular. So with that, we were protected against any persecution. If at one moment we think, we have to choose an actor. No, if we choose an actor, a very popular figure, you will be demanded and you can have problems. So we choose politicians for a good cause. You are protected. But we were prepared with something to go to jail, but it's not happened. What happened, I think only one politician say something that he doesn't like very much, but it was like a silence of the politician, but people, I think, start to talk much more about the topic, but that also there is a trick. We do the campaign, we don't know that, but we do the campaign at the right moment, but it was the end of a government, and it was there was the campaign for the new election, and the campaign was, I think, had an impact to include for the first time dementia plan in the program. And we were very lucky, because it was a president that put that in the program that win the election. So after that, she win the election, we go to the Ministry of Health, and they start to work for the dementia plan. So it was a good campaign, but also it was a lot of luck to act in the good moment, and the candidate that was sensitive to the time for the topic win the election.
Yeah, so Christopher and I were talking about this last night, right? So why is everyone in this field so polite and so accepting and so willing to put up with things? In the Alzheimer's space, we have a treatment for AD that, in fact, buys you a significant amount of time. And most European countries are not paying for that. Their regulators have said it's safe, it works, and payers have gone, too expensive. And what's happened? Like, where are the protests? Where's the objection? Where's the anger? Where are people coming out and saying this is completely ridiculous? By and large, the field has just turned around and gone, oh well, there you go, let's wait for the next treatment to come along, let's see what happens. And this is the core thing that I think has to change, whether you're talking about treatments, or you're talking about brain health, or you're talking about funding of research, or you're talking about delivering improvements in low and middle income countries and increasing equity, which is this field needs to say the status quo is not acceptable and we want to see change and actually campaign for it.
I agree that there needs to be a people-led desire in order to have politicians follow. And in my experience, going back to yesterday's example on smoking, not a lot of things have moved the needle on smoking past a certain percentage of quit rates or lack of adoption rates. But there was a campaign the Centers for Disease Control did a few years ago that was called Tips for Former Smokers. And it was a highly graphic campaign of people who were fully disfigured, lost their tongue, were lost parts of their faces, were on vests, and the graphicness really played up the real threat of smoking-related diseases, and it actually changed how smoking prevention was funded in the United States, and it changed how people were engaging with some of that content. And so, it's really just thinking about social cognitive theory on how you play up threat, and how, we all know the numbers of people who are going to have these conditions are going to explode in the next 20 years. There's a lot of clarity there on what the perceived threat is. This is one of the most severe diseases in terms of perceptions of severity in the public. There's no one that's, there are people that are like, I've seen people get cancer. You get treatment, you get over it, and you're fine. No one says that about dementia. The perceived severity is already high. So I think there's a lot to do to play on that perceived threat to really make it clear that this could be you.
Now, we are wondering what this international alliance could be used for. And now I'm thinking about the world, and I'm thinking about the small world in the world, India. So, Steve, one comment. What could we do? How could you use this platform within the World Federation, if I dare to ask?
So how can we use this platform to move forward? I'm still thinking back about the neurology and psychiatry dichotomy. I don't think there's any one place where neurologists and psychiatrists come together. I can't think of it. We have the WPA website, which I've looked at occasionally, the WFN website, which frankly needs improvement. We have websites and so on devoted to initiatives such as this. But we don't have any one place where neurologists and psychiatrists come together virtually. So I think that would be somewhat helpful. We talk about patient awareness, and that's we do that, and the 8 things or the 7 things. I think we're doing patient awareness, but we're not probably doing enough physician awareness. And I think among my colleagues, I live in the brain health world, as do all of us here in this room, but not all neurologists do, and probably not all psychiatrists do. So I think that would be a low-hanging fruit thing that we probably have not done enough. Thank you.
Great, Steve. So what's about India? So Suvarna, what can we do together?
I think more representation from LMICs, I think, first of all. I think when we're sitting together like this, we really need to have people with, I can think of 10 people in India who are probably better than I am because they are practitioners and they have so much experience. So I think just bringing people on board, like you brought me on board, having people like that from other LMICs is so important. And then the solutions will come from them. I don't think we can really speak for them. So that's one thing. The second is, we can speak for them when we have worked with them. And I know that there has been tremendous amount of learning from this interaction in this meeting, I can see. The second is, what I'll take back is, I work in the National Institute of Mental Health and Neurosciences. So we have 35 years of working very closely with the psychiatrists. So it's such a low-hanging fruit for us. So I think building a bridge between neurology and psychiatry, the presentation from the World Psychiatric Association leader was an eye-opener. Everywhere, talk about mental health and brain health. Mental health and brain health, because that is when the politician will realize that they actually go together and they're not in opposition. Because the politician will say mental health in a brain health program, he will say brain health in a mental health program. We don't want to confuse them. So the second thing would be, for me, going back and working very closely with the psychiatrists and with the non-communicable disease people. There is very little awareness about each other's disease. So educating each other from primary care to tertiary care, educating politicians. They don't know what is dementia most of the time in our countries. So LMICs will be about education, awareness, working with people with experience and bringing them to this table for it to be a successful alliance.
Thank you. Chris, any comments?
Well, so first thing to say, Lenny, I was trying to encourage you to be forward and sort of provocative. Just emphasizing that in many countries in Asia, it really isn't the done thing to go and sort of advocate too much or to be too forceful, because it would be actually probably counterproductive. So first thing to say that Singapore and maybe China and maybe some other countries in Asia, we actually think our politicians are quite competent. Now, this might come as a surprise, but they tend to perform reasonably well. So in general, it's much more top-down. And we have policy decisions. So much to my surprise, the Singaporean government has decided to focus on brain health. But it's not because they want to go and write a brain health program or anything like that. It's because for the last 20 years, they've been struggling with the idea of what to do with aging populations. So first steps, they're worried about cardiovascular health, metabolic health, etc. They think that more or less that's been sorted out. And now they're worried about difficult things like brain health and physical health. So it's a long-term decision. So when we've discussed it this morning, the levers that we can build on in Singapore would be, firstly, how to implement what we know. Secondly, to go and develop new research areas, to go and sort of look into better ways of doing things that we don't understand. And thirdly, to go and sort of bring in industry and innovations that are commercializable. So that is what's going to move Singapore. If I could comment on neurologists and psychiatrists briefly, there are many reasons why the two specialties have split, and it's mainly due to the kind of patients that you see and what you do with the patients. And I would try to characterize, if I could make a caricature and say that the trouble with stroke physicians nowadays is that the moment they remove the clot, that's it. They don't really care about the patient anymore. So neurologists should think more about cognition, about post-stroke complications like mood disorders, etc. And psychiatrists should care more about, sorry Ingrid, care more about mundane things like blood pressure, diabetes. I know psychiatrists talk about comorbidities, but they don't really examine people that way. When's the last time you took somebody's blood pressure, Ingrid? Never. Yeah. So I think that that's probably the way that we could move together, to move on a common group of patients and say that we have to go and manage them in the same way. And since I might not get the microphone again, I'll just comment about measurement. About technology. I think that in terms of digital or AI solutions, we need easily understandable, simple solutions. When somebody comes and tells me again that they are going to analyze all your wearable data and is going to spit out some fantastic prediction, I get a sense of deja vu. I would just like a reliable, digitized test to test for cognition. That would be wonderful. Then there are also many technologies which we can already scale up, which we don't utilize. So for example, I was amazed to hear from my ophthalmology colleagues that every high street, every shopping center has a retinal camera and they have OCT because every optician has these little toys now. You can take retinal photographs, it predicts a lot of things, and that can be run through AI because that's all been developed. Whether we can implement that is a different matter. Blood biomarkers. We have tremendous opportunities to go and look at multiple biomarkers in the blood. We don't need anything else if we could use those technologies. So I would say that's low-hanging fruit. Getting psychiatrists to take blood pressure measurements, getting neurologists to go and sort of test for cognition, using these tools that we already have available, and finding competent politicians.
So, yes.
Yeah, so maybe you don't want your psychiatrist to measure the blood pressure, but I would say that, I would say that one of the tasks, in my opinion, like how I think when I think of this Brain Alliance, is that we need to shape the discourse around the brain. And this is something that we can do together. Professor Lewis mentioned about charlatanism. So there is a need. And there's a segment, a large segment of the population that does not speak in disease, that thinks of way on how to measure things, how to optimize things, how to stay longer around their children and, or pets or whatever. So there are people who want to live a life which is fulfilling. And to those people, we cannot speak of like waving, oh, you're gonna die, so you have to do this because you're gonna die. So there are some people who are only sensible to optimization or to living a thriving life. And we've seen this, so there is like the high percentage of burnout is also because people are losing a sort of, let's say, I think that the psychiatrist of INECO, he said, we need Verstehen. So, and we need Verstehen in neurology as well. So a stroke person that has also a stroke deals with existential limits, like something has happened to him. And so psychiatry can help neurology become better, and vice versa. But I would say that we need this because this space is going to be taken. So it's been already taken, like the multi-billion supplement industry, and this will be taken from us. So we need to take that space. And we need to do that in an evidence-based way. The second is because we need public trust. So people need to know what is the level of evidence with different levels of interventions, right? So that's one. The second is that we are psychiatrists, of course, we are neurologists, and we think in terms of disease. But we have also a duty for populational health. So we need populational psychiatry and populational neurology. So what do we do for somebody who wants to get better? So this is something that and that's why we need to think, and this forum is the one who shapes and impulses and finds a way of what is the primary care? Is this going to be taken by generalists who are very good and very well-meaning, but they're also very overloaded and with little evidence on how the brain functions? Or are we going to think of general psychiatrists and general neurologists, and then we'll continue with... and last thing I want to say is that we need brain medicine, because if the internal medicine is able to compress rheumatology and cardiology and gastroenterology into 6 years of training, or 4 to 6 years, we are able to compress neurology and psychiatry into 4 years of training and get, primary neurology psychiatrists, and then everyone can, to fill this gap, right? So I think that the International Brain Alliance can help us also shape, the curriculum and have these more overarching themes.
Thank you. So I see that Konrad Redak had, and I would then like to open briefly to the audience. Do you have any comments before I ask the last question to the podium, and then we'll conclude? Konrad?
Thank you very much. Well, I'd like to first of all congratulate for fantastic Congress, and listening to the discussion and about the possible actions for this alliance. Perhaps it would be nice to have a kind of study, survey across different countries and asking several questions on attitudes regarding brain health and the situation in many countries. We represent so many countries here, so having such documents, I know this from our experience in Poland, that putting something written to politicians always works to get through and show in which parts of the world are some advantages and disadvantages. So that could be an idea. And at the end, referring to Christina, a comment, I am very grateful I was able to present a poster. It was off program here, but I met a group of fantastic students, young people. So perhaps it was the first poster in the history of Alliance meetings. So thank you very much.
But you will not believe, but telepathy works. I was about to ask Riyad to say something, and he just raised his hand. Please, Riyad. Well, I'm not sure it's brain health, it's telepathy.
I see the panel, and it's an exceptional panel. But from the beginning to now, there's something that will...
Can you introduce yourself?
Yeah, Riyad Guider, I'm first Vice President of the World Federation of Neurology, so Steve is my boss. And I wanted just to emphasize that I see neurology...
Professor Riyad Guider is from Tunisia.
Thank you. I'm from the world. It's brain health. And so what is important is that you see pediatricians, psychiatrists, neurologists, and you are working on brain health. One of the goals that the Alliance with the WFN and others should do is to set measurements. Because when I see you speaking about brain health as a psychiatrist, or I see a neurologist speaking about brain health, they speak about brain health, but it don't seem to me that they speak about the same thing. There's some discrepancy in what they think is important. The measurement of these things seems to me a very important task that we should put on the top of priorities, because where the politicians will take us, if they take us, okay, brain health for you is what? We will answer. And they ask the psychiatrist. I said something a little bit different. So they will say, accordez vos violons, make the sound of the music good, and we can talk with you. So I think that we are not a lot of time, we are on a hurry of time to speak the same language very rapidly. And the Brain Alliance is something that can be very useful for this in cooperation with WFN, with WPA and others. That's my thinking, is working together on speaking about the same things.
Thank you, Riyad. I think it's a very good point, and I can tell you that one of the topics that the Lancet Commission will address is actually how to measure brain health. So this is a really complex. Matilde, please, and we have then the student from Texas, whom I don't remember the name, but you will introduce yourself. Matilde.
Yes, thank you.
Please speak up.
Thank you very much, and I thank you that I think this is a good conclusion of 2 fantastic days. I think that the International Brain Health Alliance cannot take heavy burden itself, because so far there's no budget that is supporting it. It's just limited. But there is something that the Alliance has that nobody else has. It can be the really global platform to collect the experiences of others who have budget to do things. So I think that the first cannot be developing things as such, because it would be quite complex, but collecting what it is developed by all those that are working on brain health, so that the Alliance can do, and it is quite unique in this sense, the work that the Alliance can do, because so far there's no single aggregating movement. Even at WHO, you heard this morning, they're just collecting some information, scars here and there. So I think that the role should be very clear. This is the first International Brain Health Alliance that is collecting the information what the others do, but we don't do so far. And the not doing is not because we don't want to do as International Brain Alliance, but we take notes that there are some major initiatives done by, for example, the Lancet Commission or other big groups. And some of them, and this is, I see the role, could be like a knowledge transfer brought from one place to the other. Next meeting will be in another continent, and we might have other priorities. We cannot follow the priorities. I think that the Alliance is collecting what's going on, and there are some things that can be pushed, that can be useful, but I do not see any active role so far, not the brain health indicator, for example. And I think that here what is really missing is the big neuroscience institution, like the European Neuroscience Group. I mean, we are missing in this group those that are working on the common basic mechanism. I mean, we know frontotemporal dementia has the same genes as ALS. I mean, we are discovering more and more, and we have seen multiple sclerosis and schizophrenia. We need some neuroscience in this group that can be also observing what's going on and collecting what's going on, but not necessarily doing it. For me, that's my suggestion, because I think it will require some time to start doing more, but so far, this platform is unique, and in the next 3 years, the uniqueness of this platform should be also highlighted worldwide in all the possible settings. That's my opinion.
Thank you, Matilde. Did you write the mail to Deborah?
I wrote another to you first. Because,
okay, you promised.
Hi, everyone. So, I am a 17-year-old student from Houston, Texas. And one thing that I haven't seen mentioned, I mean, a lot of this has to do with the older population, but as someone who is among the younger population, attention is a very important currency nowadays, and businesses seem to recognize this, as social media companies have become kind of more of entertainment companies recently, specifically in the development of algorithm-based short-form content that a lot of younger populations seem to engage in. And so I looked at an NIH article published in 2024, and the Oxford Word of the Year in 2024 was brain rot. Which is a well-known and popular term amongst the youth, and it kind of refers to the cognitive decline and mental exhaustion due to excessive exposure to low-quality online materials. And so what that article found was that this brain rot can lead to emotional desensitization, cognitive overload, and a negative self-concept in people who engage it. And I don't think there's much research on this, because the way this works is a lot of people spend 4 or more hours on their phones, on these scrolling platforms like TikTok and Instagram. And so they're going to scroll, they're going to watch a 30-second video, scroll past it, and do this for the next, 2 hours. But the thing is that they're not going to remember all the information that they just scrolled through. It's so much information on the brain, and the way that the platform works is that the algorithm is designed to see how you interact with each video and make recommendations and adjust the suggestions to keep you on the app as long as possible. And so I'm wondering, can we start research as to what happens in the brain and what the possible implications of this are going to be for my generations as we get older and our age and memory. And there's so many aspects to this, especially people don't have as much concentration. And the youth recognize this. Online, people say, oh, well, I'm doom scrolling. I stayed up late scrolling. Like, I know it's not good for me, but I don't know what to do to prevent myself from doing it, because it is based on dopamine, and it is designed with neuroscience and psychology in mind to keep people, especially the young, on the platforms.
Thank you. Thank you so much for your question. I think it's the last one, because we are all tired, and we want to thank the people who made this possible. But I will answer my thought about your question. I think that the meeting was, these 2 wonderful days were basically about brain health in terms of the disease. As a president of the American Academy of Neurology yesterday said, in America, 1 out of 2 persons will have a brain disease through their life. And we have data from around the world that or more than 1 in 3 people will have a brain disease. So I think we focus on this, but as you said, brain skills are important, and people who don't have a brain disease in the era of the artificial intelligence need to work on resilience, attention, memory, compassion, curiosity, creativity, decision-making. So your point is clear. I think we need another meeting to talk about brain skills, and also in countries like Argentina, where half of our kids live in poverty, we have another problem. We have the disease problem, headache, Alzheimer, stroke, psychiatric condition, etc. We have the brain skill problem because we are all stressed because the scrolling and all this, the things that you describe very well. But here in this country and in Latin America, in Africa, in many parts of the world, kids are not receiving proper nutrition or proper cognitive or emotional stimulation, and this is an incredible gap. So I think there are 3 levels of discussion: the disease discussion, in which I think we focus in the last 2 days; the brain skill focus, because even if you have a disease, you have to be strong in this brain skill in this era with this technological revolution, and also the impact of the poverty in the brains that many countries have to deal with. So with that, I think it's time to finish the meeting. And before I give the microphone to Claudio, I will say that this meeting was possible due to 4 people. One is Teresa Torralba, the president of INECO Foundation. Please. Karen Fernandez, Valentina from Switzerland, and Esther, please come here. So basically, they did most of the work. So Teresa, you can say goodbye to everybody, and thanks for the guests.
Thank you very much, all of you. It was wonderful having you here at Buenos Aires. We really enjoy such information you gave us and interaction between you and all the audience. Thank you very much, all of you, for being here. It was 2 exhausted and very exciting days. We are really happy and tired, all the 2 things. I want to say you that we have another session that's on demand that you can see. We won't put it now, for sure, but I want to say it because we have 5 wonderful presentations from the 5 continents, and it's in the link in our platform, so you can see that session on demand. Please, they are great. And thanks a lot. See you next time. And I want to say that a little comment about what you said today, and it's that I also think that all of us, we are working a lot on brain health since a lot of time ago. But we need to put all the things together, I think, and we really need from Argentina maybe some help in trying to have measurements that are all the same for all the planet. Maybe we can do some adaptations because it's not the same Africa, India, Argentina, or UK, but really we need that. And we're all working in different measurements, and then it's nice to have a platform where we can use something all the same. And the same is for the plants. No? We are working in a lot of things, all different things, and having something that we can use all together and try it in all the world, it should be great. So thanks for this opportunity. We from Argentina are very happy to have you all here and see you anytime.
So I hope you bring home some good feelings, some good perceptions, some memories, and hopefully the memories will not evaporate immediately. So I hope you will bring back some good memories of this meeting. And I would like to ask Matilde to come to actually take over the baton, because the next meeting will be in Rome, and maybe you say just 2 words why we should come to Rome. We heard all the roads bring to Rome, but just add some indications why we should come.
So thank you for inviting me to tell reasons to come to Italy and to Rome, but I think an encyclopedia would not be enough. So I just say we are happy when everybody comes to our country. Italy is...
Sorry, I interrupt you because
Yeah.
for the streaming we need you there.
Where do you need me? Sorry, where do I have to go? Where do I have to go? Here? Here? Okay. Va bene. Where is Facundo? I'm taking from Argentina and bring to Italy, like in the Olympics, you take the flame and you bring from one country, not running, but I'm bringing to Rome the flame that was behind this meeting. I hope that the same enthusiasm, I'm sure the same enthusiasm will be sort of crossing the ocean and coming to my country. That is a very friendly country with scientists that have been illuminating. Beside all the other things that you already know from Italy, we are putting together science with psychiatry and neurology together, ready to host international experts from all over, and ready to give to the International Brain Health Alliance another step in its growing, because the alliance is made to have dialogue. And I think that we have the unique opportunity to show the world that together we are able to speak. Doesn't count if you are a neurologist, psychiatrist, white or black, men or women, whatever is our background, we can speak. And in name of the good for the countries that we serve, I think we are all civil servants for people that are affected by brain disorders. And Italy will be hosting with its Renaissance style everybody, and I think that we will be very much pleased to have Claudio Bassetti and all the team in Rome, together with Professor Zappia, that is the president of the Neurological Association, Professor Fiorillo, the president of psychiatry, and you have been seeing them, Professor Padovani, that is the responsible for brain health for neurology, and all the other psychiatric association. We are ready to have you in Rome and to have hosting you there. Thank you very much.
So Teresa wanted to say a few words about our team, and also a lot of people that are following this meeting by streaming, which is good. The whole country knows that we are here, so which is also good. And I want to thank everybody for coming here from different parts of the world. And I have a request, only one request. Let's work together. Let's do things together. Thank you so much. And thank you, Cecilia, all the INECO team, all the students, the postdoc, all the faculty, all my colleagues, all the friends that are here. So will be in our memory for a long time. Thank you so much. Muchas gracias, and let's enjoy the coffee now. Bye. Oh, big. Come if you want to have a picture. There is space here.
Football players.
Soccer team.
Yeah. me, but it's somebody in my team that's doing that, so I will send it. Yes, yes.
Thank you.